nire-require siya. Kaya meron tayong mga, nasasaklaw tayo sa mga sabihin natin sa mga batas na kailangan meron siya. So, under OSH, sa safety and health, occupational safety and health. So, nire-require siya. Pero ang naging nangyari, it's like one size but it does not fit all. So, parang hindi ko makita anong relevance na turuan ng first aid tayong mga doctor. Pero sige lang, kasi we have to comply. So, first and foremost, next slide, ano yung ibig sabihin ng what are the principles ng first aid? So, kung makikita natin, no, the aim, the principles of first aid, tapos yung aims niya is to pagbigay tayo ng tulong, no, provide sa ating casualty who is suffering from an illness or an injury bago merong proper medical care. Ayan proper medical care. So, usually pag sinabing first aid, we talk about the emergency part of it. And merong nakasabi dito, may tatlo, but actually there are 4 aims of first aid. One is to preserve life. Proteksyonan mo, preserve mo yung buhay. No? Preserve yung life. You protect the casualty, particularly yung unconscious kasi wala siya kalaban-laban, unconscious yun. Tapos to prevent the situation or the condition in becoming worse, no? Sana wag nang tumindi. Kung may bleeding, ma-address natin yung bleeding para wag na siyang tumindi. And of course, to promote recovery. So yan lang yung guiding principle natin. So it's like we provide immediate care, although ang first aid is limited range lang. But this, meron na po tayo tinatawag na legal clout law. Yun yung sinabi ko, the duty of care. Okay, kung naalala nyo, as nurses, ethics natin yan. So, yung duty na yon, pag hindi natin yun ma-execute, medyo sa Pilipinas parang wala lang. Sa ibang bansa wala. Halimbawa, nasa Middle East ka, pag nakita mo may na-disgrasya, nagkakaproblema pag tinulungan mo. So, huwag mo lang tulungan. So, it's not really a one-size-fits-all cultural maneuver. Okay, next slide. And it is the issue, no, na kung saan temporary care siya. Kaya tinawag na first kasi kailangan there's a time-bound principle there. And the aid is to provide what is necessary and what is useful. So simply, it can be like a self-aid or tawag natin SABA, tinatawag namin yun sa military medicine SABA, self-aid body aid. Hindi lang pwedeng tulungan mo yung iba, tulungan mo sarili mo. Okay, next slide. So, yung sinabi ko kaninang 4, no? Dito kasi 3. But actually, it's 4, yung nabanggit ko kanina. Preserve life, prevent further injury, promote recovery, tapos sinama rin dito yung protect the unconscious casualty. 4 siya ngayon. Okay? So dagdagan nyo na lang yan. Next slide. Now, the goals, simply, doon pa rin doon pa rin tayo magbabaybay. But this is, what is the end, what is the end thing na mangyari? So, humaba ang buhay. Nawala ang sakit at humaba ang buhay. We have to allay the pain of the patient. Okay? Next slide. And by the way, I'll just do lectures on basic life support, first aid, and after which I'll do demo. Okay? Demo. Para isang demo na lang ako sa lahat. Now, ano dito sa Pilipinas, gusto ko lang maano sa inyo kasi, although this is not really our main problem kasi mayroon tayong PRC license. Kahit sa labas tayo ng ospital, nag-render tayo ng care, kung nagkabuhol-buhol yun, the PRC is a strong defense sa atin. Kasi tulad ng sinabi ko, ang ating bansa has no good Samaritan law. But if you look at the ethical and legal consideration, the aspect of litigation, no? What if the first aider will do something that is wrong at ikaw ay nakasuhan? So, may kanya-kanyang mga katulad sa Australia, may nakasuhan. Yan, depende yan. But sa atin kasi, dahil wala tayong good Samaritan law, nakakaawa dahil you're on your own. Pag habulin ka, wala ka talagang defense kasi wala tayong good Samaritan. But for the essence that we have to know its philosophy, yung tinatawag ko kaninang duty of care, yun yung hinawakan nating legal responsibility. Lalo na kapag ni-require ng workplace, na. So, kung kasama ka doon sa first aid training, so pwede ka na mag-render ng first aid to your colleague or other person or bystander. Huh? Okay, so the issue is hindi ka makasuhan kapag hindi ka mag-render ng care. Kasi kung sa tingin mo, parang hindi ako sure kasi complicated masyado, wala akong gamit. Wala kang legal doon. Hindi katulad sa atin na meron ng parang expectation ng mundo. Okay? So the duty of care, yung tinatawag ng duty of care, mahihinto lang siya kung meron isa sa mga ganito, no? Katulad ng ang casualty, nag-recover siya at hindi na kailangan ng tulong. Pangalawa, merong dumating na may higher level of care. Yeah. Tapos pangatlo, katulad ng kung nasa Ukraine ka, nagpe-first aid ka, biglang nagkaputukan, tumakbo ka na. Ang casualty mo malaki, hindi mo mabitbit. So pwede yun, understandable. Tapos, kung ikaw mismo, kunwari nasa Ukraine ka, natamaan ka ng bala, hindi ka naman namatay ka. Ayun, you are incapable of doing so or continuing the care. So wala tayong magawa dyan. So yan yung mga natin. But katulad ng nurse, katulad ng doktor, katulad din ng first response, katulad ng emergency medical service. By the way guys, ang first aider ay hindi allowed gumamit ng symbol na Star of Life. Yung makikita mong kulay royal blue, no, na may Staff of Asclepius sa gitna, ginagamit ng mga EMTs, no? So hindi ka allowed kasi hindi ka part ng world ng EMS. Although pre-hospital ka pero hindi ka sa cloud doon. Unless you want to be trained higher than that, yung tinatawag na EMR or MFR, Medical First Response. So yun, you will be allowed to carry the Star of Life. Pero ang pinaka-baseline nito lahat is the consent. Okay? Kasi ang karapatan ng tao para sa pangkalusugan, no, ay saklaw doon yung kailangan hingin ang side mo when you are sane and you are conscious. Of course, pag ang isang tao nag-cardiac arrest, wala ka na makuha ng consent, so implied yun. So, yan. Now, ang first aid, its philosophy looks into the physiological response, no, sa mga body primary functions. Yung paghinga, yung daluyan ng hininga kung intact, circulation, and how we can control, no, like bleeding and other overt injuries that need to be addressed to right away. So, yan siya. Next slide. So, bakit kailangan siya? Kasi para makapag-render tayo ng assistance bago dumating yung formal assistance talaga. Pero kailangan tama yung magawa. Hindi yung nagbigay ka ng assistance na wala sa ayos. So, we have to perform what is right and righteous. And kailangan yung kaalaman na yun para ma-execute yung first aid, no? To the benefit of the patient. And it should be like using gamit na nandyan ka agad. Hindi yung you are dependent on one thing, no? Kaya nga first aid para may ma-render ka. So, kung pwede mag-improvise ka, kung gusto mong gawa ng tourniquet. So, anything na ma-execute ka agad, ika nga, it affords people with the ability to provide help na hindi pwedeng you appear so complicated. Next slide. So, golden rule, you have to execute it quickly, no? So, pinakaunang gawin mo, kailangan ang situation na control mo. Pag scene assessment mo, kailangan kalmado siya. And you can assist rescue breathing or stop the bleed or prevent complications like developing into shock. Huwag tayo masyadong exaggerated na magtrabaho na first aid is always simplicity, no? Then we have this ability to calm down the situation, including the patient. And dahil COVID ngayon, pag sinabing calm down situation, huwag yung mga, alam mo naman sa Pilipinas, maraming isyusero, baka mag-super spread pa. So how to discourage, crowding of people around the accident site, and some ethical considerations, particularly when you have to touch the face or remove some clothes, no? Okay, and how you will render the situation safe by simply pwedeng removing the patient out of harm's way, no? Kung nasa gitna ng kalsada yun. Next slide. So in everything that you do, lahat naman tayo, what is your incident action plan? Yung IAP mo. Anong plano mo? No? Halimbawa, ano ba tong kaso na to? Medical ba to versus surgical? Yan. You have to have plan of action. Next slide. And from the plan of action, you can ascertain anong kailangan gamitin mong logistics. Next slide. So, pinakamaganda, meron kang first aid kit. Mahirap naman na maglaway-laway ka lang or maghurim-hurim ka, bulong-bulungan mo lang. Hindi pwede yun. So the first aid kit, you can assemble it yourself or you can buy pre-filled kits, no? Merong sa Ace Hardware, sa Watson, sa mga drugstore, no? So nasa iyo yun. So ang pinakamaganda, medyo medium grade siya kasi pwede mo mapaliit. Pero yung mapaliit, hindi mo na mapalaki. So kung nahihilo ka na, huwag naman magbitbit na masyadong marami na. Unless static siya. Pag sinabing static, nilalagay mo lang yung kit doon sa workplace mo, just fine. Better na merong ano ka. And then of course, yung first aid kit mo, next slide, should have a place, there's a right, appropriate place, lalo na pag it's a common access. Yung tinatawag nating public access, PIFA, PAFA, public access first aid kit, okay? It's like a defibrillator. Sa state of Georgia, I think sa US, meron silang PABC, Public Access Bleeding Control, no? Kasi siyempre uso sa US yung mga mass shooting. So other than AED, meron silang mga public access na parang first aid kit rin, but intended for bleeding control for gunshot injuries or bomb injuries. So sa atin, ang public access natin, meron pa konting defibrillator na sa airport and other vital facilities or utilities. Pero super wala. Hindi katulad sa Japan na pag-akyat mo sa Mount Fuji, yung mga tea houses, bawat tea house meron talagang defibrillator at first aid kit. Okay, next slide. Yan ang mga contents. No? So I will not discuss them one by one. Next slide. Okay, so what's gonna be the macroscopic scope or sequence of action? First and foremost, when you see someone particularly unconscious, you have to ask for help. Mandatory yan kahit sa basic life support. Isang laging nakakalimutan na aspect. And then you have to intervene, no? Kung ano man ang meron tinatawag ng general intervention and focus intervention. Yung general intervention, liwa, nasa gitna ng kalsada. Di pwede ka magpa-traffic control kasi kung nasagasaan yan, tapos wala kang control, baka may nagsirit-sirit mo naman na sasakyan, kurbada pa, ikaw na naman yung madisgrace. So meron tayong general intervention and then focus intervention. And then while you do that, when you try to move the person, kailangan bantayan mo na walang meron kang spinal restriction maneuver. Eh baka naman okay siya tapos nang minove mo nagkaroon tayo ng cervical complication, cervical spine complication. So hindi siya maganda. Kaya yung dictum ng medical practice, pa-doktor, ma-nurse, first aider, lahat, primum non nocere. First, do no harm. So wag na natin dagdagan yung kapahamakan na nangyari. Next slide. Okay, so in everything, check for hazard. No? Kasi isang casualty, pag wala kang check ng hazard, naging dalawa na, kasama ka na doon. Okay? And you have to do some triage. No? It's not really the triage that you have to do like in mass casualty incident management. Pero you have to, ilan ba na-injure? Para you can ask help na, uy, bus pala na nahulog. Eh, ang first aid is designed as 1:1. Eh, hindi mo kaya yung 1:20. So, triaging is another art and science. Okay, so hindi siya natutunan sa first aid yung how you triage, sino ang unahin. Next slide. So ano ba ang pwedeng maging characteristic ng isang first aider? First aider, una, dahil sinabi natin primum non nocere, kailangan you are tender or gentle. Hindi yung bara-bara ka magtrabaho na hila dito, hila doon. And then, alam mo, pag may nasugatan noon, dati hinihipan pa yung sugat. So, hindi natin yung ginagawa ngayon. Or merong some sort of anxiety. Binibigyan natin ng brown bag. So, hindi na po ginagawa yung brown bag, ha? So, no na siya. So, being gentle is you don't inflict pain, but you do it in the aspect of science. Hindi nang hinihipan yung sugat. Kasi kahit anong pag hinihipan mo yung sugat, mayroong mga bacteria dyan sa ano mo. Ano rin. And of course, COVID ngayon. No? Next slide. Then, first aider, may resourceful, anong pwedeng gawin. Kung meron siyang duct tape, no, na may gaping wound, pwedeng gawin ng duct tape. I-demo ko yan mamaya. Next slide. The first aider must be observant. No? Mapagmasid ka, baka may mga bagay na bakit nagkaroon ng injury na ganito, no? Next slide. So, keen ka in observing. So, it's not something you learn in the classroom and tomorrow you will know it right away. So, I cannot assure na magiging observant kayo after this training. Hindi ganun, it takes time. But I know, if all of the audience here are nurses, particularly you are working in a hospital, you will learn that by and by. Okay? Next slide. Then tactful. Kasi although hindi man naman naka-emphasize doon sa legal basis sa first aider, pero lagi nating tandaan na ang pinakaunang gamot na binibigay natin sa isang tao is yung the way we address them, particularly what words do we use, no? Kailangan calming, we have the katangian na makakalma natin siya. Okay? You handle the victim na maayos, na hindi maligalig yung dating para the victim can help himself out. Next slide. And the patient must be empathic. Kailangan sakto lang, hindi yung umiyak yung pasyente, iyak ka rin, no? Hindi gano'n. Hindi rin yung wala kang pakialam. Okay, so empathy. Between sympathy and apathy is empathy. Next slide. At may galang. No? So, hindi natin kinikwento, pinupost sa social media yung mukha ng pasyente, mga ganun. So, unless you are like teaching and there's okay lang sa pasyente, but usually we pixelate the face. Kailangan mag-address sa pasyente, tao yan, may paggalang sa kapwa natin. Okay, kasi one of the main rules yan ng humanitarian action is respect towards humanity. Next slide. Now, here, how do we address first aid? First and foremost, we have to ascertain if it's like trauma versus medical case. So, hindi natin alam. Pag sinabi natin sakit ang tiyan, ay baka may bulate or baka may gastritis. Hindi. Wala ka pa doon eh. Until you reach the point, yung pala sakit ng tiyan kasi nahulog sa hagdan, bumangga yung tiyan, di trauma yon. So pag sinabing trauma, there is like an application of force that caused the pain or the injury. Pag medical, any physiological aberrancy, katulad sabi ko, may gastritis siya, yung tiyan, no? Or merong nakakain ng hindi maganda, nagtatae, nagka-crampy, abdominal pain, or nagbubuhat, may nagbubuhat na sabi natin na, yeah, maybe in some point na grabe trabaho niya, so, karoon na siya some sort of muscular pain, versus there's linear applied force. So, pag trauma, although hindi ini-emphasize sa first aid, pero may mga books na binabanggit na rin nila yung mechanism of injury. So, ano yung MOI? Halimbawa, nabunggo ng sasakyan. So, nakita mo yung brake marks sa kotse, sa kalsada, kita mo, oops, ganito kahaba. So, medyo meron kang storyline na medyo mabilis yung kotse na bumangga doon sa tao. Tapos nakita mo yung kotse na yupi. So, alam mo na, yan yung mechanism of injury. Medyo mabilis ang kotse. Ang nature of illness naman, halimbawa, nakita mo, nahirapan huminga. Yun pala, umakyat sa 10 palapag, 10 stories, inakyat ka. So, yun yung parang nature of illness. What caused the difficulty of breathing? So, ito yung dalawa. Pagdating sa medical naman, particularly when you talk about pain, perhaps, pinaka-common yung mga acute abdomen. No? Tingnan din natin dito sa medical side kung ito purely medical or surgical. So, kunwari, meron siyang right lower quadrant. So, mag-isip ka, oops, i-check natin, no? Kung may mga point tenderness, okay? Para baka kasi appendicitis to, acute appendicitis. So, nagiging surgical abdomen siya. So, again, trauma, MOI. And then medical is the nature of illness. Sa medical naman, purely medical or surgical. Next slide. So, ano ang domains ng first aid? So, maraming mga mnemonics na ginagamit, but pinaka-common yung DRABSI. DRABSI is danger, yung response ng pasyente, and then the ABC. Other is HHH, which is also ginagamit sa basic life support. First H is hazard. Ano bang hazard? Bakit nag-injury yan? The next thing is hello. Okay? So, pakilala ka as first aider kasi nga merong duty of care. No? And then, you call for help. The third H. Yan. And ang saklaw niya ay siyempre basic wound management. Next is yung position of comfort. No? Malaking bagay yung position of comfort. And, or ano yung mga rescue position. And then, if we need to start compression, rescue breathing, addressing to choking, sa first aid, basically, magiging under siya sa basic life support. So, ang first aid is malawak. Ang basic life support is another battery of skills. No? Pero parang yung iba, hiniwalay si first aid as mainly as trauma. Pero pag nagbasa ka ng libro, lalo ng home first aid, workplace first aid, lahat sila. So, both schools of thought, tama naman siya. No? Yung ano lang, for some commercial reason, no? Hiniwalay siya para siyempre, take ka ng first aid, gano'n yan. No? Nakukuha natin yung ganong style sa US. Ginawa nila yung first aid, mainly for trauma cases. Next slide. So, sa DRABSI na gagamitin natin, ito yung mga old school. No? Siyempre, check for danger or how you look at the scene. Tulad sa picture na to, baka naglason to or baka may kuryente, di makuryente ka rin. Yan yung mga how you do the scene assessment. So, kahit sa BLS, sa isa sa checklist doon, is the scene safe? The scene is safe, binimension natin by principle kasi nasa checklist. Next slide. Then we establish response. Okay? Ibig sabihin, we have to know yung ABPU, ABPU is the patient alert. V is the patient responsive to verbal command. P is the patient responsive to painful stimuli. And of course, the patient is unconscious. So, then for whatever it is, you need to ask for assistance. Next slide. Now, I have here when you call for help. Now, if you have notes, sulat ninyo. Get notes and isulat ninyo. Kasi para alam niyo paano kayo tumawag ng help. Okay? So, ito, tama to. Pero lagyan natin ng mnemonics. Ang mnemonics niya, methane. M-E-T-H-A-N-E. Okay? M-E-T-H-A-N-E. Letter M, me. Ako. Or ikaw, no? Who am I? So pag tumawag ka, sir, ako po si Juan de la Cruz. Not necessarily yun ang mauuna. Pero at least alam mo mga guide yun. So M is me. Ako. And kung siyempre ngayon kasi pag tumatawag ka, meron ng call ID. But you can indicate your number. Sir, ako po si Juan de la Cruz. Ito po number ko, 09999999. Yan. Pwede yun ganun. And then E, what is the emergency? Okay? So ano yung emergency? Sir, may nasusunog po rito. Sir, may nahulog po sa pangalawang palapag. Ayan. T, nangyari po siya, sir, 5 minutes ago. Huwag ka magsabi, sir, nangyari siya mga around 8:30. Eh, baka hindi pareho tayo ng relo. So always, when you indicate time, paatras. No? So, sir, 10 minutes ago po. Yan. So H, hazard. Kung meron, no? Sir, naglilik po yung sa gasolina kasi dito. Tumagas yung gasolina. So pwedeng hazard yun. It can cause fire. And A, yung location po, sir, that's the address and the access. No? Saan nangyari? So that's location. And then N, ilan ang casualties, number of casualties. Okay? And E is emergency services present, pwede mong sabihin, or the services. Doon sa dito sa number of casualties, sa condition of casualties, usually binibigay natin yan doon sa hazard. No? So, sir, medyo mausok kasi. Kaya yung mga casualties siya siguro nakakalanghap usok. So, you can say the condition, no? Depende sa sitwasyon. Okay, next slide. Then we go into airway. So, pinaka-common yung head tilt chin lift, or pinakamaganda, head tilt neck lift. Hindi ako sang-ayon sa chin lift. Tapos kung ano naman siya, jaw thrust kapag you suspect there is cervical spine involvement. Next slide. So sa airway, so we manipulate a little bit, no, to make our airway pattern or to open the airway. Okay, so if they're unresponsive, you need to move on to apply like a bag valve mask. So hindi na po tayo ngayon nag-mouth to mouth unless kamag-anak mo yan or anak mo, sige. No, kung required na kailangan mag-rescue breathing. Next slide po. So, mamaya, i-ano ko sa demo, papakita ko why head tilt chin lift is not the best way. Okay. Next slide. Then we go into the breathing. So pansinin natin paano siya huminga. Makikita lang naman in general sense, no? So habang tine-check mo within 10 seconds, general sense, kapag nakita mo yung breathing sobrang bilis, pwedeng more than 30 per minute sa adult or more than 45 per minute sa bata, or less than 10 sa adult or less than 15 sa bata, masasabi mo the person is distressed, the adult or the child. No? So 10:30 for adult, 15:45 sa bata. So when is adult? 8 years old up. When is bata? 8 years old down. So yan ang ating demarcation. Next slide. Then we go into circulation by looking at the face. Is the face pale? Yung lips? Yung peri-circumoral? Or hindi naman kasi tinuturo sa first aid yung tinatawag na capillary refill. And of course, sa pulse, when we check for pulse. Okay? Next slide. Now, doon sa trauma, may sinasabing MOI, mechanism of injury. So minsan, meron na parang storyline. When you look at it, so depende paano siya kung kunwari may ejection from a vehicle, lalo na pag ejection distance is more than 10 feet. So take it like it's not good. Or nakita mo, render first aid sa isang sasakyan na hulog konti sa bangin. Tapos pag silip mo ngayon, kunwari may nakita ka isang tao doon, no, worst case scenario, total mga decapitated, natanggal ulo. 4 sila. Yung tatlo nagsisigawan, yung isa decapitated. Kahit nagsisigawan yung tatlo, consider it serious. Kasi may kasamahan sila na natanggal yung ulo. So, yan yung parang mechanism of injury niya. Yan, yung death in same passenger compartment mo. So, yeah. Kung nahulog ka more than 15 feet or 3 times the patient's height, consider it significant. Or sa rollover vehicle, or nagbanggaan, or high-speed vehicle, or binangga ng isang malaking sasakyan, yung pedestrian, tapos na-eject pa siya, no? Any form of trauma na you were rendered unconscious, consider it serious. Okay, and then penetrating injury, particularly sa chest part. Okay, next slide. So ito yung sa first aid lab. Very limited. Kaya initial airway management, open the airway to create a pattern. No? Airway, create mo, mabuksan mo airway. Okay, yeah. So, in the absence of cervical spine, pag tingala natin, maganda kasi pag natingala mo yung pasyente, head tilt, ako gusto ko head tilt na case. Nagsasara yung esophagus, yung SS mo. Kaya pag hyperextend ka ng neck, i-hyperextend mo talaga ng maayos. Okay? Kasi pag hindi, bukas pa rin yung esophagus. Then you perform CPR or you do tourniquet to address the bleeding per extremity. Kung nakatusok yung object, you stabilize impaled object. Mamaya matutunan natin yun. Next slide. So, of course, when you check for danger, the next is primary survey. So, ano yung primary survey? So, yan yung unang makikita mo, ano yung mga life-threatening. Then, check for AVPU, alert, verbal response, responsive to pain or unconscious. And then, what's gonna be your initial assessment? So, makikita natin, like airway mo, ano ang pattern of breathing, no? Circulation, ano ang disability, ano yung environment at saka exposure, and then kung mayroong lumalabas na fluid sa ilong, sa tenga, sa bibig. Next slide. General impression is, ano yung unang tingin mo sa patient's condition? Doon sa una mo siyang nakita, on the first wave of encounter sa kanya. So, depende sa environment niya at kung nagre-react siya, ano yung complaint, no? Chief complaint of the patient. At yung ano yung dating niya sa iyo, yung appearance. Duguan ba yung muka? Nangingitim ba yung labi? Next slide. Then, we also look at cervical spine involvement. We stabilize it so as not to do further harm. Okay? So, ituturo ko mamaya paano gagawin. Next slide. And then the breathing, 10, 30, less than 10, more than 30 sa adult. So that's not good. Less than 15 or more than 45 sa bata, that's not good also. Next slide. Sa circulation niya, makikita natin anong kulay. And also, makikita natin yung sensorium ng tao, yung level of consciousness. Is determinant kung maganda ba ang hemodynamics papunta sa brain. Of course, check for pulse. And then if there's bleeding, we will address to the bleeding, particularly bleeding per extremity. Dapat ngayon, hindi na namamatay ang tao pag meron bleeding per extremity. Okay, next slide. Transport is not part of the ng first aid. Part ng EMR, Emergency Medical Response or Medical First Response. Pero isinama siya sa mga books kasi minsan kung okay naman, first aider, tapos workplace first aider ka, isinama ka sa ambulansya. So naisama yung transport component. Yun. Ngayon, isinama na ang transport first aid. Next slide. Okay, so mainly, first aid is trauma, sa trauma tayo. Depende kung saan ang injury. Pero sana tingnan din natin lahat. Lalo na kapag may involvement ng fall, may involvement ng nasagasaan, pedestrian accident. So from head, neck, chest, abdomen, pelvis, extremities, at sa likod. So yan yung tinitingnan natin. Pero kung nag-address tayo sa injury, tapos binalikan mo sila after addressing to the injury, like for example, tinorniquet mo yung kaliwa. Pagkatapos tourniquet, successful na, wala nang tagas tubo. Tiningnan mo yung head, neck, chest, abdomen, yung iba na. So, usually sa medical first response yan nangyari. Pero ngayon sa first aid, kailangan mong silipin na rin. Okay? Next slide. Now, sa EMT, hindi itong tinuturo sa first aid. Itong DCAP, PTLS. Pero pag kumuha kayo ng EMT, dadaanan nyo to. Ngayon, bakit ko binention dyan? Kasi yung Singaporean first aid, dati first aid dots lang, no? Deformity, open injury, or open wound, tenderness, swelling, dots. Aba, maraming ginawa ang KBAT ng Singapore. So, next slide. Hindi na siya DCAP PTLS, hindi na siya dots. Mas naging mahirap ang first aid niya. So, bad spot claim aid. Well, dots is there. Pero, kung may need lang naman na isulat mo yung incident para pag-endorse sa hospital, may mabasa sa initial intervention, isinama na itong bad spot claim aid. So, tingnan natin ano si B, si A, si D, si S, si P, so on and so forth. So, may mga pangalan yan. Si B, A, D, S, P, O, T, C, L, A, I, M, A, B, E. Bad spot claim aid. Next slide. So, ano yung bad spot claim aid? B for burn. Tapos abrasion, gas-gas, deformity. Parang, ano ba ang Tagalog sa deformity? Swelling, pamamaga, puncture wound, sugat na hirap i-Tagalog. Open fracture. No, that's not open fracture. Open injury with bone protrusion. Okay? Open injury with bone protrusion, lumabas ang puto. Then tenderness, contusion, pasa, laceration, hiwa, avulsion, tuklap, impaled object, nakatusok. Tapos multiple trauma, kunwari nangyayari yan sa blast injury. Meron siyang avulsion, na meron siyang naging open wound with bone protrusion, naghalo lahat. So yun yung tinatawag na multi-trauma. And then amputation, and then kagat. Dati kasi ang kagat, ano lang siya. Tawag nito, puncture wound lang siya i-describe. Pero ngayon, dinidescribe talaga yung kagat kasi it's a special kind of injury. And last but not least, evisceration, lalo na sa bituka, lumabas yung bituka. Okay? So yan yung bad spot claim aid. Next slide. So let's start with a burn. So a burn natin is the most agonizing injury na tatama sa tao. Most traumatic siya kasi mayroon siyang psychological component. Yan. So, pwedeng mechanical burn, electrical burn, chemical burn, lalo na sa workplace yung chemical burn. So, anong gagawin natin? First and foremost, next slide, we have to know anong klaseng burn. Di ba hindi naman yan sa first aid? Yeah, pero by virtue of academics, alam nyo lang na nasunog siya. So kung hindi mo ma-ascertain kung second, third degree, fourth degree, basta nasunog siya beyond first degree. Ayan ha. So although we treat first degree burn, depende yan kung ano, limbawa, sensitive talaga yung skin, namula, tapos mahapdi, tapos humingi ng tulong sa'yo, pwede mong lagyan ng, sabihin mo, ma'am, meron kayong aloe vera, meron kami dito. Although, hindi allowed sa first aid magbigay ng gamot, but you can somehow suggest. No? Ang allowed sa first aid is to use like povidone iodine para sa sugat, no? Or an NSS, kung meron kayong NS, pag-bleed sa wound na malalim. So yung mga pang-emergency lang, pero yung namula yung pisngi mo dahil na first degree burn ka, case-to-case basis yun. Okay? So sa mag-aakto tayo, we will already intervene if it is second degree to third or fourth degree. So kanya-kanyang libro, merong libro na hindi nagme-mention ng fourth degree. Okay? Next slide. Dito sa sa burn, next slide ulit. Okay, next slide. Hindi tayo particular. Kasi halos pareho lang naman ang management sa hugasan and lagyan ng clean gauze. Kung wala kayong silver sulfadiazine, so sinisilver sulfadiazine, so pwede siya. Except sa face, may mga doktor ayaw mag-silver sulfadiazine sa face. Okay? So, mainly tubig. Ngayon itong nasa picture, we are allowed, inallow niya. 2 years po siyang nasa ospital, nasunog siya. Ngayon, more than 2 years siya sa PJ. Bumalik siya sa eskwelahan, delayed na siya mga around 3 years. So sa eskwelahan, meron siyang extra table sa gilid niya or extra upuan kasi merong electric fan. Dahil wala na siyang sweat glands eh. Hindi na So laging may electric fan na katutok sa kanya. So I gave him my book kasi sinaluduhan ko ang kanyang pagiging matibay. So he's my inspiration. So estudyante siya dyan sa Cavite, sa Lasal. Lasal ba yun? So there's a school there na famous school sa Cavite. Okay, next slide. So meron tayong tinatawag sa first aid na rule of thumb. Rule of thumb. So ano yung rule of thumb? Ganito yan. Kapag nasunog sa leeg, mukha, ulo, second degree to third degree, wala nang maraming istorya. Take it like it's a serious burn. So pag sinabing yun ang sunog, kailangan ang tao, dalhin mo siya sa ospital na mayroong burn facility. Okay? So una, pag nasunog sa leeg, mukha, ulo. Pangalawa, pag nasunog sa genitalia sa kasapwet. Kasama pala yun, yeah. Hindi naman siya life-threatening, pero dahil we are a social organism, so sinama yun. Thirdly, kapag nasunog sa wrist at sa kamay, at nasunog sa ankle papuntang paa, and or, consider it serious kasi may kinalaman yan para maghanap tayong trabaho. So lahat yan, dinadala sa burn center kasi para maganda ang pag-intervene. Pangalawa, sa burn kasi, pag meron kang burn unit, meron kang mga annex units like aesthetic surgery para hindi ka malomoral na nasunog yung mukha. Okay, so paano pag nasunog sa other than those, neck, face? So ang sukatan natin ay palm. May dalawang book sa palm. Isinama ang daliri. Yung iba naman, mas dito ako doon sa hindi kasama ang daliri. Itong palm lang dito. Ito. So kapag nasa dibdib ko, lampas na sa dibdib ko yung laki ng sunog na second degree up, dalhin niyo na sa burn unit. Not in any regular hospital, no? Or worst is clinic. So, kailangan talaga sa burn unit. Okay, ay dito sa braso, hindi naman siya masabi natin critical area. So, palm ulit, pag lumampas yung sunog sa laki ng palm, dalhin niyo na sa burn unit. Yan, ha? So yan yung ibig sabihin, the rule of thumbs. Okay, next slide. So, these are all understandable. No? Lalo na pag nasunog ka, huwag kang tumakbo. Hinto, hawak sa muka, drop sa ground, gulong. Pabalik-balik para mawala yung apoy doon sa damit mo. So that's what stop, drop, and roll means. Next slide. Okay. I will not discuss something about this, but I'll just, doon tayo, sige, tuloy-tuloy lang doon sa picture. Sa may picture niyo. Sige, sa picture. Yan. Okay. Meron talagang burn kit. Ako, I have a burn shell. So buong kit siya na merong mukha. Pag na-burn sa mukha, ilalagay mo siya after washing with water. Kung sa katawan, formang katawan siya, sa braso, may pang-wrap around. So, medyo may kamahalan. Ang masaklap doon, wala na akong ganon dahil dinonate ko, ginamit ko nung nag-crash yung aeroplano sa Sudo. Then, anong meron dito sa Pilipinas? Usually, ginagamit ko after tubig, silver-sulfadiazine, lalo na sa parts of the body except the face. Yung iba naman, doktor, ewan po, lakas ng loob ng si silver-sulfadiazine sa face. Pero pinakamaganda, dahil sa atin, first aider tayo, kung wala ka silver-sulfadiazine, after tubig, pwede mong lagyan ng raw honey. Raw honey, pulot. Or egg white kung kaya mong magka-egg white. Tapos paglagay sa egg white, balot ka agad. Pinakamagandang pambalot is cling wrap. Nakikita niyo sa picture na yun. Kasi wala pa naman tayo sa ospital. So cling wrap. No? Huwag natin siyang i-bandage, elastic bandage. No? Lalo na tapos huwag paputukin yung blister. Okay? Kung pumutok, wala lang akong magawa. Pero as much as possible, huwag natin paputukin kasi yan yung protective layer mo. Okay? Next slide. So you might encounter like austere first aid in the house. Agree naman ako. Except na hindi ako sure bakit ang potato. Okay? So, pinakamaganda, aloe vera, raw honey, yan ang maganda sa burn. But if these are like small burns or maliliit na kahit secondary. But honey is okay. Kasi paglagay mo ng honey, kahit pa 3rd degree yan, meron na kasi siyang malakas na antibacterial component. Tapos saka mo siya balutan. Tapos pagdating sa hospital, i-declare mo lang na raw honey po yan. Sa isang doktor na nagbabasa na nakakaintindi ng wilderness medicine, wala siyang disagreement doon. Next slide. Then gasgas. Pag nagasgas ka, isang gasgas tawag linear abrasion. Pag maraming kuko na gasgas, kunwari kuko na kagasgas, multiple linear abrasion. Kapag napaltos or yung parang nakras ka sa motor, sadsad ka, abrasion siya ang tawag doon, confluent abrasion. So again, pag mababaw, we clean the wound, water, pwedeng gumamit ng soap. By the way guys, pag merong burn injury, pwede kang gumamit ng soap, pero ang soap na gagamitin mo ay Perla or Dove. Bakit? Kasi meron sila ay alkaline soap. Pag nasunog ang tissue mo, nire-reverse nila yung acidity. No, kasi sila ay alkaline soap. So, itong sa next slide, itong sa linear abrasion, simple lang. Hugas lang, then lagay mo ng povidone iodine. After povidone iodine, maglagay ka ng like a topical antibiotic. So, yan. Okay? And then cover with clean gauze. You can already apply tape to cover that. Next slide. Deformity. Wala tayong gagawin as first aider. Bagkos, ang gawin mo lang, kung mamove mo yung limb na affected, idikit mo lang sa katawan, then you can make use of some splints or slings. Hindi na ginagamit ang T-bandage sa according to American Red Cross. Hindi na siya ginagamit. Sa atin, pwedeng gamitin as sling. Pero to hold the injury, elastic ka talaga. Kasi ang issue natin dito, how strong can your bandage secure the gauze? So, alam mo naman natin, yung mga pag nag-narrow cravat tayo, kahit sabihin natin hipitan yung pagkatali, hindi pa rin siya elastic. Hindi siya katulad ng isang elastic bandage na maganda yung pag-ipit talaga sa gauze, lalo na it involves like bleeding. Yan. So, dito sa deformity, gamit lang tayo ng body sling, body splint, tapos sling lang siya, and then naka-position of comfort. Then if you can ask, meron siyang gamot sa sakit ng pananakit ng gano'n, na baka may bit-bit ka dyan, hingin niya, kunin mo para i-facilitate mo sa pag-inom. Siya mismo ang inom, mag-facilitate ka lang. Kasi ang first aider, hindi pwedeng magpainom ng gamot. Okay, next slide. So wala tayong treatment other than position of comfort. Siyempre, stabilization. Next slide. We can perform other austere maneuvers katulad dito. Kung nasa malayo ang lugar, pwede mo lagyan ng mga splints para stabilize the injured extremity. Next slide. Okay, so merong control yung traditional natin. Pero personally, ako, naniniwala ako sa mga katutubo ng gamot. Pwedeng, kung merong ibigay na, lalo na sa sakit, dahil deform siya, so, naintindihan nila, for centuries na ago, yung mga ninuno nila, naturo na rin sa kanila. So it might. Next slide. So we split the affected part, the deformity. Katulad dito, austere first aid. Yeah. Next slide. Okay. So hindi tayo nagtatraction kasi first aider lang tayo. Sa atin is position of comfort lang siya. Next slide. Next slide ulit. Sige, tuloy-tuloy lang. Kasi ano lang naman to eh. Mamaya i-demo ko naman. Next slide, yung may picture tayo. So kung full body ang involvement, halimbawa nahulog ng tao, pwede niyong gawin niya. So nangyari to sa Zamboanga na kung saan, backpack ko na lang, wala namang stretcher. Yung backpack ko ginamit, ginawang stretcher. Yan. Tapos yung sapatos, ginawang headblock. No? So pwede siya. Although this kind of skills ay hindi pang first aider, but it's not, there's no batas or what na hindi ko pwedeng gamitin. Lalo na yung mga spinal restriction maneuvers. No? So it's just okay. Next slide. Pamamaga, well, prices, P-R-I-C-E-S. P, position of comfort. Laging position of comfort. R, rest, huwag pakilusin. I, dalawang school of thought. May naglalagay ng ice, merong hindi na. So, pero kung gusto mo naman operational ulit, kasi lalakad, hindi naman mawawala yung pamamaga. Pero pwedeng hindi na lumaki, kaya ka nag-apply ng ice. Kunwari, ang ng ice. No? Okay, next slide. Punctured wound, next slide. Yan, punctured wound, tusok. Usually nangyari yan. Kunwari na baril, huwag mo sabihin gunshot wound. Lagay mo lang allegedly kung kailangan mong gumawa ng report. Usually sa first aid, walang report yet. Pero kung kailangan, kukunin lang yung site. So, yan ang punctured. Sugat na, hindi ko alam paano Tagalog yan. Help me kung paano ba yung Tagalog. Okay. So, yan siya. Now, pag nagkatabi yan, tapos kinlaim ng pasyente na kagat ng ahas, so, you can describe it as a puncture wound due to bite, or simply sabihin mong bite injury. Okay na yon, diretso. So yan, puncture wound. Ngayon, two issues there. Siyempre, lahat naman ng sugat, magdudugo. Ngayon, anong klaseng pagdugo? Eh kung malalim yan, tumama sa artery. Makikita mo, wala. Hindi talaga. Tapos pag ipitin mo siya, ang dugo may ipon sa loob. Magkakaroon pa tayo ng compartment syndrome. So, anong gagawin natin sa puncture wound? So, determine natin kung talaga gano'ng kalalim. Lalo na pag ang dugo ay sigit tuloy, labas-labas, marami. So, tapos ang pasyente nagpe-fail na, merong tinamaang artery. Okay? So, kung hindi mo kayang lagyan ng tampon, wala akong tampon band-aid, tampon bleeding control. Mahirapan tayo maglagay ng gauze dyan. No? Kaya, pero the best way, kasi galing sa, pwedeng mag-suspect na gunshot, tourniquet mo na lang. Yan. So, depende yan. I will teach you how to do stopping the bleeding sa isang puncture wound. Okay, next slide. Yan, so linisan lahat. Kung hindi naman siya super bleeder, elastic bandage tayo na merong gauze and cover. Or ETD. ETD is emergency trauma dressing. Elastic bandage siya na may nakakabit na absorbent gauze. Yan. Next slide. Well, you can put water kung merong dirt, no? Or marami siya, pwede mong sabunan yung injury. Siyempre, hindi mo maano sa loob kasi malalim yung puncture wound. So, yung labas lang, manipulate mo or makiklean mo. Sorry, makiklean mo siya. Next slide. You have to assess kung anong nangyari, kung alam ng pasyente na ano siya, or lalo na nasaksak ng ice pick. Tapos sige dugo, sumalalim yung ice pick. Okay. Next slide. Yes, you have to dress the wound. Next slide. Tuloy-tuloy lang. Thank you. Diyan tayo nagkakaroon na. Okay, so mamaya i-demo ko ulit. Paano yung tinatawag na sucking chest wound? Kasi that is a magic. It's an emergency. Hindi mo gawang paraan niya, likelihood mamamatay ang pasyente because of collapse lang of the affected site. Pwedeng tinamaan ng bala, pwedeng nasaksak. Ayan, okay? Next slide. Then, open open wound with bone protrusion. So, yan yun. So, ang gawin natin, determine lang kung merong grabing bleeding. Sa bleeding lang naman yan eh. That's always the bleeding. Kinurek ko lang ha. Open wound with bone protrusion. So, yan. Okay, so anong gagawin natin dito sa kanya? Ika nga, no? So, address to the bleeding, lalo na extremity yan. Pinakamaganda, tourniquet, kasi lumabas yung buto, mag-deep wound packing ka. So, hindi mo pwedeng gawin yon. Kasi baka lalong mawala yung, hindi ma-stabilize yung bone, kumasgas doon sa artery mo. Kung hindi pa-bleeding mo ngayon kasi na-breach yung artery. So, pag irregular, unstable. Yan ang term niya, unstable. Pag unstable wound yan, kasi may bone protrusion, gawan mo ng paraan na mas splint na hindi magkahiwalay lalo. Splint mo yan. Huwag mo nang i-manipulate. Huwag kang mag-manipulate from the outside. Hayaan mo yung doktor, walang x-ray yung mata mo. Makatatama ka pa ng artery. Ah, okay? Sige. So, next is the bleeding na naman ang problem dito. Sige, tuloy. So, yan, no, mga sample, how you splint, a bone protrusion. Medyo malawak talaga yung splinting style niya. Mga style bundok yan. Next slide. Tenderness, prices ulit. Protect or position of comfort, rest, ice, compress, elevate. Usually sa panahon ngayon, no, hindi na ganong ginagamit yung elevation. Case-to-case basis. And then S is splint, no? Laging prices. Sa tenderness mo, not necessary magagawa lahat. Baka sa ice, okay na siya. Pero again, depende kung may ice. Pangalawa, two schools of thought again. Pero hindi naniniwala na ice, merong naniniwala maglagay ng ice. Okay? Kasi minsan, may tinatawag tayong parang humanitarian point. Ideally, there's an inflammatory process, kaya nagiging tender yan. Sinamahan pa ng swelling. Kung lagyan mo ng ice, yung inflammatory process to react ulit, nahihirapan siya. Lalo na kapag merong kailangan may open wound kasama, na kailangan may defense system, medyo mabagal. Kasi ice eh. Pero sa humanitarian principle, para ma-allay lang yung pain, so binibigay natin ice kasi nakakawala ng pain. Next slide. Yan. So, prices lang yan. Meron ding peace love. Next slide. Yeah. First aid book, peace love. Next slide. Then, sa pasa. So, depende sa ang pasa. Dito sa ibaba, sa mata, kung raccoon eyes yan, sabihin natin raccoon eyes because of a head injury, huwag mo nang patagalin. Or merong battle sign sa likod ng tenga. Huwag mo nang patagalin, magde-deteriorate yan neurologically. Pero pasa sa other parts of the body, price ulit. Prices. No, prices. Yung iba, rise. Yung iba, prices. So, ganun lang ang pag-treat natin sa kanila. No? Next slide. Okay. Sige, tuloy. Sige. Yan. Dito tayo sa laceration. Nahiwa. So, again, tubig, linis tubig. Huwag mong buhusan ng betadine yung malalim na sugat. Pagalitan ka sa ospital. Bakit ganon? Kasi ang povidone iodine, hindi lang pumapatay ng mga bacterial cells. No? Di siyempre, cell din yung nasa loob niyan. Sisirain din. So instead na mag-facilitate ka ng healing, wala. Kasi wala nang nag-form na ng namatay na yung cells, hindi na siya mag-form na kung saan babalik yung tissue, pag dikit-dikit yung tissue. Hindi ganun. Pinatay ng povidone iodine, kaya hindi pwede mag-povidone iodine. Pinakamaganda sa open wound is ini-irrigate lang yan ng NSS. Dahil first aider tayo, wala tayong NSS. Tubig ulit. Malinis na tubig. Okay, next slide. So mamaya, ituturo ko ulit para i-manage. I-demo ko na lang. Kung grabe yung dugo, bleeding control tayo. Kung kaya namang takpan na hiwa, sige, gamitan natin ng mga micromen, duct tape. So let's see what we can do mamaya. Next slide. Tuloy-tuloy lang. Doon sa picture. Makikita mo, may suture doon. Pero ang sinuture hindi skin. Ang sinuture ay duct tape. Yan. Tapos gumawa siya ng steri-strip. Oh. So, yan yung mga austere maneuvers sa first aid. Next slide. O yan yung micromem. So, pakitaan ko kayo paano ginagamit ang micro. Next slide. Abulsyon na tuklap. Again, hugas, clean water, takpan ng gauze, tape, loose lang, huwag maikpit. Kapag lumuwa yung mata, alam mo, lumuwa yung mata, avulsion yan eh. Avulsed eye. Hindi naman yung mata lumuwa. Gugulong doon sa semento, hindi gano'n. Kalaki-laki ng optic nerve, sak matibay. So do not attempt to isuksok yung mata. Cover the eyes. Isama yung cover pag isa para hindi nag-move yung pangalawa. So ganun lang, okay? Cover the eyes. Go directly to the hospital. Next slide. Avulsed eye. Yan, tuklap. Next slide. Next slide. Yan, impaled object. So, ang issue dyan, huwag bunutin. Yan yung ano dyan. Rule of thumb. Huwag bunutin. Okay? Bagkos, lagyan natin ng stabilizer sa likod, sa paligid. Pwedeng donut, pwedeng karton para i-house yung ano, and transport. Sa nakaposition kung saan hindi mag-move yung object na naiwan sa katawan. Kami nakatusok sa katawan. Next slide. So yan ang mga maneuver. So you can stabilize the wound. Ang tawag dyan ay tootsie rolling, tootsie roll, or donut, or lagyan ng bahay-bahay para hindi lalong matusok or ma-sway yung object. Next slide. So next is the multi-trauma to tissue. So halo-halo lahat. So ang unang concern mo rito is bleeding. Okay, then you can wash, and the best thing you can do is wash. Tapos pag katulad dito nasa upper left, pwede mo siyang i-cling wrap din. So depende. Pero usually ganyan, open lang siya. So dinidebride lang yan. Depende sa sitwasyon or how huge is the involvement. Next slide. Again, for closed soft tissue injury management, prices are or rises or rises are. Okay, so ito mga mnemonics lang. Okay, next slide. Amputation, control mo yung bleeding, and then kung may malinis na plastic, iyan siya. Baka daw masahid lang natin yung mga natanggal na daliri or kamay, baka lang masahid, so ilagay sa clean plastic. Pero dyan, control bleeding, magto-tourniquet ka talaga. Next slide. Okay, sige, tuloy-tuloy lang. So ito yung example of austere tourniquet, yung improvised. Okay. Next slide. Now here is the standard tourniquet. Doon ginagamit natin sa lalo na pag nag-training ka ng stop the bleed. So ito dito actually sinama ko yung stop the bleed pro. Next slide. So lalo na sa bleeding, laceration may what, no? You remember depth. D for direct pressure, E for elevate. Although hindi na natin ginagawa yung elevation. Old school na yan. Pero sige, for the sake na makompleto kayo mnemonics, sige, elevate. P, pack with Kerlik's gauze. Not ordinary gauze, but a Kerlik's gauze. Sige, pakitaan ko mamaya ano ang Kerlik's gauze. Then R, apply ka ng tourniquet. Yung tinatawag nating constrictive tourniquet talaga, hindi yung tourniquet na ginagamit natin para mag-intravenous tayo. Hindi. I'll show you again the tourniquet mamaya pag demo. Then, of course, hemostatic gauze. Special gauze yan siya, special, treated. No? Ibig sabihin, meron siyang, siyempre ayaw na sabihin ang ingredient, pero treated yan. I'll show you again anong forma ng isang hemostatic gauze. Okay, next slide. Okay, sa bites, sa B bites, what to do? Linis pa rin, so kung pwedeng masabunan. Sa mukha, linis lang. No? Then bring directly to the hospital para ma-appropriate ano ang pwedeng parang ako, katulad ng maliit pa ako, nakagat ako ng aso sa mukha. So kung punta ko sa hospital, in-actionan yung tiyan ko. So depende sa aso din yun. No? You can start with isang parang rabogam or a rabies passive immunization mechanics. Preform na yung mga fighting cells mo against bite, no? Against rabies. Saka meron ding binibigay na to enhance yung tinatawag nating active immunization process para makadevelop ang katawan mo ng magandang fighting force. So, yan yung sa bite. Pero sa bite kasi kailangan obligatory, minomonitor natin, bitbitin sa bite center. Okay, sige, tuloy-tuloy na. Hanggang sa picture. So ito again, another example, lalo namang maliliit, bite mark. Okay, apply antibiotic, cover with clean dry. Kulang pa to. Kailangan malaman sa ospital. Pwede bang mag-warrant ba magbigay ng oral medication ang doktor? So depende. Kasi daga din yan eh. Alam mo naman, saan ang daga? Nagsusuksukan. Next slide. Snake bite naman, hindi na sinisip-sip yung sugat, kalukuhan. Walang silbi. So sa snake bite, kung saan ka nakagat, lalo na sa left ankle, ibabandage mo lahat yung right lower limb para kasi ang venom ay hindi dumadaan sa daluyan ng dugo. Dumadaan yan sa lymphatic vessel. Kaya tinatalian para hindi mag-contract yung muscle. Kasi yung lymphatic vessel, nagmo-move na siya pataas kapag mayroong muscle movement, no? So kung nakagat ka, yung venom doon siya dadaan sa lymphatic vessel. So nagmo-move lang yung lymphatic duct pag nagmo-move yung muscle. So kaya ini-splint natin lahat yung limb. Okay, next slide. By the way, pag yung limb pala, pag nakagat ka, doon na kung anong antivenin, polyvalent ba or monovalent. So here, ito yung evisceration. Ito yung paglabas ng mga abdominal contents. So ang sikreto nito, abdominal ETD, emergency trauma dressing, or ITD, Israeli trauma dressing. Pero wala tayong ganon, wala tayong malinis tela, i-wrap around natin hanggang madali natin sa surgical ward or sa operating room. Sorry, sa operating room. Okay, next slide. So ayan, no? Do not attempt to push the intestines back. Just encapsulate the patient with blanket, no? Kumot na, blanket. No? Natin, parang scoop mo lang siya, pwede mong ilagay sa blanket. Or, pinakamaganda, plastic. Tapos ikutan mo ng duct tape para hindi kumalat. Do not reinsert the intestine to the abdominal cavity. Next slide. Sige, tuloy-tuloy lang. Now, dito tayo sa stop the bleed. Kasi naging program kasi po sa US, tapos dinalan dito sa Philippine College of Surgeons ng Pilipinas. So, stop the bleed, okay? Dahil sa mass shooting, naging enhanced program. Particularly sa American College of Surgeons, okay, sa ACS. Next slide. So, Hartford Consensus, yan. Next slide. Next slide. So, uncontrolled bleeding is the #1 cause of preventable death from trauma, lalo na kapag nag-bleed ka dito sa kamay, sa forearm or dito sa leg, sa thigh. Yan. So pag tinamaan ka dyan, dapat hindi ka na namamatay. Tayin ko lang yung aircon na sobrang lamig. Okay, next slide. So meron din siyang ABC. First is to alert by calling 911 kasi shooting din sa healthcare. Then look for the bleeding person. Then you do compression. So bahala ka na. You can use tourniquet. So simply just address to the bleeding so that it will not bleed some more. Next slide. But if in case sa US may mga mass shooting, you have to ensure your safety. No, baka nangyari sa Florida, yung LGBT na event, yung nag-mass shooting doon. So may mga gustong tumulong, pagpasok nila, sila rin yung nabaril. In case talaga nagkagulo na, naglabo-labo na, umalis ka na. Wala tayong magawa. Kung hindi mo mabitbit ang pasyente, di iwanan mo. Okay? And kung pwede lang, umawak ka sa pasyente, naka-BSI ka, body substance isolation. Para hindi ka makawak sa dugo, lalo na kasi dahil ganyan, COVID. No? Next slide. So, yes, call 911 or mag-utos ka na may tatawag na 911. Next slide. Then, address to the bleeding. So, i-demo ko siya mamaya. Paano? Next slide. Kung wala kang trauma kit, sorry, apply ka lang talaga ng pressure doon sa wound. Pwede gumamit ka ng tela ng pasyente sa damit niya. Okay? Next slide. So, ayan, no? Dito kasi, ang ginamit na tela sa kanya. Nag-iisa lang yung damit mo. Alangan naman sa'yo. Di sa pasyente na lang. You can improvise your tourniquet pero hindi maganda ang gripping. Pero dito, kailangan gumamit ka na Combat Application Tourniquet, CAT. Sa CAT na civilian, puti. May puti siya na strap na kung saan doon mo ilalagay ang date, ang time na tourniquet. Okay? Next slide. Kung hindi naman hindi ma-tourniquet dahil kunwari nasa junction, so wound packing ka lang. Next slide. So ito yung algorithm for stop the bleed. So you have to check if you are safe. Then when you triage, no? So depende sa dami ng pasyente. Pag kunwari 3 lang naman, diretso mo i-address yung isa. Pero kung 50 ang pasyente yan, hindi mag-a-apply ang 1:1. So iti-triage mo. No? Sino yung mga tao na mataas ang chances of survival dahil unstable nga environment, sila muna. Tapos yung mga hindi nakaka-respond dahil grabe yung bleeding or what, pag hindi mo nakita, saka na sila. Sorry kung hindi naabutan. Pero kung kaya mo namang ma-evacuate ang mga tao, sige, move. Yung kailangan mag-move, move ka agad. Sige, tapos ikaw, diretso ka, focus ka doon sa isang life-threatening bleeding. Go. So ngayon, nag-address ka, safe ka na. Tapos nakitaan mo, merong isang pasyente, may bleeding. Tanong sa sarili, meron ka bang trauma kit? Pag no, dry clean cloth, tapos, or direct pressure to the wound. Ganun lang. Pag yes, nasa ng wound, extremities ba or nasa katawan? Like neck, shoulder, groin. Doon sa first aid kit mo, meron bang tourniquet? Pag yes, lalo na pag grabe yung bleeding or warak talaga, yes, you can apply. So, kung wala naman, then you just pack the wound, no? Na matindi talaga pagka-pack. I-demo ko ulit yan. Next slide. So that is the tourniquet for civilian color orange. Pag nakikita kayong tourniquet na light blue ng North American Rescue, pang training, pang sundalo, police, black yung kulay. But of course, maraming nagpo-provide ng tourniquet. Merong mga China pero ayaw ko iasa sarili ko sa ganun. Hirap na. Next slide. So yun yung mga parts ng tourniquet natin. Okay, next slide. So bandaging, splinting tayo. But before bandaging, splinting, I'm gonna give you 10 minutes break. 10 minutes break muna kayo. Okay? Joy, 10 minutes break muna sila. Let's start. Let's resume. Sorry, let's resume. Next slide. So let's go into bandaging. So what's the function? Siyempre, sa first aid, it protects the wound, no? When you dress the wound and para hindi siya lalo na if the environment is quite it's dirty, so na-protection na siya. And when you do apply bandage to it, somewhat pag properly maayos siya, then it allays the pain or removes discomfort. And with the usage of the bandage, it also absorbs exudates para yung kabuuan ng wound healing ay maayos. Then also to restrict the movement, no? I don't like the word immobilize. To restrict the movement of the body part because there's no such thing as immobilization really. Kahit anong gawin mo dyan, mamumove talaga yan kahit napaka-super minimal. So, hindi natin yan maiwasan na hindi ma-move. So, pinakamaganda is ma-restrict lang yung movement. Immobilization is 100% movement. That's very impossible. So, okay, yeah. Next slide. Now, the general principle of bandaging is hindi pwedeng must not be too loose or too tight. And case-to-case basis, no? Pwedeng you can make a bandage to restrict really the circulation, lalo na pag gawin mo yung bandage na at the same time tourniquet effect siya, yes, but if it is just to hold the bandage, it must not restrict distal circulation. No? Dapat absorptive siya and hindi lalong mamar yung tissue or distortion. Okay? And kung kailangan, madali siyang ma-check na, for example, kung nag-bandage ako dito sa tuhod, so yung aking distal ay pwede ma-subject to to some sort of examination, no? At pag nag-bandage ako, kung kailangan may pagbabago, madalis ko siyang palitan. Next slide. Splinting naman, siyempre, katulad sinabi ko kanina, when there is like swelling or tenderness or instability somehow, para hindi na mag-progress yung inflammation or trauma, split na. And totality, pag hindi na-rest siya or hindi siya ma-move, nakokontrol yung pain because wala nang added insult to the injury. So it prevents further injury, no? And it can facilitate protection. Okay? I mean, yeah, it can facilitate healing, no, when you apply this. Next slide. So, sa bandaging tayo, no? Ang ginagamit natin dati is the triangular bandage. So, yung triangular bandage, kung imagine niyo, meron tayong yung base, saka apex, yung parang sa pyramid sa dulo, no? So, review ko lang muna kayo, ha? Tapos, pag i-fold mo siya pababa yung apex to the base, so broad fold bandage, tapos ikot mo pa, i-fold mo pa yung narrow cravat, no? Or narrow fold bandage. Pero hindi na siya natin ginagamit ngayon. Kasi ang ginagamit natin to hold the dressing is elastic na. Dati kasi, ang uso pa yung T-bandage, ginagamit natin siya to hold a dressing in place, lalo na it talks about open wound. And it can also apply direct pressure, kahit sabihin natin na wala siyang elasticity. Pero sige, let's give credit also. Because we enjoyed the usage of T-bandage for years. Then when we do that, it reduces swelling. Although hindi niya kaya yung kaya ni elastic bandage. And provide support and stability for an extremity or joint. Again, mas maganda si elastic, pero DT bandage, na-enjoy niya yun din. Okay? And of course, kailangan clean din, katulad ng lahat ng gamit natin. Kung pwede sana clean, not necessarily sterile naman. So, sa mga klaseng bandages, we have roller bandages, self-adhering conforming bandages, gauze rollers, elastic roller bandages, triangular bandages. Yan. Next slide. So, tuloy ko lang sa bandage. Pag sinabing roller, para maintindihan niyo lang yung roller bandages. Yan yung usually 1 or 2, 3 inch yan. Pag 1 inch with mga pang fingers, pag 2 inches, yan sa wrist, sa hands, sa feet. Pag 3 inch, pwedeng sa ankles, sa elbows, no? Yung mga moving parts. Pag 4 inch naman, para sa knees and legs. So, meron siyang mga tinatawag nating gaano siya kalapad. So, yan yung roller. Yung self-adhering, yung parang corrugated siya, magaspang. No? Conforming bandage yun. Pag gauze roller, gauze siya, na pwede siyang gawin sa deep wound. No? And at the same time, pwede din siyang iikot. And we have the famous elastic bandage. Okay. Next slide. So, sige, tuloy lang yan. Balik ulit ako sa triangular bandage. No? Usually, ginagamit natin yan pag mayroong ears, sa bandaging sa head. Pero yun, hindi na siya kasing tulad ng elastic na nagagawa. The best thing lang talaga sa T-bandage, guys, ay ginagawa nating sling. So, yun siya. Sige, tuloy mo lang yung slide. Sige, tuloy. Sige. Hindi ko na ano yung mga test na yan. Sige, tuloy. Assess the scene. Sige lang. Anyway, for learning purposes, doon tayo sa, sige lang. Doon tayo sa merong making a diagnosis. So, first aider ka, do you make a diagnosis? Actually, hindi. Pero, merong, sabihin na natin, the family of it. No? Sige lang, tuloy mo lang. Doon tayo sa yung making a diagnosis. Yan yung mga, let's prevent shock from happening. No? Mga first aid maneuvers on what to do pag nahilo. Sige, i-demo ko lang lahat yan mamaya. Isa-isahin ko yan from head to toe. So, anong ginagawa ng first aider? Okay. So, these are the slides now for your own reading. Para siyang sa home emergency, saka sa workplace emergency, o mga what to do. Electrical shock, spill, burn, Sige lang. Eye injuries, anong gagawin? So doon lang kanina sa bad spot claim aid, anong gagawin natin? Yan yung sa mga bandaging, sa bandages. Okay. Exposure to spills or hazmat, hazchem. Okay. So pinakaayaw natin dyan is inhalation of fumes. So, broken bones, particularly pag ang bone ay lumabas. Environmental emergency like heat illnesses or heat exhaustion versus, sabay wala naman tayong lamig dito versus, tapos ano yung heat stroke, although hindi maganda yung picture ng heat stroke dyan, daanan natin yan. Sa seizure, anong gagawin natin sa seizure? Okay. So, mamaya i-head to foot pa yan. So, sa bandage, anong kailangan gawin natin? Yan, no? Mga types of bandage, yan yung sinabi ko kanina. Sige lang, roll. So, makita nyo, yan, roller bandage, self-adhering, gauze rollers. Yan ang elastic yung pinakawan gamitin natin. DT bandage. Sige. So, naging part na rin. But the T-bandage, pinakamaganda, sling na lang siya ngayon. Okay. Yung mga roller bandages, yan ang paggamit natin. Yan. No? Yung doing cravat and then splinting extremities. Sige. So, why do we splint? So, yan ang reason. So, we can have bellow splint, air splint, body splint, some splint. No? Gamitin some splints. So, maraming klaseng splints. Okay, sige. So, sa position, always place the patient in a position of comfort. Yan lang naman yung principle sa mga positions. Position of comfort. So, merong supine, prone. Pinakamaganda dito is alam natin yung shock position sa lateral recumbent, lalo na mamaya sa BLS ituturo ko. Okay, Fowlers, high Fowlers. Okay. So, yung position of comfort, usually kinukuha natin yan sa pasyente. No? Actually, maraming klaseng ano dyan. Maraming klaseng maneuvers, no? Okay, doon tayo saglit diyan. Balik muna. Okay, stop. Balik tayo sa PMART speed tayo. In case lang mapunta kayo sa abroad. Mapunta kayo sa abroad. Tapos madaanan niyo 'yan. Yung issue na 'yan, yung PMART speed na 'yan. Kasi malay mo ituturo siya. No? So, actually, it's the March. Kasi yung P, hindi naman kay law enforcer. So, yung provider safety, patient safety from gunfire. So, nawala siya. Pero sabihin na lang natin, sige, let's use the word patient provider safety for whatever it is. So, alamin natin if the scene is safe. Okay? And then, next slide. Then we can perform massive hemorrhage, lalo sa upper extremity. Okay? You can employ you can detect saan ang source of bleeding, yung tinatawag na 4Ds. Detection, next slide. Okay, next slide. So, detect natin kasi mahirap mag-detect lalo na sa kalagitnaan ng kaguluhan. Hindi mo malaman na tinamaan ka pala. Totoo yun. Totoo yung sa palabas. Unless high caliber, malalaman. So, next slide. After detecting, you have to apply direct pressure or you can use devices like tourniquet. And kung kailangan mo magbigay ng fluid, do not dilute. So, hindi, meron tayong tinatawag na tolerable hypotension. So, yung hypotensive resuscitation to avoid thin blood or pumping stability or pumping fluids. So, yan. No? So, yan yung 4Ds. Then sa March, no, massive hemorrhage. Then we have A. A means airway. Airway management, malalaman natin. Next slide. By looking at the level of consciousness. Okay, so training po yan. Next slide. Okay, level of consciousness, and at the same time, tingnan natin kung lalo na kahit sa airway tayo, simultaneously check din natin yung ibang parameters, but through by looking, look, listen, and feel the way sa huminga. Okay. Next slide. Then huwag ka mag-blind sweat, no, para sa pag sa airway, sa patidsi ng airway. Then respiration. 10:30, 15:45 sa bata. Okay, next slide. Then circulation. Okay, so ito yung checking if there are other than sa massive bleeding sa extremities, check baka may iba pang simula sa leeg, no? Abdomen, parang ito yung secondary assessment. Next slide. And then check for head injury and hypothermia. Okay, next slide. And then of course painkillers. So ito lang naman, although ito yung parang first aid sa military, iba naman sa military, medyo advanced sila. So at least baka lang mapunta kayo sa abroad, tapos baka pa kayo, tapos pumasok kayo sa serbisyo, hindi na kayo strange na na hindi nyo alam yan. So naalala ko to kasi yung anak ko nasa US Army, kaya nung tinuruan sila ng combat life saving, tuwang-tuwa siya kasi na-train na siya dito sa Pilipinas, hindi na strain sa kanya during sa training ng CLS or combat life saving. My son is in the US Army, baka raw sila in case ang US ma-deploy sa kasi napunta na sa Latvia yung US in preparation sa Ukraine. So tinawagan niya ako, baka lang daw ma-deploy sila. Next slide. So ito yon. We don't make a diagnosis, but you have to know yung sa MOI, tantayan mo ang reklamo ng pasyente, ano yung nakikita mo. And somehow, yung diagnosis mo is not really doctor's diagnosis actually. Diagnosis, prognosis, kung okay ba o hindi, doon mo ma-determine what level of transport na masuggest mo sa pasyente. So that's the essence of it lang naman. So next slide. I'll give you one sample. So nahulog ang pasyente sa kabayo. With his permission, pumayag siya. No? Yeah, it's okay. He's a former soldier na combat medic. Nahulog siya, bali ang tibio and fibula. Tibio-fibula. Tibia niya sa kapibula. As in. So close fracture. Siyempre, doktor ako, nakita ko. So I gave morphine. Kasi sobrang sakit. Ang pain is 9 to 10/10. Sobrang sakit. Malayo ako, tinawagan ako. So sirit ako papunta sa kanya. Okay, next slide. And then, tiningnan ko yung minanipilit ko lang konti para maalay yung pain na in-straighten ko yung involved na limb. Pero nagkataon, wala kaming splint. Next slide. So, inorderan ko yung isang kasamahan ko na EMT. Taga-Sulu to, tausog to siya, pero EMT siya. So, nagpakuha ako ng bani ng saging sa kawayan. And then, next slide. Ginawa kong splint. Yung bani ng saging, medyo malamig-lamig yun. Nakakatulong din para maalay yung pain. So, bani ng saging, next slide. Nilagyan ng kawayan, elastic bandage. So, mas maganda talaga elastic bandage o Berti bandage kasi maganda ang holding power niya. So, yan ang nangyari. Next slide. So, ayan na, nakasplint na siya all over. So, pinasakay namin barko kasi sa Camiguin to no? Pinasakay yung barko papuntang Cagayan de Oro upang sa gayon siya ay confined sa hospital for definitive treatment. Ayan. Pero at the same time, hindi na to first aid. First aid yung ginawa ko, hindi na rin. Bakit? Nagbigay na ako ng fluid sa kanya. Para lang abang ng tawag nito. In case I have to drive, analgesia via endotracheal, via intravenous. Okay, next slide. That's Praying Hand by Dorer. Magandang story nito. Mahirap yan sila. So, gusto niya mag-aral sa France ng pagiging artist. So, dalawa silang gusto mag-aral. Yung kuya niya, sabi ng kuya niya, sige, ikaw na mag-aral, wala tayong pera. Magtrabaho na lang ako sa minahan. So, nag-aral siya so many years hanggang sa nakatapos siya. Naging siya, famous sculptor. Si Dorer naging famous sculptor. Tapos nang bumalik siya, sabi niya, ikaw naman mag-aral. Yung kuya niya sa katatrabaho sa mine, hindi na makapag-aral dahil ang kamay, pasmado na. Wala na talaga pag-asa. Ang ginawa na lang niya, gumawa siya ng sculpture, the praying hand, in honor sa kamay na tumulong sa kanya. It's a very nice story. So, ganun din tayo when we, there are sacrifices before we became as lifesavers. There are sacrifices given by our families to be who we are right now. So we have to always remember those people who sacrifice for us to be very good humanitarian workers. Next slide. So yan yung story ng si Albert Dürer. Okay? So yeah. Next slide. So good medicine in bad places. So yan yung ibig sabihin niyan. Okay. Now guys, I'll just do my next lecture para puro ako practical na lang mamaya. Hindi yung mag-practical ako tapos balik naman sa lecture. Masisira yung momento. So my next lecture to you is basic life support. So it is part of first aid. But it is already a course all by itself on its own because first and foremost, it becomes a requirement to other courses. So BLS 2020. Kaya baka magulat kayo medyo bakit kakaiba siya. So this is really an extracted file from the ACLS 2020, yung BLS. Hintayin natin yung slide. So basic life support is a concocted ng AHA. Ibig sabihin, sila yung nag-isip niyan. Pero wala na magawa ang AHA sa intellectual rights kasi marami nang gumagamit ng BLS kahit hindi AHA. Kahit ASHI, BLS na rin siya. So naging common na lang siya around the world. Pero ang unang nag-concoct ng word yan is yung AHA. Actually, Red Cross, nag-claim din sila na sila daw yun. So, hindi kasi na-establish yung year talaga. So, Red Cross, sabi ng Red Cross, we are earlier than you. Wala nang dispute. O sige, lang. It's everyone's property na lang kung sino na lang ang nag-concoct ng BLS na yun. Okay? So, next slide. Next slide. So, anong objectives natin? First and foremost is describe natin ang basic life support and then identify the chain of survival for both in-hospital cardiac arrest and out-of-hospital cardiac arrest. And then BLS and COVID protocols. Tapos perform BLS skills. Ang problema dahil virtual tayo, ako na lang ang mag-perform at manood na lang kayo. And then understand the bridge towards ACLS. So, or other advanced life support. Pero it's always the ACLS ang nangangailangan ng BLS. Halimbawa, mag-trauma ka, mag-ITLS ka, hindi ka mag-BLS, walang requirement. Ang kailangan lang naman pag nag-ITLS ka, sa nag-PHTLS ka, may knowledge ka sa BTLS, sa Basic Trauma Life Support. Pag nag-management of obstetric emergency and trauma ka, hindi mo na kailangan mag-BLS. Ang nangangailangan lang talaga BLS is ACLS. You cannot progress into ACLS pag hindi ka pasado sa BLS. Okay, next slide. So BLS refers to a set of basic interventions for the urgent treatment of any unconscious individual, adult, child, or infant, na walang pulso, or with agonal breathing, or with no breathing, or with an airway obstruction, and to institute naloxone to a person with opioid overdose. Haba? Ganun na pala ngayon. So yun yung bago. BLS is performed by trained personnel. Parang kayo, pag na-train na kayo, meron kayong, kailan makakuha kayo ng certificate na BLSP, maybe provider. No? Actually, walang bumabagsak. Pag bumagsak ka, hindi ka lang bibigyan certificate, paulitin ka, parang ganun naman. Ganun yun. I don't know kung anong patakaran yun ngayon, pero nung time na ako instructor ng American Heart, so ganun siya. Unless pag nakitaan ka ngayon na magaling ka, BLSP ka pa rin, pero doon sa instructor's notes, minamarkahan na IP ka. IP means instructor's potential. So susulatan ka nila na, are you willing to undertake? Ganito, to be instructor. Yan. Tapos pag instructor ka na, makakuha ka ulit ng certificate. Na I ka na, instructor ka na for basic life support. So dito sa Pilipinas, ang mga instructor pools meron dito, no, na medyo general, talaga, on the side of the government is yung Philippine Heart Association. Although si Red Cross, sila yung certifying body. Pero pinaka-legit talaga, siyempre si Philippine Heart, doktor yan eh. Mga doctors yan eh. Ang nasa Red Cross, hindi naman lahat doktor, first aider. Siyempre, doon ako sa mga doctors na making the standards of it. Kasi sinusunod nila yung AHA. Okay, so yan ang definition natin. Next slide. So ano ang magiging sakop niya? So of course, the 2020 protocol, the compression mechanics like 1-man versus 2-man rescue, in hospital ba yan versus out of hospital, adult, child, infant na style, tapos AHA versus Badger County or other ano. So hindi naman nag-aaway. Meron lang mga styles, no? Pag sinabing Badger County, Arizona County, tapos Arizona style, Badger County, CCR of Singapore. So man kanya-kanya sila. Pero ang body controlling it is the ILCOR. Okay? So yung is in it's like a international parang committee. No? Then we do BLS in COVID. So merong konting adjustment. So meron akong isinamang slides yan, yung 10 commandments na ginawa ko. In case lang nasa labas kayo, hindi kayo sa in-hospital. Pero tuturuan ko rin kayo paano mag-BLS inside the hospital. Pag nag-iisa ka pa lang, no, depende sa hospital naman yan. Hanggang dumadami kayo. Sino yung uuna? Ano yung unahin? Dati kasi compression, ngayon medyo COVID tayo, medyo kakaiba. And then look at foreign body airway obstruction management, rescue breathing, and then naloxone. Nalihirapan ako sa accent, sa pag-pronounce. Naloxone, yan, naloxone induction. Okay, next slide. So BLS is a requirement for ACLS. Mainly, nakalimutan ko ilagay. Pero indirectly, requirement din siya. Mahirap yung nag-advanced life support courses ka na hindi mo alam ang BLS, niloloko mo kasi. Lahat yan, mag-start, mag-CPR talaga yan. Lahat yan, matrauma man yan, ma-medical, pag lumala yan, pag nag-arrest yan, hulog lahat yan sa heart. Kaya baga ang ACLS is the cornerstone of all advanced life support. By virtue, no, na lahat talaga magka-cardiac arrest talaga yan. Next slide. So, ano yung tinatawag na in-hospital chain of survival? So, 6 yan. Pinakabago, 6. So, meron tayong early recognition. Doon nagbabangko ang buong mundo sa early recognition and prevention. Okay, so doon muna ako sa early recognition and prevention. So, paano natin malalaman yung early recognition and prevention? Lalo na pag in-hospital. So, inaalam natin kung sa mga patient history, ano ba siya? Anong meron tong tao na to? Nasa, ano siya, anong lahi, anong gender, anong edad. Kasi meron tayong tinatawag dyan sa prevention, understanding prevention and recognition sa sa mga modifiables versus non-modifiable. So sa mga non-modifiable, merong 3 components ang non-modifiable na most likely madadali ka talaga sa cardiac arrest. Katulad ng number 1, age, edad. Pag medyo edad-edaran ka, wala na talaga akong magawa. Mas normal yan. Wala namang fountain of youth. Okay? So tandaan yan. Number 2, gender. Sa mga lalaki, mas prone sila magkaroon ng cardiac arrest kumpara sa babae. Siyempre kasi ang hormone ng lalaki is a warring hormone, yung active siya, fight, 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 gano'n. So siyempre ang wear and tear sa vessels mo, mas mataas pag gano'n ka. Pangatlo, hereditary. Kaya nanay, tatay mo, kunwari diabetic, o di problema tayo. So pwedeng mataas ang likelihood madadali ka, or kung may heart ailment, madadali ka rin. So yun yung non-modifiable. Pero dito tayo mag-a-action sa modifiable. So ano yung modifiable? Katulad ng high blood pressure. Oh, pwede natin siya ma-modify. Ibig sabihin, we control the pressure. Hindi natin pabayaan na mataas siya. Number 2, high cholesterolemia. Hypercholesterolemia. High cholesterol in the blood. Siyempre, pababain natin. So depende kung may involvement ba ng triglycerides or yung check natin yung total cholesterol, no? So depende kung mag-statin ka, mag-fibrates ka, basta pababain natin. Ano pa? High blood sugar. Kunwari, hyperglycemic ka, may diabetes, i-control natin kasi siyempre alam natin diabetes, it's complications. Madadali talaga yung heart. Now, you have to note here, since you are all nurses, it is not actually the fats. You are all deceived. Na-deceive tayo lahat na ang pinaka-bad talaga daw, number 1 culprit sa buong mundo na kalaban ng tao is fats. Wrong, people. That's absolutely wrong. The number 1 enemy of our body is sugar in excess. Of course, glucose is needed by our body for metabolism, aerobic metabolism. But it's the sugar that is the culprit of all the trouble. Yan. Excess sugar becomes triglycerides din. So taba-taba din siya. So very addictive pa. It's worse than opium. Kasi subliminal si sugar pag tumira. Okay, so yan, no? So ano pa ba ang mga modifiable? Obesity, o di magpapayat ka. Ano pa? Smoking, o di huwag ka manigarilyo. Ano pa? Sedentary lifestyle, o di mag-exercise, yan. Walk, pinakamaganda, mga walking lang. Walk ka lang, aggressive walk, mag-aggressive ka find ways to walk. So, those are the things we can modify. Ano pa? Stress. Yun, mahirap mag-advise for stress kasi ako, biktima ako diyan. Stressful din talaga yung life ko. Kaya punta na lang ako ng Ukraine. Kung makuha ako, mataas bayad doon. Mag-work ako doon, pwedeng combat medic, 1,200 per day ang sweldo ko. Kagatin ko na yan, doon na lang ako. So, doon tayo nag-bank sa early recognition and prevention. Now, in case mayroong cardiac arrest, no, sa in-hospital ako then activate emergency response, perform high-quality CPR of no less than 120 per minute. Kung hindi kaya, 100 to 120. Tapos, defibrillate. Pag in-hospital, ideally, huwag ka mag-AED. Manual ka, manual. Hindi AED. Ang AED sa out of hospital siya. Okay, then, by the way, AED stands for Automated External Defibrillator. For those who, then post-cardiac arrest care or post-ACLS care. And then, ito yung nadagdag yung recovery. Sa recovery kasi, kailangan cycle ulit. Malaman natin, babalik ka ulit doon sa recognition and prevention para ma-prevent natin sa recovery. Kailangan may family sa community support. Ano yung community support? For example, post-stroke ka, naka-wheelchair ka. Dapat ang community natin ay friendly sa mga may sakit. Yung mga sidewalk, mayroong ramp for wheelchair. Yan, no? Katulad pag pumunta ka sa Japan, mapunta kayo sa Japan, maglakad kayo, magugulat kayo, meron doong corrugated parts sa street para sa mga visually impaired, sa mga sabihin natin bulag. So pag bulag ka, hindi ka nandoon talaga. Merong area, hindi ka mawawala doon. Okay, so yun yung sinasabi ko na part ang community in your recovery or rehabilitation. So yan yung in-hospital. Sa out-of-hospital, ang difference lang is syempre the component of the ambulance. So pag nakita ka na may problema sa out-of-hospital, call for help, institute CPR, tapos kung may public access defibrillator, then care inside, ACLS care inside the ambulance, and then post-cardiac arrest care, and then recovery. People, dahil kayo ay mainly nasa hospital, memorize this by heart. Sa standard exam, no? Siguro gagawa ako ng exam, no? Swerte kayo ngayon, ha? Ibigay ko kay Ma'am Joylet sa next batch, gagawa talaga ako ng exam. Ito, ipa-enumerate ko talaga to in order. Kasi useless ang BLS sa ACLS pag engot tayo sa chain of survival. Ito yung startup eh. Okay, next slide. Then kung merong adult, may pedya. Okay, so sa pedya pareho din, pero medyo, ito lang ha, ito, you have to admit these people. Ang mundo mas pabor sa bata. Kaya in hospital sa out of hospital, merong mataas na component ang prevention. Dapat ang mundo natin child-friendly talaga. So diyan mo makikita na sa out of hospital, merong prevention. Pareho sa in-hospital, pareho sa adult. Although, ang defibrillation is not mentioned as defibrillation, it might be. Pero karamihan kasing arrest sa bata ay hindi cardiac o hindi pulmonary. Yan, kaya hindi. Kung sa adult, ang nakalagay dyan sa may lightning ay defibrillation, sa bata, simply advanced resuscitation. Dito naman sa ibaba, same thing, pero walang nakalagay na defibrillation, hindi katulad sa adult. So sa bata, ambulance lang kaagad kasi mahirap mong ipa-cardiac arrest ang bata. Mas matibay siya kaysa sa atin. Okay? So, yan yung totoo dyan. Okay, so yan ang chain of survival. So, memoryahin yung apat na yan kasi by the next time na mag-exam tayo, magbibigay ako na exam kay Ma'am Joy, ano to, ipa-enumerate ko talaga in sequence, no? Ilan yan, no? Rin, 1, 2, 3, 4, 5, 6, 6, 24 din yan, 24 items din yan, no? Grabe. Konti lang naman yung exam ko, 350 items lang naman yan. Next slide. For us to understand why we have to be fast, because what we are after is a brain that does not enjoy oxygen. So meaning, kapag may cardiac arrest yan, wala na oxygenation sa brain, so ganyan ang mangyayari. So from 0 to 1 minute, so cardiac irritability, ibig sabihin, ventricular fibrillation, no? That's mainly what's happening. No? Then, pag akit sa 4 minutes, halos fine BF na lang yan hanggang mag-asystole yan. 4 to 6 minutes, pwedeng asystole na yan, may brain damage possible. 6 to 10, super asystole na talaga. Beyond 10, mahirap na lalo na sa tropical country. So, kailangan bilis ka talaga maka-institute ng BLS, particularly sa compression. Next slide. So, what happens? These are all pictures actually. What happens when a fibrillating heart has no intervention? Pinaka-high upper picture, yan ang mangyayari. So, matay talaga. Hanggang course BF, mag-fine BF, hanggang mag-flatline. Sa next picture, delayed ang CPR, so mababa ang margin of survival. Sa third picture, mabilis ang CPR, late ang defibrillation, at least tumaas. Hindi na to ang statistics, nabago yata itong statistics ngayon. I just forgot. Nang time na nakita ko, it was hindi ko nakuha ng source. Tapos dito sa next, hanggang sa ibaba, puro early approach ka, early call, early CPR, early defib, early ACLS care. Actually, depende sa may age bracket, umakyat siya even up to 84. Wow! Kaya in-encourage yung mga public access defibrillation. So of course, mayroong age bracket to. Next slide. So, BLS is considered as a bridge to ACLS, so we call it the BLS primary. Kasi yung ACLS mo, tawag doon ACLS secondary. No? Next slide. So yan yung package natin. Okay? Yan. So, una, nabanggit na natin, chain of survival. Then, we have the compression, which I will do a demo later. Then, foreign body airway obstruction management. Then, rescue breathing, AED operation, and naloxone induction. Next slide. So, sa BLS, yung component niya, scene is safe. No? Scene is safe, then assess responsiveness. Whatever it is, activate code blue. I don't know what you call yourself diyan sa Tri-City, or activate emergency response. Tapos cover the patient with mask, no? Yung kanyang bibig kung nasa out hospital kayo. Pag nasa in-hospital kayo, non-rebreather mask. Next slide po. And I will do a demo on that. Okay? Next slide. So this is your algorithm for BLS. So number one, scene is safe, pinakitaas. Then ano ang patient? So unresponsive siya, you call for help, activate emergency response, and request for an AED kung meron. Now, as you assess the patient, while checking the pulse, kasi ano tayo we are healthcare providers, we should check the pulse. So while checking the pulse, we are checking the airway. So assuming there's airway and there's breathing, then we just put, kung kaya, position of comfort, no? Kung hindi naman namutla, para mag-shock position tayo. So depende, no? Kung namutla, shock position. May kasabihan, when the head is pale, raise the tail, yung paa. When the head is red, raise the head. Ganyan lang yun. Okay, so nakita natin yung breathing irregular or agonal, then we do rescue breathing. Ituturo ko paano mag-rescue breathing using bag valve mask kasi healthcare provider tayo. So yan yun. Now, what if the patient has no pulse and no breathing? So that's the time we perform CPR. So we perform the 2 cycles of CPR. Pwedeng along the way, dumating na sa AED or wala pa, basta 2 cycles. And after that, after 2 cycles, wala pa rin, no? Check for responsiveness, check for pulse ulit, baka meron. And then again, run down again CPR. Pero sa ibang bansa, at ang gumawa ng ganitong algorithm ay ibang bansa, ina-assume nila na meron kaagad AED. So habang nag-perform ka ng CPR, meron lang akong i-remind everyone na AED, merong mga hindi tayo sinusunod. Voice prompt siya, no? Pero merong hindi sinusunod. Kasi may mga AED na babalik ulit sa simula. Pag alam mo, nagsisipera ako, biglang nagbukas yung merong AED, tapos sasabihin ng AED. Unit, okay. Apply patch. So, huwag kang huminto. Gawan mo ng paraan na yung kasamahan mo, yung kahit hindi mo kasamahan, no? Kasi naglalakad ka lang sa mall, kataon na meron doon, utusan mo. Ilagay doon, ilalagay mo sa dibdib, or kung ang dibdib mabalahibo, sheban niyo muna habang tuloy-tuloy CPR kasi. The first undisputed rule sa CPR is, the second rule undisputed is no interruption in compression. First one is push hard, push fast. Although sa 2020, naging one na yung isa. Pinagsama na yung push hard, push fast with no interruption. O, ganun na yun. Sinama nila. Pero pareho lang yan. Basta importante doon, no interruption ka. So, habang sinishave yung balahibo, tuloy-tuloy. Tapos paglagay ng patch, nilalagay mo na yung patch, tapos binubunot lang yung may naka-extend na rabbit ear para dumikit yung ECG pads. No? So, ganun lang. No? Although, i-demo ko yan. Tapos pag may ilang magsasabi siya, call for help. Alangan naman call for help ka. Tapos na nga yung call for help mo kanina call for help ka ulit. So wag mo nang susundin. Yun yung point ko kasi ang AED, karamihan binabalik ka niya sa simula. Sundin mo na lang yung metronome style. Okay? If there's no pulse, start compression. tit, tit. Oh, yun na, sundin mo na yun. Yung tit, tit, tit na yun, expected mo, kunwari nag-CPR ka na, nakatapos ka ng 2 minutes, expected mo na may 2 minutes ka ulit bago siya analyzing. Doon sa analyzing ka ngayon, isa sa sundin mo, no? So there are few things na hindi mo pwedeng sundin na, lalo na kapag nakapagsimula. Okay, so nag-perform akong CPR, biglang after 2 minutes, na tit, 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 biglang sumigaw siya. Analyzing. So, yun, bitawan mo na. So, okay, ganito. Binitawan ko ang katawan ng tao. Bakit? Kasi para magbasa maayos si AED. Bakit kailangan nakabitaw ka? Kasi ikaw ay meron kang electrical impulse. Baka mamali basa niya, baka ang nababasa niya ay sa'yo. Ganun ba? Meron palang kuryente sa katawan ng tao, bakit di ko nararamdaman? So meron po tayong kuryente. Kasi mainly, kung ang tissue lang ng tao, per se, tissue lang, hindi po tayo conductor. Nagiging conductor tayo kasi 70% of our body is composed of water. So, ang water is a conductor. Kaya ang heart, tingnan mo si heart, pag nag-detect ka ng limb lead sa heart, naglagay ng ECG doon sa wrist at saka sa ankle area, bakit doon nakikita ang heart? Sa limb leads? Yes, because nagbabato ng kuryente ang heart mo. Limb leads ang tawag doon. So, nakukuha ang electrical impulses ng heart, nakukuha mo ang heart via the limb leads, kasi dalawa kasi ang how you look at the heart, the limb leads and the chest leads. Okay, si Roman numeral 1, 2, 3, saka si ABL, ABR, ABF, yan yung limb leads. Then the chest leads is B1 to B6. Okay? So, sumigaw siya, analyzing. So, ina-analyze niya, yun yung rhythm check. So, makikita dito sa maroon na box, rhythm check. Few seconds lang yan. And it will determine, the AED is programmed to determine if the rhythm is shockable versus non-shockable. So, yan po. Okay? So, next slide. Pinalaki lang. Tinanggal ko na yung demarcation. This is the total, the whole BLS package. Yan. In the aspect of compression. Next slide. Pabalik-balik naman. Doble. Next slide. Ito yung luma, pero applicable pa rin ngayon kasi wala namang sinabing ano. So yan, ulit. No? Unresponsive, no breathing, no normal breathing, only gasping. So activate emergency response and get the defibrillator. Then you can start CPR. So magsa-cycle ka ngayon sa 2 minutes. Assuming meron kang tawag nito, may AED ka. So shock CPR ka lang hanggang madala sa ospital. So ganun lang naman yun, shock CPR. Pag nag-ACLS ka na, drug shock, CPR ka na. Okay? So, yan o. Push hard, push fast. Okay? So, yan ang cycle ng ating BLS. Next slide. Now, next slide. Now, this is how you will do it in the normal process. May konting adjustment in the COVID times. Yan. So, ituturo ko yan mamaya sa actual. So again, mainly, pag solo rescuer ka, 30:2 for adult and for child. Okay, adult, child. So, single rescuer. Pag double rescuer, 30:2 for adult, 15:2 sa child. Pero pag double rescuer, meron kang BVM na naka-attach sa oxygen. So, papakitaan ko kayo ng assembly mamaya. Okay, tapos ang lalim ay 2 to 2.4 for adults, tapos sa bata, 1/3 of the depth of the chest. Okay? So 1/3 of the depth is around mga 2 inches. Yeah. Next slide. Ngayon dahil COVID, nagdagdag sila ng protocol. Hinabol ang 2020 kasi yung 2020 protocol ng AHA, kahit 2020 siya, pero ginawa yon mga 2018. Hindi naman ganong pag 2020 gumawa ka, 2020 ma-release, hindi. 2018, 2019. Usually 2019 yan. Tapos na-release sila 2020. So wala, na-release sila, wala pa yung COVID. So nag-emergency ano sila, doon sa chain of survival, bago compression, hindi siya part sa chain, pero meron ka, ginawa siyang steps. So after you call, activate emergency response, then before compression, you have to put the mask. Yun lang naman ang dinagdag eh. So yan yung sa AHA natin. Okay, next slide. Okay, so ano ang role ng H-rescuer? Ituturo ko sa inyo. Dati, palitan. Okay, mag-switch duties ang rescuer sa airway. Ngayon, sa COVID po, hindi na. So expected na medyo sa loob ng ospital ang magko-compress ay palitan dalawa. Ang airway lang siya. For the purpose na ayaw natin madagdagan ang makontaminate na tao. Kasi among sa team na magresponde sa tao, ang pinakamalapit talaga na most likely makakuha ng COVID is the airway guy. Kaya laging naka-level 4 siya. So yan ang ating setup. No? Hindi natin masusunod tong magsiswitch ka, ang compressor, maging airway, tapos after another 2 minutes, palitan. Hindi siya masusunod na yan. So kung ikaw, airway ka, kawawa ka. Oh, sorry talaga. Yun ka, wala tayong magawa eh. Dinisign kang ganun ka eh. Okay, next slide. So dito sa next slide is, there was a study checking how many oxygen, blood going around the body sa isang very good compression. So pag maganda ang push hard push pass mo at 2.4 inches sa adult ka, umakyat sa 140 to 160 millimeters of mercury. And that thing is very good para sa oxygenation ng brain mo. Ngayon makikita mo may mga bakante. Ito yung time na after 30, hihinto ka. Hihinto ka para magbigay ng oxygen. The storyline here, pag nag-solo rescue ka, nag-iisa ka lang, hindi maganda ang 30:2. Kasi kahit pa meron kang BBM, nag-iisa ka lang. Oh, no? Hindi naman pwedeng mouth to mouth, bawal na siya ngayon. Pag huminto ka, wala talagang walang oxygenation sa brain. Kailangan continuous yung oxygenation sa brain. So ang all compression ay ang all compression ay dapat na-institute kasi kahit hindi ka huminto para magbigay ng hangin, merong by virtue of recoil sa lungs, no? Pumapasok ang hangin sa lungs. Pumapasok sa alveolus. Pagpasok sa alveolus, lilipat sa blood vessel. Kahit hindi ka huminto, tuloy-tuloy lang. So, mas effective ang all compression sa isang solo rescuer na wala siyang kasama na merong bag valve mask. Pero pag double rescuer na kayo, meron ding requirement. So i-demo ko yan, explain ko yan mamaya para mas maintindihan niyo. Ano yung mas pabor sa patient. Next slide. Ito yung bagong na-offer ng 2021. Sa BLS provider, naging 6 na. Pwede nagbibigay ng gamot. Yung tinatawag na naloxone. No? Narcan. Dalawa kasi yan eh, Narcan or Cloxado. Yung Cloxado, mas mataas ang dosage. So ito, usually sa US kasi maraming mga opioid addict doon. No? So no amount of CPR defibrillation, pag ang opioid nag-cause ng arrhythmia, wala talaga. Unless ma-reverse mo yan, hindi mo mabuhay yung tao. Tapos hindi mo siya ma-reverse, by simple wash out. Kailangan talaga i-block mo yung mga receptors by introducing the naloxone, Narcan. So meron tayong intranasal solution by Narcan, mas medyo mababa siya. 2 mg actuation saka mayroong 4 mg actuation. Yung Cloxado mas mataas siya. 8 mg actuation siya. Okay? So single dose siya sa isang nostril. Next slide. Okay, single dose sa isang nostril. Next slide ulit. So yan ang forma niya. Kakaiba. Single dose. Ngayon kung gusto mo mag-run, sa continuous CPR ka na, sa ambulansya, humingi ka na ng medical advice kung kailangan ba. Siyempre kasi mayroon din side effects yung mga sinaloxone. Na hanapin ko, may ganyan ako eh. Hanapin ko kung saan ko nalagay. Pero ano siya, paso na siya. Next slide. So if you can see, si Cloxado mataas siya. So repeat dosing, no? Pag yung desired response is not obtained, then pwede ka mag-additional spray but you have to inform your medical control. Next slide. Yeah, diyan nilalagay yung direct sa isang nostril. Next slide. Kasi bakit kailangan natin? Kasi magkakaroon ka ng respiratory depression sa opioid and will result into cardiac arrest. Sabi ko sa inyo, lahat ng problema sa mundo, sa katawan, matrauma man yan, ma-medical, pag sinagad mo yan, hirap na hirap siya, cardiac arrest talaga ang patutungan. Nag-respiratory arrest ka, magka-cardiac arrest, ganun ka rin. Ganun lang yan. Okay? Next slide. So, now, dosage modification, yung mga partial opioid agonist or mixed agonist antagonist, okay, i-correct natin ng respiratory depression. So it's like part of the drug kit and it's now under BLS. Next slide. Now, the emergency medical care, nag-IV na tayo, ICLS na yun. So dito sa sa pre-hospital, yung mga restrict 2 mg dose to opioid dependent patient, no? Nagkakaproblema tayo. Minsan kasi mga tao, pag nagbigay ka ng Narcan, kailangan may pulis kang kasama kasi it took them a hard time to get opioid tapos ngayon babasagin mo yung trip nila. Pwedeng pumatayan sila ng tao. So kung hindi naman respiratory, gusto ko lang positive talaga for opioid dependency or substance abuse. Pag i-reverse mo, may kasama kang pulis. Next slide. We go into 10 commandments. Ito yung ginawa kong 10 commandments. Okay. I'm not changing the protocols. Ganun pa rin, except na medyo hinighlight ko lang dito sa Pilipinas. So next slide. This is about sa labas ng hospital, out of hospital approach. So dahil nurse ka or sino ka man, tapos na-train ka sa BLS, lalo na pag nurse ka, parang ang sakit na may nabumagsak na tao or na person in question for whatever it is. Tapos wala kang gagawin. So wala naman, you cannot go to hell naman kung ano man ang reason. Pero if you remember the story of the Good Samaritan, what do you wanna play? Who are you when you see a person in distress? Kaya mo bang talikuran? Or babain mo? So, number 1, dahil COVID ngayon, always rule of thumb, consider everyone to be COVID positive. Ganyan lang. Okay? Number 2, next slide. Check in. Ibig sabihin, introduce yourself to the crowd. Okay? Maybe I can help. Baka po makatulong ako. Ako po si Juan de la Cruz. Isa po akong nurse, baka po makatulong. Lagi mong sabihin yung baka. Huwag ka magsabing makatulong ka. No? Kasi you don't give like let the people have full expectation because case-to-case basis yan sa culture natin. Next slide, 3. Crowd control may be there or may not be there. Kung wala ang anong tao, hindi mo ma-employ ang crowd control. So it does not mean always number 3 to. Baka pwedeng sa last part to. Pero sige, isama ko muna dito. Maraming tao, you don't like na maraming tao kasi pwede mag-super spread. So maging super spreader. So palayuin mo yung mga tao. Habang nag-access ka sa pasyente, sir, pasuyo naman, paayos ng traffic. Sir, pabigyan ako ng hangin. Palayuin mo siya. Hindi naman, unless may lumapit sa'yo, marunong din siya, you can have him na mag-alalay sa'yo. Okay? So, bigyan mo ng assignment yung mga tao sa paligid, huwag sila maging osyosero. Kasi pag osyosero yan, lalagay yan ng niyang cellphone, sikat ka ngayon. Kaya gawin mong tama kasi you will be popular, viral ka ngayon. Next slide. Number 4 is check hazard. So, anong dahilan bakit bumagsak yung tao? So, yun yung hazard. Pero sana, mapakialaman mo rin kung may hangin, saan galing siya. Maganda yung hangin na tumatama sa likod mo para kung yung aerosol ng tao, palayo sa'yo. Hindi papunta sa'yo yung nabububugang aerosol, lalo na pag nag-push hard, push fast ka, yun yung problem. No? Tumulong ka na, nagba-viral load ka. Next slide. Then, check for responsiveness. So, i-demo ko mamaya paano mag-check for responsiveness. Medyo may kakaiba in checking for responsiveness kasi meron ng tinatawag na trapezius pinch. Trapezius pinch. Next. Then, call for help. Pag call for help ka, swerte kung nasa Davao ka, mabilis ang 911. Swerte kung nasa Cebu ka, mabilis ang Aero. No? So, yan. Pero pag nasa ibang parte ka ng Pilipinas, pag nag-911 ka, ang problema sa 911, pupunta mo na ng Manila. Tapos yung Manila, tatawag ko naman, nasa Sulu ka, tatawag siya, babalik niya doon sa Sulu or sa Tacloban, it takes time na, masyadong matagal. Hindi katulad sa US na per state, meron talagang 911 command center. Hindi na pupunta ng Washington DC ka nga. So ganyan po yun. So call for help. No? So ganito po sa Tagalog. Pag check mo ng responsiveness, ang tao hindi siya responsive. So you can say, wala po siyang malay. Sir, ikaw po na naka-polka dots. So isang kamay mo ay nandoon sa carotid kasi nurse ka. Para i-overlap mo, dual job ka, nasa carotid area. Sumisigaw ka na, sir, ikaw po na naka-blue. Pasuyo po ako ng ambulansya sa katanod. Yan, dalawa palagi hingin mo. Yung ambulansya, siyempre kailangan mo ng ambulansya kasi will take it that lahat ng barangay may ambulansya. Ideally, dapat ganun. Tanod is for you to endorse kasi wala ng good Samaritan. Yung tanod, perhaps, nakikilala kong pasyente na to kung tagad dyan lang yan. So, yan yun. Okay? Next slide, number 7. Before you start your CPR, cover the mouth and nose of the patient using pinaka-ideal is surgical mask. Merong American Heart Association nagturo na baliktarin daw yung mask. Mali po. Hindi mo pwedeng baliktarin. Same pa rin. Kasi the inner layer of the mask is the absorbent layer. Ang absorbent layer ang kailangan kong kunin para habang nagsi-CPR ka, yung hangin na lumalabas, ma-absorb doon sa inner. Ang outer layer is the repellent. You don't like to repel kasi pag nagbuga ka ng pag nag-ano ka ng hangin, pag nag-compress ka sa dibdib, yung hangin na lalabas doon sa repellent layer, lalabas sa mga gilid-gilid, lumilipad din sa himpapawid yung mga aerosol. So mali po yun. Nakinig ako, American Heart Association instructor pa naman. Hindi naintindihan yung mask. So ang mask, same. Because the surgical mask, the first intention ng surgical mask ginawa, hindi dahil maproteksyonan ako kung ako ang sumusuot. But maproteksyonan ko ang mundo, kaya ang mga doktor, kaya sila nagsa-surgical mask, no, tayo sa operating room, not to protect us, but to protect the patient. Yun yung first intention. Kaya maling-mali yun kung nagsa-surgical mask ka, para isipin mo maproteksyonan ka. Kung gusto mo protection, mag-identify ka. Yun yung pinaka-minimum standard mo. No mask will not. Konting-konti lang tayo. Ang ginagawa ng iba, nagdo-double mo surgical mask. Nako, di grabe na yung resistance. Saan lulusot ang hangin? Sa gilid-gilid na. Doon hahanap siya sa corridor or sa least resistance. Eh kung maliit mukha mo, yung mask mo mag-flare sa gilid sa ilalim. Oh. Ang mask hindi siya one size fits all, depende din sa klaseng mukha. No? So yan. Okay, so number 7, cover the mouth and nose with the mask. Next, then you can start compression. Compression lang of 120 in a minute. So 240 expected ka, 220 to 240 in 2 minutes. No stopping to give rescue breathing. Wala nang ganun. Tuloy-tuloy lang. Pag 2 minutes, anong gawin mo? Mag-stop ka for 2 purpose. Check for pulse. Number 2, breather mo yon. Kahit 10 seconds, makapagpahinga ka. Kasi hindi biro mag-compress. And then compress ulit. Next slide. Then ideally, pag may AD, connect to AED. And listen to the voice prompt. Yan. So mamaya i-demo ko yan. Next slide. Then the last, ito yung totoo sa Pilipinas. Mahirap tumawag ng ambulansya kasi makasagsagan ng pandemya. Karamihan ambulance ay dedicated to COVID. So mahirap talaga rin, ubos talaga. So you should be ready how to bring the patient using other vehicles to hospital. Pwedeng tricycle. So kailangan marunong kayo mag-CPR sa tricycle. Yan, ganyang style, no? So ang tawag doon, case evacuation. Case evacuation is a military definition na tinransport ang isang pasyente sa isang vehicle hindi dedicated for as ambulance. Pag ambulance yon or dedicated for sa medical, ang tawag doon tactical evacuation. Pero kung nag-commander ka lang ng sasakyan, ang tawag doon case evacuation. Yan. Next slide. So ano mga take-home messages for 2020 ACLS at BLS up to ACLS? So yun, layperson start good CPR. No, yan yung mga makukuha sa first aid, sa first aider. 2, kailangan high quality siya with particular to depth and speed. Tapos sana, ideally, sa BLS lang, itong 1 to 3, ay makapag-institute ng defibrillation. So, itong pababa, ACLS na yung 4 to 10. Okay, next slide. Isinama din natin in detection ng stroke. So, ibig sabihin, anong mangyari kapag nakaano siya? Kasi it's a cardiac emergency also, no? Kasi cardiovascular nga, advanced cardiovascular, or BLS is a bridge to ACLS. So, vascular. So, stroke can still be a problem. So, actually, this is under first aid, pero i-piggyback natin sa BLS. So, meron tayong tinatawag na Cincinnati Pre-Hospital Stroke Scale. So, meaning, the Cincinnati Pre-Hospital Stroke Scale ay FAST, FAST. Nagbago na ngayon, dinagdagan ng BE, pero hindi Cincinnati. Pero let's give credit to Cincinnati. So, B is their balance and behavior change. May headache or dizziness, loss of balance, and or, so not necessarily pag may stroke ka, merong problem sa balance, pero walang problem sa balance. Kaya and or, meron kang blurring of vision, and or facial asymmetry or facial droop, and or arm or leg weakness, no? Arm drop, and or speech difficulty. And all of this, kailangan ma-package mo, na-identify mo para mabit natin yung time. Call right away. And support or transport immediately. Kung walang ambulance, transport immediately to defeat the time. Kasi pag matagal yung time, mabubugbog yung brain, walang oxygenation, mas mahirap na buhayin, baka hindi natin ma-reverse. Next slide. Okay, so ano yung highlights natin sa next slide? Next slide ulit. Okay, next slide ulit. So, sabay yan. So, guidance for BLS hanggang ACLS resuscitation. So, yung mga parang ating algorithm, pinakita ko kanina. And early identification and early initiation of CPR. Particularly sa pre-hospital care amongst lay rescuer. Sana. Pero ngayon, takot ang mga tao pag may bumagsak sa SM dahil Nag-suicide, wala nang gustong gumalaw kasi baka ang magagalit si Soko. Okay, and then the others are kahit anong mangyari pag ACLS ka, babalik ka pa rin sa quality CPR. Kaya tinatawag siyang BLS primary. Next slide. These are all ACLS schematics. Next slide. Okay. Then, ito yung emphasis on recovery sa 6 link ng IHCA sa OHCA sa chain of survival for BLS and ACLS. So, yan. And then next. Next slide. Sige, next. So, ito ay ACLS, pero may mga BLS component. Ano yun? Anong pwede natin gawin dito sa BLS? Okay. So, mayroong component dito sa BLS. Okay. Ang component dito, katulad ng cold exposure, no, through first aid, BLS and first aid. So, nagagawa natin yan. No? Another thing is hypoxia. So, kung ma-facilitate natin very good airway opening, you don't need to have oxygen. Facilitate mo lang yung 3 seconds breathing, so pwede. So, PLS yun, component. You can start with good BLS. Sa toxins, kung ma-delay natin yung ano ng toxin, kung merong available antidote, or ano man yun, like na kagat ng ahas, tapos meron siyang patient's med na anti-ahas, na kagat ng bubuyog, tapos may patient's med na anti-allergy. So, yun. We can do something about it. No? Next slide. So, team dynamics for BLS, anong gagawin natin? So, ituturo ko siya, okay? Para makita ninyo, nag-iisa kayo hanggang dadami kayo. So, kung nag-iisa ka sa ospital, ano ang unang gagawin? So, dahil COVID tayo, may kakaiba. Next slide. Okay, next slide. Yan. Yan na yung pang ACLS. Para alam nilang starting with 1, 2, 3, 4, saan ang setup. Okay, next slide. So, you have to remember, all arrests, you start your BLS, karamihang arrest ay ventricular fibrillation. Siyempre, hindi mo makikita yan dahil wala naman sa automated external defibrillator. Pero by statistics, 85 to 90% will have BF. So wala kang hemodynamics. Kailangan mag-CPR ka, then defibrillate ka. So sa BLS, wala tayong chemicals. So ang tawag natin doon ay ME lang tayo. Mechanical sa electrical defibrillation. Ngayon, kung ang AED walang sinabi no shock advice, continue CPR, it might be na asystole na siya or merong pulseless electrical activity. So as BLS, wala na tayong gagawin kundi CPR and then detection, baka maging baka maging BF, no? Malay mo lang. From napaka-strange naman, no? From flatline ng BF. But there are situations na nagiging ganun. Okay? The next is, dahil BLS tayo, sa in-hospital, merong variation sa in-hospital BLS. Ano yun? The usage of bag valve mask. Yan. And then how to introduce oropharyngeal airway and NPA. Yan, no? Sa BLS. Next slide. So this guy, partially cardiac arrest. Papunta sa kamatayan, nangingitim na yung ano. So nang tinawag ako, nangingitim na talaga. Zero pulse, zero lahat. I started CPR. Inutusan ko yung mga co-instructors ko kasi nagtuturo kami ng counter-terrorist. Inutusan ko, then kinuha yung defibrillator sa sasakyan ko. Sa madaling salita, na-defibrillate ko twice, nabuhay yan. After nabuhay siya, the funny thing, kinasuhan niya ako kasi nangitim yung dibdib, pero nabuhay ko siya. Hindi na pustro yung kaso kasi yung mga counter-terrorist, pinagsasabihan siya, binuhay ka na nga, magreklamo pa, sabi sa akin ng mga counter-terrorist unit. Ilibing na lang kaya namin yung sir. Kasi ang yabang pa, binuhay. Pero sa akin, okay lang. Kung nasa US ako, madadali din talaga ako kasi kahit binuhay ko siya, siyempre nangitim yung dibdib niya. For whatever it is, ano siya, tawag nito, nabuhay namin siya. And it is part na you feel the glory of patay siya. Kung wala ka doon, patay na talaga. So nabuhay siya. Because I have my own defibrillator na nasa sasakyan ko. So that's the story why we need to have BLS. If this is your father, you would probably thank me. And ako naman, I would really thank for being trained on BLS. And you will perform the same also. So iba yung taong may training kasi i-extend ng margin of survival, not only sa sarili mo kung ano man yun, but sa mga mahal mo sa buhay. So learn BLS not because it is an obligation or it is na kailangan compliance mo ng OSH ba siguro or what, no? But because ang una mong bubuhayin ay pamilya mo. Pag wala kang alam, ang gagawin mo lang ay sumigaw. Tatay, nanay, Lord, buhayin mo. Narinig ka ni Lord mo. Ang problema, binigyan ka na ng dulong, wala kang ginawa, hindi ka nag-join. Sumigaw ka, makipagpustahan ako. Walang kasalanan ng Diyos. Kahit pa sumigaw ka ng Lord, Lord, Lord dyan, hindi tatayo ang nanay mo sa cardiac arrest. So that's the essence why we need the life skills there. Not because it is a compliance by OSH, kung yan ang but it is because when you learn life skills, it's part of your dingal. Pag may mga skills ka, lalo na life skills, nadagdagan ang dingal mo. Ang respeto mo sa sarili mo na may alam ako paano buhayin ang sarili ko sa kabuhayan ng mahal sa buhay. Huwag niyo munang isipin na sagipin yung mundo. Isipin niyo na ang una mong sagipin ay ang pamilya mo. Okay? So next slide. That's the end of my slide. So we will be, I'll be doing some sort of a demo to you. No? So give me around 10 minutes and I will, 10 minutes break muna tayo, wiwi saglit. And I will arrange para ako ng lighting. Okay. Gagawa ako ng setup. Kausap. O Mario, andito na ba lahat?
Yes po.
Yeah, sorry ha. Baliktarin ko kasi yung hinanap ko yung tama. Okay. So in emergency inside the hospital, so solo responder. Sa tinuro sa atin, the method is compression. Sa atin hindi. The first thing is cover the airway. So paano gawin? In hospital. So it's either the patient comes in the ER or you are in the ward and suddenly the patient undergoes cardiac arrest, cardiopulmonary arrest. Okay. Ang first thing gawin mo is kailangan pinaka-minimum mo is level 3 ka. Level 3 so hanggang level 4. So, how do we do that? Okay, ganito yan. This is your non-rebreather mask. So, non-rebreather mask to, makikita mo siya, meron siyang mask at merong reservoir. Pag walang reservoir, it's a Hudson mask or plain face mask. In an emergency, it is always the non-rebreather mask. 1. Number 2, the oxygen must be emergency oxygen, not medical oxygen. Ang medical oxygen ay merong humidifier. So, ang hirap ng humidifier na mag 15 liters ka naka-humidifier ka, mahirap talaga yan. So, pinakamaganda, huwag ka munang gumamit ng humidifier. So, meron yung bypass or ano na siya na naka 15 liters. So, 15 liters, nakakabit yung dulo sa 15 liters. Kung wall man yan or ano, 15 liters. Sa 15 liters mo, ang delivery ng oxygen, akyat ka ng 80+%. Kasi ang oxygen natin 100 eh. Pag naka-nasal cannula, ang pinakamataas mo, mga 6 yan. Ang optimum mo, mga 3. 2, 3, yan. So wala na siya, parang hindi maganda ang nasal cannula mo hanggang 25% lang kanyang deliver sa 100 kasi makukuha masasagap ambient air eh. So may kanyang purpose yan. Sa emergency, wag kang mag-nasal cannula tapos nakunan ka ng video, pagtawanan ka sa buong mundo. In an emergency, it's always the non-rebreather at 15 liters. So, ang unang gawin, siyempre, naka-level 3 or level 4. Better, level 4 ka. Pag-address mo doon, tapik, sir. Pwedeng malapit. Pag sa hospital, pwedeng dalawa. Sir. Sir. Oops, unconscious pa. Patient unconscious dito. Pa-activate bed number 2. Male ward, bed number 2, activate code blue. Checking pulse, 6,000, 7,000. Bakit ako nag-6,000 o 5,000 ako mag-start? Kasi nung tinatawagan ko kayo para i-activate ang code blue, kumain na ako ng segundo doon. So you can start at 4 or 5 or 6. Okay? 6,000, 7,000, 8,000, 9,000, 10,000. Patient has no pulse. Ang tendency next is to do CPR. No. Kuha ka muna. Non-rebreather ka muna. Kuha ka ng mask. 15 liters. Lagay. Yan. Okay? So, sumisirit na dyan ang tinatawag natin around 80% plus oxygen. Pag plain mask yan, walang reservoir, kung wala ka talagang non-rebreather, okay, plain mask, but don't expect 80. Mataas dyan, mga 60% lang. So, kailangan mataas yung ating oxygen tension, oxygen concentration, para in the absence of it, habang nag-start ka ng CPR, during recoil, may pumapasok na 80%, mas mabilis mabuhay ang brain. Siyempre, mataas ang oxygen percentage. Ganun lang kasimple ang rasyonale. So, paglagay nito, nag-iisa pa lang ako, then I can start CPR. Okay? 1, 2, 3, 4, 5, 6, 7, 8, 9. Hinga. sige ka CPR, no? Kung ano naman, or insert backboard, mabilis. No? Kung walang backboard, pwede ka mag-CPR habang tumatawag ka na may backboard parating kung bawat ano ninyo. So case to case basis kasi may mga hospital beds na walang backboard on the side eh. So it doesn't mean you have to run for a backboard. Pwede ka. Hindi lang maganda ang CPR mo but you started hanggang dumating yung iba. Ganyan ang ating sequence. Kasi you don't like the delay. Kasi yung sinabi ko sa inyong time frame of 6 minutes, from 6 to 10 minutes in a tropical country, pahirapan yun. Sa non-tropical country, 10 minutes demarcation. Sa atin, 6 minutes demarcation. Ganyan. Kasi tropical tayo. So pag CPR, malalim lang, laliman mo lang kasi kinakain ng bed hanggang darating yung board. Insert the board, tuloy ka lang. What happens pag may kasama ka nang dumating? 2:1 na yun. Ngayon, nag-iisa ka pa lang. No? Eh by the way, nag-iisa ka. Kaya mo ba maglagay ng backboard mag-isa? Hindi. No? Hindi. So much delay. Bakit? Yayakap ka, boom. Slide yung backboard, pwede, delay. So 1, kung ang backboard available. No? Ang backboard mo hanggang dulo lang, pag ganun mo, at least may backboard ka na. So okay lang yan. An ideal backboard, mahirapan ka maglagay. Mag-isa. Ganun mo, lapit sa'yo. Naka 90 dapat. Pag 90, kunin mo. Paghiga mo doon, kukunin mo pa yung handhold, hilain mo pa ang pasyente. So ang pasyente, tatabingi pa konti yan. Para may hulmahan doon sa ulo. May hulmahan yun sa ulo. Para ang ulo niya, pag lagay ka ng nakaganon ang ulo. Kasi yung ideal backboard, meron siyang depression doon banda para lagay yung ulo mo. Para pag nag-airway ka, nakaganon na. Eh karami yung backboard sa Pilipinas, ginawa mo lang, bane of board talaga. Pag nag-backboard ka, huwag mo isama ang ulo. Ang backboard mo hanggang dito lang sa balikat. Para yung ulo, pag tanggal sa unan, ang ulo kahit papano, nakatingala na siya. Nakalapat doon sa ano. Ganyan ha, huwag mong i-backboard ang ulo. Okay? So, it's just okay. Yung iba, nagba-backboard ang ulo for the purpose, kasi hindi siguro sa more rigid konti, medyo so, okay lang yun. So, binabackboard ang ulo para mas malaro nila yung head tilt, chin lift. So, case-to-case basis. Pero kung sa tingin mo, karamihan naman kasi ng hospital beds ay matigas, so ang i-backboard mo ay yung ano lang, yung hanggang balikat. But depende yun kung paano mo siya nilagay kasi mag-isa ka. Kung hirap ka, kahit matigas naman ang hospital bed, huwag ka na mag-backboard. Galingan mo lang, laliman mo lang konti kasi darating naman yung kasamahan mo. So, yan ang point. Number 2, pagdating ng kasama mo, nag-CPR. Sige. Lagay ako ng tao-tao. Para ma-imagine yan. May taga-CPR na ako. Yan. Taga-CPR. Sa taga-CPR ha. So dito ako, ano ang klaseng pag ano ko sa BVM? So ang BVM ko, dapat kompleto. Valve, mask. Ang tawag nito BVM or ventilator. That's the name. Hindi tawag ambubag. Ambubag is the brand. No? So ang BVM or ventilator. So pansinin nyo, may apex, may base. Apex goes to the ilong. Okay? Ganyan. Ang particular ako na maraming nagkakamali dito sa Pilipinas ay the way they lock this. 1. Letter C. Letter E. Dito mismo sa dito ka mag-letter E. Huwag ka dito mag-letter E kasi hindi mabigyan ng hangin. Dito sa mandible rim, sa bone, huwag kang humawak dito sa soft part. Dito sa gilid. O, tingnan mo, letter C and letter E, pang mandible. Okay? And then up. Yan. Okay. Ngayon, dito ako. So the ideal valve map is the valve, the mask with a reservoir. Without a reservoir, defeated siya. Umaakit ako ng 90% dito kung nakakabit sa oxygen na 15 liters per minute. So, ang mangyari, tuloy-tuloy CPR, anong mangyari? Tanggal, huwag mong tanggalin. Tanggal si non-rebreather mask, palit si bag valve mask doon. Palit si bag valve mask. On! Tirit mo, sirit-sirit ang hangin, marinig mo, tapos hinay mag-inflate to. Para ka dahil COVID, level 4 ako. Ha? Huwag kang mag-airway na hindi ka level 4. Pagtanggal nito, tingnan ang tanggal ha. So, two things. Pagtanggal ito, hila konti. Taas. Yan. Tanggal, baba. Kailangan ang mask. Baba sa gilid. Baba. Away. Huwag mo kasi maraming aerosol dyan. Baba. Tapos lagay. Hayaan mo muna yung oxygen mag-flow. Wala ka pang posisyon. Gawan mo to na masecure to. Securing, walang dapat kakao. To, wala. Kailangan, yan yung ano mo muna. So tuloy-tuloy lang siya. Nakakount na siya ngayon. Okay, sir. Airway ready? 30:2. So yan ang command ko. 30:2. So lagay, tinapon ko na si book, tinapon ko na yan. C, E. Hawak. Dikit, no? And then, hawak sa ulo, iangat mo. Sakto na ganon. Ngayon, you don't like it kasi mapapagod ka, pwede ka maglagay ng Tootsie Roll sa ilalim mo, parang unan-unan, parang tumingala. Kasi pag hindi yan nakatingala, nakabukas yung esophagus niyan, ang hangin pupunta sa tiyan. No? May magkaroon ng insufflation, tapos pwede mag-decompress yung tiyan, susuka yan, lahat ng bumitos, may mga pupunta sa baga. You don't like it. So, hawak or pwedeng neck lift, dito ka sa neck, ipitin mo to, neck, angat. Ito, tuloy-tuloy yung oxygen. Kasi nagsi-CPR siya, liparan yung mga aerosol. Importante, pag nag-shift ka ngayon, ano kaagad to, para wala na yung aerosol. Mga bagong BBM ngayon ay mayroong filter for COVID. May filter. Para yung mga hangin na lalabas, sinasalo ng filter. May filter drum yan sila. Yun yung bago. So ready na ako. 1, 2, 3, 30. Pag 30, drive. 1, 2. Okay? So nakadistansya konti. 1, 2, 3, 4. Okay? 30. 1, 2. Okay? Sige, tira siya. Hawak ka lang. Kailangan doon sa lugar na nagko-cold blow kayo, lagyan niyo ng electric fan. Ang electric fan nasa side. Papunta doon. Para gumagawa siya ng wind corridor. May sasalo doon para yung hangin may palabas. Hindi kakalat sa buong ospital. Gagawa kayo ng wind corridor. Yan yung new normal approach. Or, maganda kung ospital niyo sana, lagyan niyo ng mga filter system na may mga exhaust na malakas. Parang sinisemay, negative natin konti. Para lahat higop lang ng higop pataas. Okay? So, saluin lang yun. Mayroong filtration system para hindi kumakalat sa ospital. Bawas na bawas yung mga microparticulates sa loob. So, 1, 2, 3, 4, 30. Ngayon ito, mapapagod. Ang kapalit niya ngayon is the third guy who will come. Walang palitan sa dalawa. Kasi pag nagpalit, pag bitawan ko yan, hindi naman niya nakadikit dyan eh. Bitaw yan, lilipad. So, yan yung pagbabago. Kung may papalit dito, it's either the drug guy or the electrical therapist. Okay? So, dumating na si defibrillator. Defibrillator, dumating na. Ngayon, sige, AED muna tayo. So, dumating si defibrillator, inon si defibrillator.
Adult patient. If the patient is a child, press the child button. Remove clothing from the patient's chest. Open packet and apply pads onto patient's bare skin. Apply pad.
Saglit. I'll answer the phone. Okay. So, ako lang muna nag-prepare. Pero assuming, i-ano ko na lang na may airway. I'm the third guy. So, to simulate, para hindi kayo malito, kasi nag-iisang tao lang ako. May airway ako, may compressor. No, what do you call this? No interruption compressor. Tuloy-tuloy lang siya, 30 to 30. So, here I am, defibrillator. Pag on sa defibrillator, assuming defibrillator meron kayo, ang marinig niyo, unit okay, apply patch. Okay? So may CPR dyan, hindi siya hihinto. Tuloy-tuloy lang siya. Gawan lang ng paraan. Now, dito ko i-apply. Dito ko i-apply. Kita niyo. Hanggang dito. Apply patch. Pero dito siya, para lang makita niyo. So, tuloy-tuloy compression. So wala kayong susundin hanggang tit. Ganun. So tuloy-tuloy ang compression, tapos dito lang ako, electrical therapist ako. Hintay lang ako ng command. Biglang sumigaw. Analyzing. Ako, may airway ha, ako yung electrical therapist. Okay guys, analyze, lahat bitaw. Anong mangyayari kay Bls-Acls-Phlebotomy? Si Bls-Acls-Phlebotomy dahil walang compression, hawak siya, papatayin niya ang oxygen. Patay oxygen. Okay? Kasi 100% yan, di ba? Apoy yan, apoy. Electricity yan. Kung mag-spark yan, impyerno tayo sa loob ng ER. Pero may oxygen 100% dito. Therefore, this is the time you may, so case-to-case basis, pero maganda, you may put it down away from it. Okay? Put it down. Okay? Distansya. Yung iba, malakas loob, hindi. Kasi by the time ng analyzing, tingnan nyo ha, analyzing, ang gagawin ng iba, hook, two, analyzing, stand clear, 3, winawas out ang oxygen. No? Pagpatay, iwawas out 1. Wala nang oxygen tumatakbo. 2, winawas out niyo yung 100%, 3. Yan, pwede yun. Walang problema yun. Yan yung mga adjustment natin. Huwag bitawan para it creates a cover. I'm more okay with that. Pero was out. Tapos, sisigaw siya. Analyzing, stand clear. Nakahawak ako, pero plastic yan, silicone, wala siyang conductor. So, I'm okay. Shock advice, stand clear. Ganun na ang defibrillator. Shock advice, stand clear. Si electrical therapist will start to shout. Okay, ganito ang shout niya. One and clear, nandito sa side, one and clear, titingin siya sa sarili niya, be sure na hindi siya nakatouch sa patient or sa bed. 2 you're clear, titingin sa airway. Pag tingin niya sa akin sa 2 you're clear, kailangan nakita niya na nakapatay oxygen ko at ang katawan ko ay hindi nakalapat. Okay lang to. 2 you're clear, clear, sisigaw ako, clear airway. Sisigaw siya, 3, everybody's clear. Titingnan niya si compressor sa kayong kamag-anak doon sa ulo, may kamag-anak nagpiling. Tayo, ako, including ako, at this compressor guy, sisigaw kami, clear! Pipindutin niyo yung shock button. So, lahat ng AED, mayroong button na kung saan may lightning. May lightning. Pag shock, gagano na pasyente. Sisigaw ang AED. Shock given. Continue CPR. Pag sabing shock given, continuous CPR, on sa oxygen, siya, dire-diretso, tira ka agad siya. 1, 2, 3, sabay ng pip, 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 so isa po, on, oxygen, C, C-clamp, E, angat, 30, 1, 2. So, ganun ang pattern. BLS pa kami, wala pang ACLS. Bakit? Kasi wala pang drugs na nag-intravenous or intraosseous ACLS. Okay? So that's how the evolution come in. So tatlo lang talaga ang ideal Kung may pang-apat dumating, yung pang-apat dumating, wala siyang maitutulong kung hindi palit kay compressor guy. Habang walang ACLS. Pero usually pag dumating yung pang-apat, siya na yung magbibigay na IV. So doon na tayo magta-traverse ito ACLS. Yun yung last part dun sa scope na BLS as bridge to ACLS. Kasi anything na may invasive ka, yun ang parameter ito ACLS na. Okay? Eh ngayon, anong part sa BLS ang airway adjunct? Oropharyngeal airway, different sizes. Nasopharyngeal airway, different sizes. I'll start with oropharyngeal airway. So may different sizes from 000 to 6. 6 pinakamalaki. Ito ay 5. 3 yata. Yellow is 2. Anyway, pag nagbigay ka nito, no need for, kailangan mabilisan. Okay? So pagbigay, hindi ganun. Ang ating objective is magiging ganun. Pag initially, you give it like this. So, ganyan muna. Pag 50% dun sa curve tube, ang tawag dito flange, bite area. Dito dapat ang ngipin. And this is the curve tube. This is the orifice, single orifice. This is your girdle. Yung Berman ay magaspang. Tingnan mo kung Berman. Wala akong Berman, but still an OPA, except na para siyang ang kanyang skeleton ay nasa gitna, tapos sa side yung mga daanan ng hangin. So this is more popular kasi mas medyo friendly look. Yung Berman parang ma-intimidate kayo, parang siyang stellate yung So paglagay nito, pagdating 50%, twist para to displace the tongue. Tingnan nyo ang kamay ko. Twist, alright. Alright. Oh, inserting. Kaya nang mag-announce ka. Inserting OPA, oropharyngeal airway. Because the dulo will reach the pharynx. Oropharyngeal. So lagay. Twist. Habang pag nag 50% twist to displace the tongue. Tapos lagay. So I have here an OPA. Now, you give OPA to a person who is totally unconscious. Because if you give this to a person who is half conscious, he's gonna spit it out. Masusuka yan. So, kailangan ang patient unconscious. So, inon ko yung electric fan to drive away the microparticles. I'm in full PP, assuming I'm level 4. Ngayon, ang pinakamaganda, ginagamit kahit sa semi-conscious patient is the NPA, nasopharyngeal airway. At dito ako sa OPA. Ano ang tamang sukat sa OPA? Dito sa corner of the mouth, hanggang sa lobule, yan po. Ganyan ang sukat. Isang sukatan lang si OPA. Insert, pag 50% twist, while driving, so that's it. Nasopharyngeal airway. Anong sukat? Sukat sa patient. Corner, sa lobule, no? Na naka-curve, huwag mong pilitin na i-scan. Kailangan mo siya yung kanyang factory. So, ganun. Okay? So, yan ang sukat. So, unang sukat. Pangalawang sukat, kailangan kasing laki ng 5th digit. Okay? So, paglagay nito, wag pa ganun. Wag pa ganun. Paglagay nito, pa ganun. Ha? Wag pa ganun. Pa ganun. So, hindi pwedeng ganun at paikot-ikotin, hindi. Diretso lang siya, straight. So, lagyan mo muna ng gel. Wala akong gel eh. So, lagyan natin ng gel. Paglagay ng gel, inserting NPA. So, medyo maganit, walang gel. So, sige, insert. Walang gel eh. So, this is your NPA being inserted. Ganito yung forma niya. Yan. Okay? So, whether it's ito or ito, dapat isa lang. Then you can have your BBL. So, mas patent na yung airway ko. Mas patent na. So, another thing is, this is simply temporary before you do your advanced. So, advanced pwedeng endotracheal tube with laryngoscope, or you can do supraglottic with your laryngeal mass airway, with your combi tube, with your King LT. Okay, King LT. So, yeah, okay? So, that's how you do it. Now, going into CPR, what is your out of hospital setup? So, sa out of hospital, always consider all patients to have COVID. So, rule number 1, consider everyone to be COVID. Rule number 1C, the 10 C's. Number 2, pakilala ka. I'm Juan de la Cruz. Nurse po ako, baka po ako makatulong. Sino mga kasamahan nito? Sino mga kilala? Okay. So ngayon, maganda kung meron kang bitbit na gloves, part of your EDC, everyday carry, saka extra sa bag mo, na meron kang mask, laging ganun. Ako sa laptop bag mo, may extra mask ako, A95 saka surgical. All my bags have extra mask. Merong first aid. Ang tawag doon EDC. Everywhere I go, merong EDC at example. So this is my laptop bag. Siyempre, ang laptop ko nandoon. Ginamit ko eh. So wala nang laptop. So, yan. Yung wipes. A95. Yung tatlo ng A95 pala. Surgical. So, part of my EDC, kasama alcohol. Pangit naman wala kang everyday care, tapos nurse ka pa naman, o doktor ka, tapos parang unlikely. Dapat, you have to be ahead of the game. Siyempre, may headlamp ako. Kung sa gabi, may headlamp. Para may... toothbrush. So, yan. Dito sa loob, yung mga essentials ko. Yan. Sat phone. Kasi I have a crucial job eh. Kaya may sat phone. Satellite phone. GPS. So, ibig sabihin, meron akong compass. Compass. Weather tracker, laser finder. Para magtawag ng aeroplano, helicopter kung sa laser finder yun. Wala ng battery. Ewan ko kung wala ng battery. So meaning, lagi akong may everyday carry na bagay, like the mask, kasama na. Of course, first aid kit. Balik ko lang. Meron pa nga akong scissor, tourniquet, yan, kasama sa first aid kit. Scissor. Leatherman scissor. Leatherman. So, meron akong pasyente, merong bumagsak na I have to address. So, number one, consider everyone to be COVID positive. Number two, check in. Nurse po ako, baka po ako makatulong. 3, maraming isusero, crowd control. Sir, pasuyo po, pasuyo, traffic, distansya po. Sa mga kung may kilala dito, sana po, paano patawag kung sino nakakilala dito. Okay. Bigyan niyo po ako ng air. Please, sige, bilis po, bilis po. Tapos sa may tapik. Tingnan mo ang tapik ko. Tingnan mo yung distansya ko sa pasyente malayo. Huwag akong magtapik ng dalawa. Malapit ako. Tapik ako, malayo. Sa right to the patient, right ko. Ang tawag doon, the right to right. Yan. Wall na kasi. Right to right. Okay. Sir. Hindi dati dalawa. Ngayon, isa lang. Sir. Then trapezius pinch. I-pinch mo siya to ascertain the pain stimulus. Masakit po yan. Kung i-pinch niyo sarili niyo, hindi kinasaktan. Pero subukan niyo mag-pinch ng ibang tao. Ito, pinch. Trapezius muscle po yan. Trapezius muscle. Yan. Yan yung muscle na kung may torticollis ka, yan yung parang stiff neck, no? So pag i-pinch mo yan, kung may kasamahan kayo, subukan mong i-pinch. Huwag purot ha, huwag magpurot na ganyan. Hindi ganun ha. So, ganun. Yan ang trapezius pinch. Masakit yan, subukan nyo ngayon. You check it out with your comrade, kasama mo sa work. So, ulitin ko, right, nasa right ako ng pasyente, so right to right. Sir. Trapezius pinch. Wala po siyang malay. Walang malay. Okay, the next C, call for help. Pasuyo po ikaw, Blue, pero nurse or doctor po, yung kamay ko, naka-check sa carotid. You have to remember, kung nasa right ka, sa right carotid ka mag-check. Kung nasa left ka, sa left carotid. So, ganun lagi. Huwag kang mag-validates na pabalik ko ang check. Or, kung nasa left ako, huwag kang mag-check sa right. Parang, baka mabasa ng community, baka sinasakal mo. Paluin ka nila. So, nasa right ako, check sa right. So, paglagay ko dyan, sabay call for help. Okay? Sir, pasuyo pa ako. Ikaw naka-blue. No, pasuyo po ako ng ambulansya. Or tanod. Tawag kayo ng tanod. Ambulansya, tanod. Balikan niyo po ako. Balikan niyo po ako. Para malaman ko na they are doing something. Doon sa mga, Sir, pasuyo po. Tawag na ambulansya or tanod. Balikan niyo po. 6,000, 7,000, 8,000, 9,000, 10,000. Wala po siyang pulso. Okay? Wala po siyang pulso. Anong next? Next C. Cover the patient. Mabilisan. And kung pwede, yung head niya tilted away from it. Kasi ang isang tao, pag nakalay on the ground, pag dead weight siya, it's either nakaganon siya o nakaganon. Walang tao na nakastraight ang ulo or else hindi yan unconscious. Okay? Then ang dead weight is either nakaganon ka or nakaganon ka. Okay. So, yan. So, nakakabit. And then, kilikili, punta sa gitna. So, it's either you interlace or you do like this. Wala akong pakialam. Basta importante, I can achieve a 120 no less than per minute or a 2 to 2.4 inches depth and adequate liquid. Okay? Ganun kabilis. 3, 4. Tuloy-tuloy. After 2 minutes, no? Kung malaman mo, hinga malalim, check ulit. Biglang, pag gano'n mo, biglang may dumating AED. Tuloy lang ng AED. Paglagay ng AED, sige tuloy, lagay. Okay, tuloy. So, depende sa klase sa AED. May AED na puro pads, may AED na mayroong sensor sa gitna. Pag may sensor sa gitna, kunin ng sensor, sagay-lagay, tapos lagay yan. Okay? So, ganun lang. Now, when do I start to follow AED? Pag mayroon ng metronome. Undress the patient. Undress na nga sa ibabaw eh. Call for help. Huwag ka call for help. Tuloy-tuloy lang. Biglang siya. You start CPR. Beep, beep, beep. So 2 minutes yun. Tuloy-tuloy mo lang 2 minutes. Analyzing. Bitaw. Nag-iisa lang ako ha. Stand clear. Shock advice. Stand clear. Shock advice. Biglang pupula yung sa defibrillator. Yung pupula. Okay? So, shock advice. Okay? Sisigaw ka. Clear ha? Lahat clear. Huwag ka lang yung 1, I'm clear, 2, you're clear. Wala ka namang airway ganyan. Okay, everyone clear? Wagawa, okay, pindot. Titingin ka rin sa paligid. Baka kung anong may mga, other things na might be trouble. No? So, pindot, boom, shock siya. Shock given. Continue CPR. Continue CPR. So, continue ka ngayon. Tapos, habang nag-continue ka, kaman ka ulit, may tumawag na mga ambulansya, pasuyo naman ako, tanod o ambulansya o sino nakakilala nito. Tuloy-tuloy ka lang. Analyzing. Bitaw ko ulit. Until the help will arrive. Okay? Now, I'm not asking you become Superman. What if you get exhausted? Tapos ka talaga. Okay? Assuming kako-COVID mo lang. Or na-COVID ka, na-destroy yung lung mo, hindi ka na kasintibay noon. Papagod ka. Pwede kang tumawag. Sino marunong? Sino baka dito meron? Patulong ako. Pagod na po ako. Pwede mong pagod na po. Okay? Sige. Tapos lapit. Sige sir. Pwedeng dito ka. Sige. Gayan mo ko. Sige. Paglapat ng kamay niya, ilapat mo muna yung kamay mo. Sige sir. Sige. Sige. Guide mo muna siya. Sige. Pusat mo ulo. Ilayo mo. Center mo. Layo sa kanya. Sige po. Sige. Fine tune. Sige sir. Good. 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 Salamat po. Hindi ka malalim. Palayo. Okay? That's good. Meron ka ng kapalit. Tuloy-tuloy lang siya. So, anong meron ka sakit? Alcohol ka. Kuha ka. Tapos tawag ka. Pero wag mo siyang iwanan. Tawag ka ngayon, distansya, tawag ka ngayon. Or sino kakilala nito? Huwag ka doon sa side niya, dito ka sa harap mo. Ganyan ang approach sa hospital. Huwag mong suluhin yan. Okay? So, your BLS, the complete package of it is, once you execute, ito yung compression style. Pag sa bata naman, merong
adult patient. If the patient is a child, press the child button. Child patient.
So may mga
Remove the child's shirt. Open packet and apply pads on the child's bare skin.
So may mga AED na yun na intended for child. Si mas low joules siya. No? So yan yung mga bago, yung mga luma, wala. So kaya minsan nakakailang magbigay ka sa child 8 years below ng AED. Hindi talaga tayo halos mag-AED, lalo na infant, kaya hindi ka mag-AED. Puro ka lang. So sa child, pwedeng isang kamay, tapos ang ulo, hawakan mo sa neck para nakatingala, para habang nagre-record ka, bumabalik yung hangin. Same okay, same pa rin, lagyan mo ng mask. Kasi hindi naman natin kung hindi mo kakilala. Pero kamag-anak mo or kasama mo sa bahay, God forbid, ayan, wala ng mask. Siyempre, pareha kasama mo sa bahay. So, ganun lang. Pag sa infant, ganun lang mabilis. Hawak, kung kaya mo maghawak, hindi ako nagdala ng baby. Pag hawak mo, call for help, sumigaw ka. Sa platform, pwede. Pero kailangan moving ka. Sasakyan, pakiprepare sa sasakyan. Sige ka lang. Ngayon, pag buga ng hangin, no? Pag buga ng hangin, kuha airway, buga hangin. Yung ilong breathe kasama. Yan. 1, 2, 3, 4, 5, 6, 7, 8. Okay? Kasi single rescuer, 30 ka muna. Single rescuer, 30 is to 2. Pag hindi ka makakompress, dahil tuloy lang yung higa. Yan yung mga variation. Pasok ka sa yan, hindi ka pa muna makakompress, pero pag ginagawa, Okay. Safety ka pa. Ganun. Tuloy. Pagod na. Kuha. Yakap. Ikot. Ikot. Dito. Hulog. Lagay ulo. Compress. Ipalabas. Maganda pag malaking tiyan mo. Ipalabas mo yung pata. Ganun para hindi nalay. Ganito ang style. Yan. Ulo. Okay. Yan. Tapos nag-compress ko. Okay. Kapagod din yan, ha? Laylay yung dalawang paa. Yung isa pa nasa loob ng dito, sa doon. So yan ang pag-compress. Kailangan moving. Hindi pwede naka-static ka. No? Kailangan moving. Moving ka. Bitbitin mo siya, moving ka. Kasi moving is survival. Okay? Yan ang lamang sa bata. Pwede ka papunta sa garay. Insta ka, sige, tuloy-tuloy ka. Move. Bilisan. Yeah. Okay. Saan ka nakaposisyon? Sa harap, sa likod? Likod. Nakaporma ka kasi pag napagod ka, pwede mo ilagay saan luhod ka doon sa kapakan, nakaganon ka doon sa upuan, sa likod. Ganun ka. Tapos, open, move, habang papunta sa ospital. Okay? That's the pre-hospital. Pag sa loob ng ospital, sa bed, ibabaw mismo buong katawan sa ibabaw ng cardiac wall. Yan. Mabilis. Ganyan kabilis, oh. Ang double rescuer, 15. 1, 2, 3, 4, 5, 6. Tapos ang hawak sa BBM, dalawang kamay. Pwedeng isa mag-drive, or kung nag-iisa ka lang, ganun din, mas madali hawakan, mas soft ang ano. So yung maliit na BBM natin, bagwag, mas 1, 2, tira. Ang ating BBM, 30:2 synchronous. Pero kapag naka-intubate ng pasyente sa advanced cardiovascular life support, which some of you will undertake it tomorrow, asynchronous na siya. So straight to 140 for 2 minutes, o depende sa team leader niyo. Tapos ikaw, drive ka, ganito yan. Assuming na meron na akong heart rate, airway lang yung problema ko. So, angat, 1, 1,000, 2,000, 3,000, 4,000, 5,000. Drive, 1,000, 2,000, 3,000, 4,000, 5,000. Drive. Yan. 3,000, 4,000, 5,000. Drive. So habang bago kong drive, kailangan nakaangat siya para walang insufflation of your stomach. Okay? So yun ang ano natin. Yun ang style natin. Okay? So, yan. So bago tayo mag-lunch, foreign body airway obstruction. So foreign body airway obstruction people, the patient will have usually hawak one or hawak isa, kakapa, hilot, gano'n siya, hindi siya tulong. Hawak sa leg niya isa, hawak sa leg niya isa. Usually ito, hindi gano'n. Hawak yan. Sense of doom. Yan. One thing. So, how do we know? Okay, number 1, there's partial obstruction with good air entry. So, facilitate coughing. Bigyan mo ng sequence ng coughing. So, ano ibig sabihin? Sir, you cough. Ubo po. Iubo mo. No? Tapik mo. Iubo mo siya. Sige, sir. No? Kasi merong stridor. Ganun, no? So, you facilitate coughing. Sir, ubo po. Iubo nyo. Ubo niyo po, sir. Tapik sa likod. Sige, sir, ubo. Dito ka. Kasi COVID, dito ka sa side. Huwag ka doon sa harap. Sige, sir, ubo. Tayo. Pag may mask, let him wear the mask. Baba sa nose. Choking yan eh. Mag-feel siya ng sensation na para siyang nag-choke, so ibaba mo sa nose. Okay? That's your pre-hospital way of doing it. Okay, sir. Okay. Cough. Inhale. Pag inhale, huwag mabilis. Inhale. Hinay. Inhale. Kasi nandiyon yung na-choke siya. Biglang, balik ulit yung choke doon sa sa airway. So, hinay. Inhale, tingnan dito. Tapos, tapos hinay. 2, tatlo, inay ha. 3 seconds, inay. 1,000, 2,000, 3,000, pick up. Yan, facilitate cupping. So, yan yung with air entry. If the patient goes into partial obstruction with poor air entry, prepare, facilitate cupping, and then you can back slap at in between the two blades of the scapula. Two blades. Pag slap mo, i-create ka ng kanal dito kasi dito dadaan ang spine. Huwag mong i-slap ang spine. Don't uninsult. So ang slapping should be like that. Tingnan niyo po. Yes sir, sige. 2, 3, 4, 5. Okay, gano'n. Sige. Kakapa na siya. So minsan aabutin ka niya sa likod. Assuming siya sa likod ko. Siya yung tumutulong sa akin. Siya yung tumutulong sa akin. Aabutin ko pa yan. Aabutin ko siya. Ganun ako aabutin ko. Normal yun. Sense of doom yun. Sense of doom. So prepare mo na. Kung talagang nakikita mo manghihina siya, i-prepare mo na habang nakatayo. So anong mangyari? Yung isang paa mo, ito paa niya. Yung isang paa mo, i-prepare mo na lagay dyan sa gitna. Kasi para pag na hilo siya, hindi mo siya kaya, pwede mo na siyang ipa-slide. Pa-slide mo siyang ganun, slide hanggang malagay sa floor. Kasi pag hindi mo gawin yan, tapos lumaylay siyang ganyan, tapos pag medyo mabigat yan, sub-sub kayong dalawa. Or dahil ayaw mo sub-sub, bitawan mo, dive siya ngayon sa semento. Nako, nasaan yung primum non nocere? Pero bog, dive siya. So, kailangan paghirap ka na, ilapit mo siya sa'yo. Tapos hayaan mo, mag-slide siya para mahiga na. Habang papunta ka doon, para hinay-hinay siya, gumaganon papunta sa wall, papunta sa floor. Okay. Ngayon, medyo hirap na. Tapos kikita mo, poor air entry. Progressing into total blockade. Or, bisip nakita ko, hindi talaga makahinga, total blockade, wala kang, ganun siya. Position to the back. So, ipaas ko lang para makita nyo. Xiphoid process or xiphoid process. Create like this. Ganun. 45 degrees going up to the scapula. Ganun, no? Sir, 1, 2, tingin ha, 3, 4, 5. Sige, sir, sige. Sir, muna, pwede mo sir. Wala. Kasi ako control pa. Kapa pa siya. Ulitin ko sir ha. 1, 2, 3, 4, 5. Yan. Sa bata, ganun din. Sa infant, ganun din. Backslap, pa. Ganyan, pero chest compression. 1, 2, 3, 4, 5. Tingnan ko. Pag lumabas, sweep. Huwag kang mag-sweep na hindi mo nakikita. No blind sweep. Okay? What if the patient is on the ground? Wala na. Do I have to perform abdominal thrust? 2 schools of thought. 2 famous schools. Merong okay pa rin sa abdominal thrust, pero ang pinaka-trusted ko talaga is chest compression. Pero ganito yan. Pag nakita mo, pasyente mo, biglang bumigat, wala na. Meron pa rin yung pulso. Wala na yung hininga, pero may pulso. 3D pulse yan. Papunta na yan sa cardiac arrest. So, ganito ang gawin natin. Nihiga ko na. Higa na. Pag higa niya, sir. Gagano siya. Parang merong mga twitching pa yan konti. Gano'n yan. Walang malay. Sir. Wala. Doon ka na mag-emergency response. Pasuyo naman ako. Pero pagkapa mo, meron ka pang maramdaman. Pero kailangan keen ka. Bakit? Habang nag-a-address ka ganyan, pag hindi ka sanay, ang pulso mo bumibilis. Baka ang nakuha mo pulso mo. Tandaan yan. Lalo na pagka mag-anak mo yan, talagang kabahan ka rin. Baka akala mo, may pulso naman. Hindi niya pulso yun. Pulso mo yun. Tarantahin ka rin, no? Kailangan deep breathing ka. Check mo. 6,000, 7,000, 8,000. Walang pass. All compression ka muna. pero nakatingin sa bibig. Bigla, gumanon siya. Kuha ang balikat, lagay, hila ang tao, sabay sapit sa likod. Sige, sapit na. Ganun siya. Yan, ha? Sabay hila at papik, nakalapit sa iyo. Okay, so ganito. So, bumagsak na, dito ka. Call for help ako, wala. So, start ako si Kuya. Tingin ako. Usually, pag may blockage yan, maganda pag ano, kung luluwa yan talaga. Pag luwa niyan, automatic ang tao magre-regain consciousness. And pag nag-regain consciousness, ang tendency niyan, susuka. Ang taong unconscious, hindi yan susuka. Ang taong conscious lang susuka. Pero kailangan mabilis kasi wala siyang control. Pag sumuka, ang next episode niyan, higop, kung mabagal ka mag-recovery position. Tapos, pag ganun mo, side, tabi, sige, suka, ganyan, apik mo. Ganun ang style. Okay? So that's how you will perform sa choking management. Okay? Same sa bata. Now, how do you perform recovery position? So recovery position is performed in this manner. Man, pasuyo nga ako. Ikunan mo ko. Kunan mo ko. Saglit lang. Iganon mo ako. Kunan mo ko. Makikita. Kailangan makikita ko. So, siya yung rescuer. Buong natawan ko. Siya yung rescuer. So, nasave na niya ako. Okay na ako. So, huminga na ako. So, recovery position. The recovery position should be towards the rescuer. Iaangat niya ang kamay ko. Isa, one. Kukunin niya to. Two. Pagkuha niya, huwag niyang bitawan. Kasi pag bibitawan niya, babalik mo. Pagkuha ha, yan ang mali. Sa ibang turo. One, bitawan mo. Bitaw na. Ganun na. Two, hawak dito. Then, yung kamay niya ng tanan, kukunin itong ilalim. 3. Tapos, kanan kamay, kaliwang kamay, papuntahin niya ako doon. 4. Ganyan ha. Ganyan na recovery position until help arrives at ambulance. Pag return to spontaneous circulation. Okay, so ulitin ko. 1, 2, nakahawak ang kaliwa. Scoop ng kanang kamay niya, kanang kamay. 3, sabay dalawa. 4. Para kailangan to, para touch mo, kasi pag wala to, susubsupan mo nga sa simento. So ito, unan, para yung spine ko, somewhere sa nose string. Okay? So, yan ang important. So, alam mo yung mga secretion, tutulog ito. Okay? Ngayon, dropping, nalulog ang tao, kakaiba yung CPR. So, CPR ko, bug. May damit ako, bigla, pag sumuka ako, ilagay yung damit ko mabilis. Ganun, sabay pakik sa likod. Para hindi ko ma-aspirate. Kaya wala akong damit. So wala siyang hilahin. Pwede niya kunin ang kamay ko. Ito yung kamay niya. Pwede niya kunin ang kamay ko. Ipatong niya sa kamay niya. Tapos yung isang kamay niya ipatong. So therefore, ako nakaganon sa kanya. So habang sinisipera ko, yung kamay ko nandito. Bigla ako sumuka. Ganon. Ang gagawin niya, hilahin na niya pataas. So magiging meron na. Habang isang kamay tumatapit sa likod. Para hindi ako maka-aspirate. That is an adjusted CPR for drowning. So wilderness medicine na. So isa kasi problem kapag sa drowning is always the number 5 issue. Number 5, which is the aspiration of vomitus. Pag nag-aspirate ng vomitus yan, malaking problema natin dyan. So there is another style of performing CPR in a drowning case. Yan. So isa yun, mga maneuvers in doing CPR. Okay? So now it's 12. Balik tayo 1 because I'm gonna teach you first aid. So take your lunch, okay? So see you at 1 o'clock. Mga tanong nyo, mamaya na lang 1 o'clock.
Thank you po.
Engine 105 en route to 50 Wheeler Road.
Copy engine 1 en route to 50 Wheeler. Update on patient, 60-year-old male. Bystander CPR is in progress.
Copy. CPR in progress.
Go ahead and set your phone down, put me on speaker.
Hold on.
Okay, can you hear me?
Yes.
Okay, let's get him flat on his back. I'm going to tell you how to do CPR. Okay, I want you to put one hand on top of the other, right in the center of his chest.
Okay.
We're going to pump the chest hard and fast, at least 2 times per second and 2 inches deep. We're going to do this 600 times or until help can take over.
Okay.
This is the pace that I want you to do. It's 1, 2, 3, 4.
Dispatch.
1, 2,
LFA Command 2 en route. I'm mobile and nearby. ETA 1 minute.
Cardiac arrest is the loss of the heart's ability to pump blood through the body. The most dramatic occurrence, sudden cardiac arrest, can happen anywhere with little or no warning. Victims unexpectedly collapse. Breathing stops. Sudden cardiac arrest occurs when the normal electrical impulses in the heart suddenly become disorganized. Normal mechanical contraction of the heart muscle is lost, and a chaotic quivering condition known as ventricular fibrillation can occur. Blood flow to the body, along with the oxygen it carries, abruptly stops. Within minutes, brain cell death starts to occur from the lack of oxygen.
Fire department! In here! We're in here! Hurry!
Okay, let me in here.
Okay, thank you.
Sir, are you okay?
Confirmed cardiac arrest.
Cardiopulmonary resuscitation, or CPR, is the immediate treatment for a suspected cardiac arrest.
14, 15.
CPR can restore limited oxygen to the brain and other vital organs through a combination of chest compressions and rescue breaths. However, CPR alone is not enough.
1, 2, 3, 4, 5, 6.
The most
7,
effective way to end fibrillation is defibrillation, using a defibrillator and electrode pads adhered to the chest. A controlled electrical shock is sent through the heart to stop ventricular fibrillation, allowing the heart's normal electrical activity to return and restore the normal pumping action of the heart. Successful defibrillation is highly dependent on how quickly a shock can be delivered. For each minute in cardiac arrest, the chance of surviving goes down by about 10%. After as few as 10 minutes, survival is unlikely. An automated external defibrillator, or AED, is a portable, computerized device that is simple to operate. The use of AEDs by emergency responders and other healthcare personnel allows defibrillation to occur much earlier than before. Turning on an AED is as simple as pushing a power button. Once on, an AED provides voice instructions to guide an operator through its use.
Apply pads to patient's bare chest.
19, 20, 21, 22.
An AED automatically analyzes the heart rhythm to determine if a shock is needed.
Stay clear of patient. Analyzing.
If a shock is advised by the AED,
Shock advised.
Everyone clear?
the
Clear
operator
the shock
clears the person
now.
and pushes a button to deliver the shock.
Shock delivered. Begin
Immediate
CPR.
high-quality CPR and early defibrillation with an AED can double or even triple the likelihood for survival. Most cardiac arrests occur outside of a hospital. Most of those occur in the home. The chain of survival is often used to describe the best approach for treating cardiac arrest. Each link in the chain is essential for a person to survive. If a single link is weak or missing, the chances for survival are greatly reduced. The greatest chance for survival exists when all the links are strong. The chain of survival for cardiac arrests outside of a hospital consists of 5 interdependent links: early recognition of cardiac arrest and prompt activation of the emergency response protocol for the setting, immediate CPR with high-quality chest compressions, rapid defibrillation or electrical shock to the heart, effective basic and advanced EMS care and transport, and effective post-cardiac arrest care at a hospital. Cardiac arrest inside a hospital usually occurs when a known medical condition worsens. The chain of survival inside a hospital reflects how resuscitation fits into the overall picture of medical care: monitoring, prevention, and treatment of pre-arrest conditions, early recognition of cardiac arrest, and prompt activation of the emergency response protocol for the setting, immediate CPR with high quality chest compressions, rapid defibrillation or
Engine 2312, dispatch.
Engine 2312.
I have an update on patient condition. Caller reports patient was caught in a fallen tree and submerged for several minutes. The patient is now out of the water, and we're attempting to get bystander CPR initiated now.
Copy, dispatch. Engine 2312, on scene now.
Copy 2312 on scene.
He got caught up on a strainer. I just got him out.
Sir, can you hear me?
Unlike sudden cardiac arrest, in which the heart is the primary problem,
No pulse.
cardiac arrest can also be the end result of a blocked airway or loss of breathing. This is known as secondary cardiac arrest.
Apply pads to patient's bare chest.
Problems such as hazardous breathing conditions in a confined space, drowning, and drug overdoses are all causes of secondary cardiac arrest. With no incoming oxygen, the heart progressively becomes weaker until signs of life become difficult or impossible to assess.
Stay clear of patient. Analyzing. Stay clear of patient. No shock advised. Begin CPR.
Medic 849, engine 2312.
If the heart is simply too weak to create obvious signs of life,
Cardiac arrest.
immediate CPR with an emphasis on effective rescue breaths may be the only chance to restore them. The abuse of opioid drugs is a serious and growing health problem. Increasing prescriptions for opioid pain relievers such as hydrocodone and oxycodone have made them more commonly available. The increased availability and use of heroin, a highly addictive opioid, is also contributing to the problem. As a result, overdoses and deaths from prescription opioids and heroin have risen dramatically. Opioids taken in excess can depress and stop breathing. Opioid overdose is a common cause of secondary cardiac arrest. Suspicion of opioid use may present itself through questioning of bystanders or by observation of the person and location in which she was found. Naloxone, also known as Narcan, is a medication that can temporarily reverse the life-threatening effects of opioids. It's easy to administer, either through an auto-injector device or through an aerosol that is sprayed into the nose. Initiate and establish BLS care prior to
Can you hear me? Hello? Hello? Command, this is Engine 105.
This command, go ahead.
We have a child in cardiac arrest at our location. We need a medic unit right away.
Copy that.
Children are more likely than adults to experience secondary cardiac arrest due to an airway or breathing problem. When describing age groups in relation to CPR, an infant is younger than 1 year of age. A child is 1 year of age until the onset of puberty. Puberty can be identified by breast development in females and the presence of armpit hair in males. A person is considered an adult after the onset of puberty. The chain of survival for children and infants emphasizes prevention and giving effective rescue breaths as part of CPR. Prevention of airway and breathing emergencies. Early CPR with an emphasis on effective rescue breaths, and if needed, defibrillation with an AED. Prompt activation of the emergency response protocol for the setting. Effective basic and advanced EMS care and transport, and effective post-cardiac arrest care at a hospital. The quality of CPR matters. Higher quality CPR performance is directly related to an improved chance of survival. There are two key elements of high-performance CPR: high-quality CPR skills and a more efficient team approach to resuscitation. CPR skills can vary greatly depending on a person's experience, practice, and physical ability. It is normal for there to be a gap between perfect skills and what you can actually perform. An important goal is to narrow that gap as much as possible. High-quality CPR skills include beginning CPR compressions within 10 seconds of determining cardiac arrest, compressing fast at a rate of 100 to 120 times per minute, compressing hard at least 2 inches on an adult and at least 1/3 the depth of the chest for children and infants, allowing for complete chest recoil at the top of each compression, minimizing interruptions to compressions, giving effective rescue breaths that create a visible chest rise, and avoiding excessive air on rescue breaths. CPR feedback devices that measure skill performance in real time can be used to optimize CPR. High-quality skills are only part of high-performance CPR. Orchestrating the actions of a resuscitation through a team approach, much like a pit crew in a car race, can significantly improve the care being provided. An effective team approach has clearly defined roles, uses clear and effective communication, allows multiple treatment actions to occur at the same time, maintains high-quality CPR by allowing team members to switch places when tired, and minimizes overall interruption times. The only way to develop a high-performance CPR approach is through ongoing commitment and practice. CPR skills can deteriorate significantly in as little as 3 months. Shorter, more frequent, scenario-based retraining sessions are reasonable for maintaining skills for individuals likely to respond to a cardiac arrest. Emergency situations often present hazards to your safety and health.
He's over there. He was mixing chemicals and fell.
Okay.
Your personal safety is the highest priority, even before the safety of an ill or injured person.
Go and get hazmat on. Tell them we got 1 man down as an unknown chemical.
Putting yourself in danger to help someone can make the situation worse. Always pause for a moment before approaching. Look for obvious hazards. Consider the possibility of hidden dangers. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. When caring for someone, you can be exposed to blood or other potentially infectious body fluids. While the risk of contracting a disease is very low, you must take measures to reduce exposure. The most common infection bloodborne diseases and pathogens include hepatitis B, hepatitis C, and HIV, the virus that causes AIDS. Standard precautions is a set of protective practices used when providing care, whether or not an infection is suspected. Personal protective equipment, or PPE, describes protective barriers worn to prevent exposure to infectious diseases. Reducing exposure lowers the chance of infection. Disposable gloves are the most commonly used barrier. Make sure they are readily available and always use them. To prevent direct contact, use a CPR mask with a one-way valve when giving rescue breaths or a bag mask device to prevent direct mouth-to-mouth contact. Unprotected mouth-to-mouth rescue breaths should not be given by emergency response personnel. BLS providers and the locations in which they work vary. So does the way in which they activate a response for higher levels of care. Activation is typically defined by emergency response protocol. A BLS provider or member of a workplace emergency response team may radio a centralized communication person to contact EMS, or the provider may call EMS directly. An EMS provider may request help from advanced care providers or inform other incoming responders about the details of the situation found. Inside a hospital, a floor nurse may call a code to which a resuscitation team with appropriate equipment will respond. To be an effective BLS provider, you must understand your local protocols on how to call for additional help. The quality of CPR skills can be improved during practice with the use of a real-time feedback device that measures things such as compression depth, compression rate, and overall timing. Real-time feedback allows a user to make ongoing adjustments to maintain and reinforce high-quality skills. The Loop learning system is designed for CPR skill practice. The Loop feedback device is placed directly on a mannequin chest. Compressions are done normally on top of the device. A Loop software program allows a user to set up timed sessions in which the Loop system provides real-time visual and recorded measurement of chest compression rate and depth. Compression rate can be easily seen at the top of the screen. Adjust your compression rate to keep it in the green area. Compression depth is measured across the bottom of the screen. Compression spikes that are green indicate a compression that is ideal. Red spikes indicate a compression that is too shallow. Watch your performance in real time on a computer screen and make adjustments as necessary. The Loop software also records your performance and allows for overall review after finishing a session. There are basic CPR skills used to provide the most effective approach to cardiac arrest. These include high-quality chest compressions, high-quality rescue breaths using a CPR mask or bag mask device, use of an automated external defibrillator, and checking for life-threatening emergencies using a BLS assessment. External compression of the chest increases pressure inside the chest and directly compresses the heart, forcing blood to move from the chest to the lungs, heart, brain, and the rest of the body. To perform proper compressions, the person needs to be positioned on his or her back on a flat, firm surface. Kneel close to the side of the person. Place the heel of one hand on the center of the chest on the lower half of the breastbone. Place the heel of your other hand on top of and parallel to the first. Bring your body up and over the chest so your shoulders are directly above your hands. Bending at the waist, use your upper body weight to push straight down to a depth of at least 2 inches. Lift your weight and allow the chest to fully return to its normal position. Move immediately into the downstroke of the next compression. Focus on high-quality techniques. Compress deeply more than 2 inches. It is likely you will not compress deep enough. While injury could occur from deeper compressions, do not let the fear of this affect compression depth. Compress fast, between 100 and 120 times per minute. Do not let a higher compression speed result in a shallower compression depth. Do not lean on the chest between compressions. Blood pressure is created and maintained with ongoing compressions. When compressions stop, pressure is quickly lost and has to be slowly built up again. Allow the chest wall to fully recoil or rebound at the top of each compression. Minimize interruptions when doing compressions. When compressing properly, You may hear and feel changes in the chest wall. This is normal. Forceful external chest compressions may cause chest injury, but are critical if the person is to survive. Reassess your hand positioning and continue compressions. As an alternative approach, you can grasp the wrist of one hand with the other when it is difficult to compress with the heels of both hands. To perform chest compressions on a child, position the child face up on a flat, firm surface. Place the heel of one hand on the lower half of the breastbone, just above the point where the ribs meet. Using upper body weight, compress at least 1/3 the depth of the chest, or about 2 inches. Lift your weight and allow the chest to return to its normal position. Without pausing, continue into the downstroke of the next compression. Continue compressing at a rate of 100 to 120 compressions per minute. Remember to compress fast and deep and allow the chest to recoil to its normal position at the top of each compression. Compressions on a larger child can be tiring. If needed, use 2 hands to perform compressions. To perform chest compressions on an infant, position the infant face up on a flat, firm surface. Place 2 fingertips on the breastbone just below the nipple line. Compress at least 1/3 the depth of the infant's chest, or about 1 1/2 inches. Allow the chest to return to its normal position. Without pausing, continue into the downstroke of the next compression. Continue compressing at a rate of 100 to 120 compressions per minute. Remember to compress fast and deep and allow the chest to recoil to its normal position at the top of each compression. When doing chest compressions with 2 or more providers, encircle the sides of the chest with your hands and use your thumb tips to compress the lower third of the breastbone. Rescue breaths are artificial breaths given to someone who is not breathing. They are given by blowing air into the mouth to inflate the lungs. The air you breathe contains about 21% oxygen. Your exhaled air still contains between 6 oxygen. This exhaled oxygen is enough to support someone's life. To give rescue breaths, you need to make sure there is an open airway. The airway is the only path for getting air into the lungs. An unresponsive person can lose muscle tone. If flat on his or her back, the base of the tongue can relax and obstruct the airway. This is the most common cause of a blocked airway. The tongue is attached to the lower jaw. Lifting the jaw forward pulls the tongue away from the back of the throat and opens the airway. You can open a person's airway by using the head tilt chin lift technique. Place one hand on the forehead. Place the fingertips of your other hand under the bony part of the chin. Apply firm backward pressure on the forehead while lifting the chin upward. This will tilt the head back and move the jaw forward. Maintain the head tilt with your hand on the forehead. Leave the mouth slightly open. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Even though the risk is very low, as a BLS provider, use a protective barrier such as a CPR mask when giving rescue breaths to minimize your exposure to infectious disease. Before using a CPR mask, quickly inspect it to make sure the one-way valve is in place. Place the mask flat on the person's face with the top of it over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom. Tilt the head and lift the chin to open the airway. Lift the face up into the mask to create an airtight seal. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. Additional air is unnecessary. Remove your mouth and let the person exhale completely after each breath. Take a fresh breath between delivering breaths. If you remove your hands from the head, the airway will close again. It is necessary to open the airway each time you give rescue breaths. Rescue breaths for children and infants are performed in the same manner as for adults. It is recommended to use an appropriately sized pediatric CPR mask. The airway of an infant may become blocked if the head is tilted too far. Position an infant's head in a neutral position, in which the ear openings are level with the infant's shoulders. Special care should be taken not to give too much air in a single breath. Provide only enough air to make the chest visibly rise, but no more. The jaw thrust is a convenient airway technique, especially when working in a team or when using a bag mask device. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Lift and tilt the head backwards. Use counter pressure against the cheeks and displace the jaw and move it upward and into the mask. This will open the airway. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. A bag mask device allows rescuers to provide rescue breaths without having to blow into a person's mouth. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. A bag mask can be used by a single BLS provider, but is best used by 2. From above the head, place the mask flat on the person's face with the top over the bridge of the nose and use the jaw thrust airway technique to establish an open airway. Have a second BLS provider squeeze the bag with both hands to ventilate. Squeeze the bags to deliver each breath over 1 second. Make the chest visibly rise, but no more. When using a bag mask as a single provider, position yourself above the person's head. Place the mask flat on the person's face with the top over the bridge of the nose. Use the thumb and index finger of one hand around the valve in a C position to seal the mask against the face. Use your remaining 3 fingers in an E position under the bony part of the chin. Tilt the head back and lift the jaw up and into the mask to open the airway. Use your free hand to squeeze the bag and deliver the rescue breaths. Deliver each breath over 1 second. Make the chest visibly rise, but no more. Bag mask rescue breaths for children or infants are done in the same manner as an adult. It is recommended that an appropriately sized pediatric bag mask be used. When caring for someone who is seriously injured, establishing an open airway is a higher priority than protecting a possible injury to the spine. Without a patent airway, a person will not survive regardless of injury. When the potential for a neck injury exists, a jaw thrust without head tilt can be used to open the airway. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Use counter pressure against the cheeks to displace the jaw and move it upward and into the mask without tilting the head. If you find the jaw thrust without head tilt does not open the airway, use jaw thrust with head tilt or the head tilt chin lift technique instead, even if neck injury is suspected. You must establish an airway for a person to survive.
Mrs. Williamson collapsed in the treatment room. Activate EMS.
Remove clothes from patient's chest. Peel white pads from gray plastic case. Attach pads to bare skin exactly as shown. Stay clear of patient. Analyzing heart rhythm. Shock advised. Stay clear of patient. Press the flashing orange button now. Shock delivered.
Begin CPR.
AEDs are designed to be simple to operate. Voice instructions, lights, and screen prompts guide an operator through use. There are many different brands of AEDs, but the same basic steps for operation apply to all. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice instructions and readies the device for use.
Apply pads to patient's bare chest.
Pads must be applied to a bare chest. If needed, quickly tear away or use scissors to remove all clothing from the torso. Dry the chest quickly if wet. For a woman, remove the bra to provide better access for pad placement. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each as shown in the pictures. Place one pad below the right collarbone above the nipple and beside the breastbone. Make sure it adheres well by pressing it flat. Place the other pad lower on the left side over the ribs and a few inches below the armpit. Again, press firmly. Most AEDs automatically start analyzing once the pads are in place.
Analyzing.
Stop CPR. Movement can interrupt the analysis. Be certain that no one is touching the person. If defibrillation is advised, the AED will begin to charge for shock delivery.
Shock advised. Stay clear of patient. Deliver shock now.
Quickly look to make sure no one, including you, is in contact with the person before delivering the shock. For most AEDs, a button is pressed to deliver the shock.
Delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. In cases when a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. AEDs are also designed to detect problems during use and guide you through corrective actions.
Press pads firmly to patient's bare skin.
If a troubleshooting message occurs at any time,
Insert connector firmly.
stay calm and follow the AED's voice instructions. Cardiac arrests involving children are likely caused by the initial loss of the airway or breathing. High-quality CPR with effective rescue breaths may be the only treatment required for successful resuscitation. However, conditions can occur for which defibrillation of a child or infant is warranted. The steps for using an AED on a child or infant are similar to an adult. Most AEDs have specially designed pads or mechanisms available that reduce the defibrillation energy to a level more appropriate for a smaller body size. For smaller children and infants, place one pad on the center of the chest just below the collarbones. Attach a second pad on the center of the back between the shoulder blades. Follow the AED's voice instructions to provide the appropriate care. The BLS assessment is a simple way to quickly identify if resuscitation is required. It is the same for all ages and is performed quickly. Before anything else, pause and assess the scene for hazards. Take standard precautions to prevent contact with blood or other potentially infectious materials. If it is safe, check for responsiveness. Tap or squeeze the person's shoulder and ask loudly, "Are you all right?" For an infant, tap the foot. If unresponsive, quickly look for signs of normal breathing. At the same time, check the carotid pulse in the neck. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, or gurgling sounds, known as agonal breaths, can occur early in cardiac arrest. These actions provide no usable oxygen. This is not normal breathing. For an adult, check the carotid pulse in the neck. Locate the bony Adam's apple with your fingers, slide them into the groove between the windpipe and the muscle on the side of the neck closest to you. For a child, check the carotid pulse or the femoral pulse in the leg. Place your fingers just below the middle of the crease where the leg and torso meet. For infants, feel the brachial pulse on the inside of the upper arm. Lay your fingers across the arm and compress inward. Take at least 5 but no longer than 10 seconds to assess breathing and pulse. If you are unsure, assume they are absent. If not already being done, tell another person to activate the protocol and get an AED. Relay what you have found so it can be passed on. Your assessment of the person and situation will determine the care you provide. If the person is breathing normally and uninjured, place her in a side-lying recovery position. Place the arm nearest you up alongside the head. Bring the far arm across the chest and place the back of the hand against the cheek. Grasp the far leg just above the knee and pull it up so the foot is flat on the ground. Grasping the shoulder and hip, roll the person toward you in a single motion, keeping the head, shoulders, and body from twisting. Make sure the head ends up resting on the extended arm. Roll far enough for the face to be angled towards the ground. Make sure there is no pressure on the chest that might restrict breathing. The recovery position helps protect the airway by using gravity to drain fluids from the mouth and keep the tongue from blocking the airway. Frequently assess and monitor the person's breathing. The condition can quickly become worse and require additional care. If the person is not breathing or only gasping, but definitely has a pulse, he is in respiratory arrest. The indicated care is rescue breathing, which is ongoing rescue breaths provided without chest compressions. If the person is not breathing or only gasping and does not have a pulse, he is in cardiac arrest. The indicated care is CPR, a repeating combination of chest compressions and rescue breaths. Always perform a BLS assessment to quickly determine the need for CPR. Ensure the scene is safe. Assess responsiveness. Assess for breathing and pulse. Activate the emergency response protocol for your setting and get an AED.
Heather? Heather? Heather, breathe! Heather! Heather, breathe, please!
What's going on here?
I think she overdosed. She took something new.
Okay, let me check. Ma'am, can you hear me? Ma'am, can you hear me?
A person in respiratory arrest has stopped breathing but still has a beating heart.
Dispatch, P37, can you advise EMS this is a possible overdose? She's not breathing but has a carotid pulse. I'm going to start rescue breathing.
Copy P37, possible overdose, rescue breathing in progress.
Without immediate intervention, respiratory arrest can quickly progress to cardiac arrest.
James, I've got my naloxone kit.
Great, go ahead and give it. I'm going to keep giving rescue breaths.
Okay, James, I'm ready.
Okay, after my next breath.
Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to assess. This person is unresponsive, not breathing, and has an obvious pulse. Have someone activate your emergency response protocol and get an AED if one is available. Establish an airway and give a rescue breath. Continue to provide one high-quality rescue breath every 5 to 6 seconds, or about 10 to 12 breaths per minute. Reassess the pulse about every 2 minutes. Take no longer than 10 seconds to do so. If the pulse is absent and tissue signs indicate poor perfusion, or you are unsure, perform CPR starting with compressions. If an opioid overdose is suspected, consider the use of naloxone, as indicated by your local protocols. The rate of rescue breaths when performing rescue breathing for children and infants is 1 breath every 3 to 5 seconds, or about 12 to 20 breaths per minute. When monitoring the pulse of an infant, check for the brachial pulse in the arm. Add compressions and perform CPR on a child or infant if the pulse rate is 60 beats per minute or fewer, and it appears the heart is too weak to adequately move blood forward. Signs of poor blood perfusion include pale, mottled, or bluish skin color, weak pulse, and cool extremity temperature.
Let me take over for you.
How long has he been down?
Just a few minutes.
Sir, are you all right? One, two, three, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21.
Stay clear of patient. Analyzing. Shock advised.
Everybody clear?
Clear.
Stay clear of patient. Deliver shock now. Shock delivered.
1, 2, 3.
Immediate high-quality CPR and defibrillation with an AED can double or even triple the chance for survival from sudden cardiac arrest. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This person is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use the AED immediately when it arrives. Turn on the AED and adhere the defibrillation pads to the bare chest. Allow the AED to analyze the heart.
Analyzing.
If a shock is advised,
Shock advised. Stay clear
make
of
sure you are not touching the person before delivering the
Deliver
shock.
shock now. Shock delivered.
Immediately after a shock is delivered, resume CPR, starting with compressions. Voice instructions and additional analysis by the AED will guide you through further care. Don't stop until the person shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
Stop CPR, he's responding.
If a person begins to breathe, moves, or respond, stop CPR and place the person in the recovery position. Leave the AED turned on and the pads attached in case cardiac arrest reoccurs. In cases where a shock is not indicated by the AED,
no shock advised.
Immediately resume CPR. Continue to follow the AED's instructions. Compression-only CPR is being widely promoted to people who are not trained in CPR in order to encourage and increase the chance for bystander care. Simple instructions in compression-only CPR are being shared through things such as social media and public service announcements. EMS dispatchers are also providing compression-only instructions during emergency calls. However, compression-only CPR is a limited approach to treating cardiac arrest. At some point, rescue breaths are essential for all cardiac arrests, especially for secondary cardiac arrest. As a trained BLS provider, perform both compressions and breaths during CPR. Most arrests involving children are secondary to the initial loss of an airway or breathing. Immediate CPR with an emphasis on effective rescue breaths may provide the only chance for survival. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This child is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use an AED immediately if one arrives. Don't stop until the child shows signs of life, another BLS provider takes over, or you are too exhausted to continue. Infant CPR is similar to adult and child CPR. Pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This infant is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Don't stop until the infant shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
And punch it out now, all the way in front. If you want a little bit more intensity, push with the palm. Keep those hands in the water. Now push, push. Lift up those knees, get those shoulders down and back. Let's go. Good job. Take it to the side. Same thing. Fist is a little bit easier. Palms a little bit harder. Get those knees up. Up, up,
High-performance CPR not only requires high-quality CPR skills, but it also relies on the efficiency of multiple providers working as a team. It is common for multiple providers to respond to a cardiac arrest, but a resuscitation may start with a single provider. Other providers can be integrated as they arrive. When 2 providers are available to perform CPR, one performs chest compressions, while the other gives rescue breaths. For adults, the ratio remains at 30 compressions and 2 rescue breaths. The compressor pauses to allow rescue breaths to be given. Give breaths as quickly as possible to minimize the interruption. High-quality compressions are tiring. If an AED is not attached, switch every 2 minutes at the end of a CPR cycle. Clearly communicate the details of the switch ahead of time to prevent confusion. If a third provider is available, have him or her relieve the compressor while rescue breaths are being given to shorten the interruption. With 2 providers, use a 15:2 ratio of compressions and breaths for a child or infant. When 2 or more BLS providers respond in an emergency, orchestrating actions is necessary for high-performance resuscitation.
Yes. Our lifeguards are responding now.
Stay clear of patient. Analyzing. Stay clear of patient. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
It is important to recognize the common roles identified for a team resuscitation and be ready to assume any one of them. The compressor is typically the initial responding provider. A BLS assessment is done and CPR is started, beginning with compressions. When a second person is available, he becomes the ventilator and takes responsibility for maintaining an airway and giving rescue breaths. An AED operator brings and quickly attaches defibrillation pads without interrupting CPR. This person is also responsible for the efficient and safe delivery of defibrillation shocks.
1, 2, 3, 4, 5, 6, 7, 8, 9, 30. 1, 2, 3, 4, 5.
Yes, I hear the sirens. Oh, they're here.
Stop CPR. Stay clear of patient. Analyzing. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
1, 2, 3, 4, 5, 6, 7, 8, 9.
The team leader takes a general perspective to supervise and improve overall team performance.
What's the story? He was exercising in the water and then he collapsed. How long since you started?
Effective team communication is essential. Speak calmly and in simple terms.
2 to 3 minutes. Was it witness? Yes.
This person is also the main point of internal and external communication. If you are asked to do something, repeat it back to confirm and reinforce the instructions. Other roles may be filled as necessary. A second ventilator to help with the use of bag mask, or a scribe or reporter to document patient information, treatments, and intervention times. In the transition to more advanced care, additional roles for actions such as administering medications may be added. When an AED is attached, plan to relieve the compressor during the time an AED analyzes the heart. This typically occurs every 2 minutes.
Are you guys clear?
After a shock is delivered or no shock is indicated, the new compressor immediately resumes CPR, starting with compressions. After a resuscitation, a facilitated group discussion or debriefing lets team members reflect on the care provided. Debriefing identifies issues with skills, equipment, or established procedures. It also emphasizes and reinforces what was done well. Changes based on debriefing can improve the overall standard of care for future resuscitations. Using realistic, scenario-based practices is an excellent way to prepare for team-based resuscitations. Practice using a team approach. An advanced airway device may be inserted into the throat during a resuscitation to maintain an open airway. When an advanced airway device is in place, the mask from the bag mask is removed and the bag is attached directly to the device to ventilate. As with other approaches to rescue breaths, provide enough air to make the chest visibly rise. Once an advanced airway device is in place, it is no longer necessary to pause compressions to give breaths. Provide continuous compressions at a rate of 100 to 120 per minute. Regardless of age, provide a single breath every 6 seconds or 10 times a minute. Choking can occur when a solid object, such as a piece of food or a small object, enters a narrowed part of the airway and becomes stuck. On inhalation, the object can be drawn tighter into the airway and block air from entering the lungs. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop an obstruction out of the airway. Compression of the chest over the breastbone can also create enough pressure to expel an object. To provide the appropriate care, you must first be able to recognize the difference between a mild blockage and a severe blockage. With a mild blockage, a person can speak, cough, or gag. This type of blockage is typically cleared by the affected person naturally through forceful coughing. Allow someone with a mild blockage to try and resolve the problem on his own. Stay close and be ready to take action if things worsen.
Morning, Chrissy. How are you feeling?
Much better, thank you.
Good. I need to get another set of your vital signs after you finish your breakfast.
Sure.
When a severe blockage occurs, a person cannot take in enough air to dislodge the object. Signs of severe obstruction include very little or no air exchange.
We'll just continue with the video later. Para mas maintindihan nyo. Kasi maganda yung mga AVP natin eh. So, we'll finish up with our first aid and some basic medical approaches. Okay? So, sa first aid natin, bago tayo sa wound management, yes, we have to identify the head to foot situation. We do it by system. We treat it by focus treatment, but we approach it by main body parts. I mean, main body parts, not system. Sorry. So main body parts, hiniwalay ang face. Okay, so head, face, neck, trunk, then abdomen, upper limbs, itong inguinal area, hiniwalay siya. Dati kasi parang sinama na lang doon sa lower abdomen, so hindi. So ito, kung sabihin natin kung hindi first aid, pelvic area, but lower abdomen area, up to the junction, tapos lower limbs, isinama si thighs sa legs. Okay? Other first aid book, hiniwalay si hands and feet. Okay, si hands and feet. So, there's no problem. So anything na problem sa head, no? Mabukol man yan or open wound, sa trauma natin lahat yan. So anything na trauma, isahin ko lahat ng trauma. So anong pwede doon sa brain na hindi ko nakikita pero parts sa head? Anong pwede doon sa brain maging problem? One is stroke. So sa stroke, ang nakita ka na stroke, be fast ulit. Is there like a problem with balance? Is there like a complaint of eyes or nag-droop yung eyes? And then F, may siyang facial asymmetry, no? A is arm drop. Check mo, tapos pag bitawan mo, hulog yung isa. Okay? And then slurring of speech, particularly kapag ang right body yung weakness, kalagmitan yan, ang meron niyang speech, meron slurring of speech kasi nasa left brain kasi yung ating broadcast speech center. So, yun. Okay? So, and or lang yan. Not necessarily pressure lahat. And depende rin sa laki ng sa stroke. So, kailangan doon time frame, magdala natin kasi kung mag-advanced life support tayo, meron tayong tinatawag na 10 minutes to ER, 10 to 30 minutes prepare for CT scan. So, ganun yan. And then, makikita natin kung yan ay sumabog or yan ay barado, kung infarcted. So, sa hospital na yan, that's ACL, stroke management. So, ano pa? Sa seizure. Sa seizure, you cannot contradict. Pag nag-tonic-clonic, huwag pilitin, huwag lagyan ng spoon, nothing. Just leave it na nag-seizure. Kahit ilateral recumbent mo yan, hindi mo pa yan malateral recumbent. Pagkatapos, makikita mo na konti na lang, medyo malambot na recovery position ka. Huwag mo siyang iwanan na nakaan. Kasi ang daming secretion yan dito. Okay? Lalo na mga grand mal or tonic-clonic na seizure. So, if it's like recurring dahil merong infection, such epilepticus, so, bantayan lang siya ng bantayan until help arrives kasi mahirap mag-seizure na nakaside. So, pag seizure niyan, tihaya siya, nakasupine, tapos pagkatapos seizure, recovery position. Okay, ganun lang ating style doon. And then facilitate oxygenation. And of course, transport to hospital kasi you don't like a seizing patient dahil mabubugbog yung brain, pati yung mga organs. Next is, what else? Stroke. So, yun lang muna sa head part. Sa face, iniwalay si face because it is a display. The face is a display of lots of problem around the body. Pag hirapang huminga, makikita na yun, nag-flare yung nose. So, alam natin merong respiratory distress, no? And nagpipil yung mukha, alam natin na meron siyang hemodynamic problem. So, wala tayong gagawin except yung facilitate breathing, no? Pinakamaganda, position of comfort, makikita kasi yung mga grimace face, no? Position of comfort, and laging tuturo yung 2 to 3 seconds inhalation yung tapos inhale to the mouth, 3 seconds, 1,000, 2,000, 3,000, inhale sa nose, 1,000, 2,000, 3,000, inhale, exhale sa mouth. So, mga ganong maneuver ang ginagawa natin. So, sa face. Okay? So, walang trauma tayo. So, dito naman sa neck, no? Wala tayong magagawa kung ano yun, unless trauma. So, anong mangyari? Halimbawa, may nakita ka, lumalabas isang blood vessel, first aider ka. So, hindi, wala kang magagawa. Kasi, kunwari, meron siyang congestive heart failure or merong cardiac tamponade, no? First aider ka. Wala ka rin magagawa. Pero at least alam mo anong nakikita mo kasi first aid, isa sa ginagawa sa first aid is you should be observant para alam mo anong i-refer mo. Or merong tracheal division, debate ng trachea, tapos plus respiratory distress, pwede siyang merong dalawa. No? Pwedeng may pneumothorax, pwedeng merong atelectasis. Atelectasis is the division towards the affected side. Pneumothorax naman, division away from the affected side. Pagdating dito sa chest, ano ang mapapansin natin? Una is complaining of pain. Any pain, particularly on the left, on the center, sa pain na hindi niya ma-describe, any pain na hindi niya ma-describe, pag sinabing burning pain, umaakyat, kakaiba yun. Mabigat. And or nakaramdam na may nakadagan. Dito sa left, minsan dito sa right, minsan dito banda. Minsan may pain, umaabot sa leeg, or bumabaybay dito. So, most likely, heart yan, in origin. No? Huwag ka muna mag-isip, ay baka sakit sa muscle yan, pinapush up ka kasi ni doctor eh. Mga, hindi ka muna ganon. Always take it hard, lalo na kapag merong mabigat na, para may nakadagan, tapos nahirapan. Absolutely, that is an emergency. Let's settle it in the hospital. So, wala kang gawin. Kundi, position of comfort and breathing. Buying time yun talaga yung breathing. Yan yung mga madaling gawin pero hindi natuturo. Yung 3 seconds in, 3 seconds out. 3 seconds in, 3 seconds out. Okay? Pain kahit sa likod na hindi mo maintindihan, take it like baka pwede siya, no? Tapos lalo na pag wala siyang pain na paghawakan mo, wala talaga nasa loob. Then take it like it's cardio. Okay? So, yun. Pagdating sa tiyan, kung anong pain, pero may direct tenderness or what, na masakit siya, tapos ang pain scale mo, maabot ng mga 6 up, no? 6 up, 6 to 10 yan eh. Or 0, non-pain, tapos 1, halos wala, hindi mo yung super konti. 10 is the most painful. So pag nag-akyat ng 6, rule of thumb is MPO ka. Wala kang ipapainom, wala kang ipapakain. And then breathing na yun. So breathing lots of oxygen can facilitate release of some endorphins inside the body kahit pa paano makatulog. So we encourage the patient to visit the hospital kasi consider it as a surgical case. Pag dito naman sa lower abdomen, ganun din para ma-check baka meron ka ascending urinary tract infection or merong sakit dito sa may likod sa tiyan, baka umaakit na sa kidney yung sakit mo. No, yung infection. So, lalo pag hinawakan mo or kidney punch, ito yung lower back, ganun mo na. Yeah. Tapos masakit siya. So, take it like there's like a infection. So, hospital din kasi first aider ka, hindi kang pwede magbigay ng antibiotic. Only doctors do that. So, yun. Tapos, or difficulty in urinating, no? Or hindi niya ma-evacuate yung pupo niya. So those are the indications na ikaw hindi kailangan may nilapat ka sa katawan mo, kundi yung suggestion mo, let's go to the hospital because ganito yan. Gusto kong kumain, saglit. Ano bang klaseng pain? Mahapdi na may nasusunog? Sige. But I have it would like check. Ganun ka ba? Pag alam niya, ganun na po ako, meron talaga akong gastritis or acid peptic ulcer disease, although it's an old term, APUD. Hindi naman ginagamit na ngayon. So, meron kang medication, kunwari omeprazole, sige, facilitate mo. Pero kung nag-persist, then go to the hospital. But in the absence of anything na first time kong naramdaman to, better advice, go to the hospital. Ganun lang yan. Kasi lalo na ngayon, COVID, maraming pwedeng manifestation ng COVID. Ano-anong mga sakit na labo-labo siya. Okay? So, other than things, mga extremities, yung pain by movement, muscular pain, well, you can do over-the-counter treatment. You can suggest or you can ask the patient, are you taking anything before? Pag ano kasi ako, naglaba eh. Sumakit. Then, kung hindi naman lalapit tao, kung kaya na, hindi yan lalapit sa'yo. Pag lumapit, itanong mo lang palagi. Kahit first aider ka, meron kang sample. No? Binaba na po yung sample. Hindi lang yan sa EMT saka sa EMR. Binaba na sa first aider. Signs and symptoms, yun. Tapos, may allergy ka ba sa gamot, but you will not give the drug. Meron ka bang mga medication iniinom? Kung ganong sakit na were you advised to take the medicine, tapos P, past history. Ganon na ba? Dati may ganyan ka? L, last oral intake, and then events leading to the illness. No? The illness. Anong nangyari? Naglaba ako. Pwede, some sort of cramps. Baka nagkaroon ako ng electrolyte imbalance, no? So these are the things. But as a first aider, kasi nagsakit siya, but have it check para makita natin, ma-check yung dugo mo, baka may problema sa electrolyte. Kasi at your mind, meron kang sample. Sakit siya, pagkatapos laba, yan ang nangyari. Wala ka na may ibang ginawa. O ganun, balikan mo na yung sample. Okay? Ganun na ngayon, medyo advanced na si first aid. So, the whole approach, the whole body approach is inano. Pero halos wala kang intervention except the 3 seconds breathing in and breathing out. Init mo, tapos labas mo. Tapos pag merong anxiety attack, ganun din. 3 seconds in, pero pag exhale sa mouth, pursed lips, nagbibilang siya ng 3 seconds out. 1,000, 2,000, 3,000. Inhale. 3,000. Exhale. 1,000. 3,000. Inhale. Tapos exhale, pero pursed lips. Walang brown bag. Okay? Pagtatawanan ka, pag brown bag ka. Okay, so yan ang ating whole of the body approach sa issue being first aider. Okay. Now we will go into trauma. So ayusin ko lang ha. Ilawan. So let's go into addressing open wound sa bleeding. Okay. So I have a wound, gaping wound. So we need to close this. So there are issues. So since we don't suture in first aid, so we just don't like it to coaptate. Kailangan siya makasara ganun. Then meron tayong penetrating wound. Yan, penetrating wound. It does not mean smooth edges. So pwedeng stellate or irregular edges because there is like a blunt thing. Pero may sharp edge siya ay nawarak niya. Pero ito malalim. So this can be, kung sa gunshot wound, this can be some sort of an exit bullet. Ang entry ay ito. So this is a penetrating wound. Entry siya. So clean. Pwedeng ice pick. So anything na pointed. Okay? Sharp siya, pointed. So that's it. Then we have some sort of laceration. Okay. So kung titingnan mo, malalim din siya. Tingnan mo yung daliri. Now, with all these injuries that can hit the body, the first issue is there an oozing? Is there like situation where the blood, it oozes out? So mabilis. So hindi katulad sa mga palabas na sisirit ang dugo. Hindi talaga pwede sumirit ang dugo. Why? Because arteries are deep set. Sa ilalim siya. So pag na-breach yung artery sa ilalim, makikita mo, bubulwak lang yung dugo. Pero hindi yung na parang projectile. So bubulwak siyang gano'n. Makikita mo. Tapos pabilis kasi sumasang-ayon sa tibok ng puso. So bulwak siya. Alam mo na arterial yun. So yung mga nasa libro na capillary bleeding, venous bleeding, sa arterial bleeding, hindi ako basta maniniwala. Kasi bakit? Pag may artery bleeding, tumabi siya sa mga capillary din. Automatic ba bright red ka agad siya? Hindi. Kung nagkatabi si arterial sa kasi venous bleed at the same time, hindi mo makikita. So you cannot ascertain it because you don't have x-ray and whatever na magsabi, kahit sabihin natin magaling ka sa anatomy, hindi naman bye-bye na ano yan. Or dito ang aking brachial. Dito ang tama ko. Hindi, pero ang tama ko pa ilalim, tinaanan yung aking main artery. Pwede rin yun. So, you don't know the cavitation, particularly like if it's a gunshot wound. Hindi mo alam kasi ang gunshot wound, pag tumama sa katawan ng tao, lalo na yung 5.56, no? Yung sa M16, 5.56. Pag depende sa layo, minsan nag-iikot sa katawan ng tao. So hindi mo alam saan nanggaling yung ano, kasi pwede siyang umikot o tumama sa buto, lumihis. So pwedeng gano'n. Meron din pagtama, high caliber talaga. Pagpasok sa loob, tapos gumawa siya ng wide cavitation. Paglabas dito, warak sa exit wound niya, bumalagbag yung bala. Depende rin sa lapit ng baril. Kasi habang palapit ang baril, mas high penetrating siya. Kung malayo na, pagpasok sa katawan nito, babalagbag na yung slug. So mas kikreate siya ng wide cavitation. So it's really difficult to ascertain ano kung merong arterial ba, veins, lalo na gunshot wound, no? So parang natawa din ako sa mga libro na wow, agree ako, may kulay. But pwede siguro yung maganda yung knife pag nasaksak kasi ang knife deliberate talaga siya yung kanyang angle o ano yung blade lang. Hindi katulad ng bala, pwedeng bumalagbag or umikot sa loob ng katawan ng tao. So how do we do it? So the first and foremost is it bleeding. So tandaan niyo lang yung depth. D-E-P-T-H. Okay? Ano yung sabihin nun? Direct pressure. So dito, bago kayo turuan ng austere sa first aid, is i-ano natin. Tingnan natin anong klaseng injury. Hindi ko na ituro yung mga betadine, mga mababaw na wound yun eh. Dito ko sa mga hindi familiar ang tao. Sa sunog din, yan. Ulitin ko, sa sunog, okay yung rohani. Okay yung, ang rohani pwede sumuka. Pero huwag mong takpan ng silupin mo, kahit hindi mo kainga. Pwede mong butasan, takpan mo. Tapos butasan mo lang, okay na yun. Butasan mo lang siya, kung dalawa. So na-cover siya. Okay, tapos pag may mga injury naman, laceration, well, we just bandage it like sabi naman po sa tali. So standard bandage, ngayon, ewan ko sa Pilipinas, meron na siguro. Ito yung ETD, meron siyang absorbent layer. Ito yung tatama ko na rin, may tama ko dito, lagay siya dyan. So hindi na tayo hindi na tayo nagtiti-bandage. So ito na lang siya. So ito naka-velcro rin. Pag bitawan mo, pusa siyang kakapit. So may velcro. Pusa siyang kakapit. Yung velcro. Ayan o, may velcro siya. So bitawan ko, hindi na siya ma-release. Kasi may mga velcro along the way. So yan. Okay? So maganda siya, ang ETD, kasi mas iipit talaga. Lalo na kapag may gaping wound, iipitin niya talaga. So that's the point why things change. Hindi pwedeng puro tayo pang ancient pa rin. Kayo kaya nanay niyo may na-disgrasya, gusto niyo ancient yung style of treatment. Hindi na ganun ang mundo. Kaya sa mundo, ano ka na? Sumasang-ayon ka kasi medical science is very aggressive and very dynamic science. So ETD ginagamit, and then we have ETD goes with sizes. So, ito another ETD rin, ibang kulay siya. Pero yun din, may absorbent layer. So, elastic din siya. Merong ganito na abdominal pads. Ang abdominal pads, siyempre dapat makita nyo, absorbent, except pag abdomen, meron siyang extra sheet. So ngayon, nilapat ko kasi may evisceration. So, dagdag, ano siya, dagdag covering layer. So, kunwari, tali kong ganyan, dadaanan mo muna yung main line. Okay. Tapos akyat ka na. Yan yung point ng abdominal layer. Abdominal bandage. Okay? So, hindi na gumagamit ng Sira eh. Hindi na gumagamit ng mga tawag nito, ng yung metal clip kasi natatanggal. So meron na silang ngipin. Pwede mo nang so yan. Tapos naka-velcro siya. So pwede mong ilagay dyan. So nakakabit na siya. So you have your abdominal bandage. So yan na yung language ngayon. Ayoko matuto kayo na puro austere kasi yan na yun sa mga wilderness medicine. Pero pag nasa tamang healthcare institution tayo, kailangan maayos. And these are common things naman. So kung makita mo, meron siyang added pad. Kung hindi naman ganong kalakihan, hindi ganon lang. Kung hindi naman ganong kalakihan, ang maganda dito, nalalaro mo, added pad siya. Yan. Okay, so this is your abdominal. Ang mga ganito, ang commonly, we call them ETDs. No? These are made by, bago na civilian to, ginagamit ng sundalo. So we call it emergency trauma dressing. Meron din yung ginagamit ng Israeli na merong reverse. Ang tawag naman ITD, Israeli trauma dressing. Ganito rin, except na pagtali mo, meron siyang clamp doon. Pwede mong i-reverse to add grip to the bandage. Meron siyang plastic sa in between para mag-reverse ka. Ito kasi single roll eh. Doon, pag roll mo, dadaanan mo ngayon yung plastic, ikabit mo siya doon, pwede mo siyang i-reverse. So, yun yung Israeli trauma dress. Okay. So, let's go now to addressing injury para matackle ko rin yung component ng stop the bleed in injuries with bleeding. Pag sinabi kong bleeding, lahat naman nagbe-bleed, but I'm talking about active bleeding. So may arterial component siya. So I'll start with this. Okay, nakikita nyo. Now, una is direct pressure. Saan ka mag-direct pressure? Sa ganito kalaking, bakit ako mayroong mahabang buhok? Buhok ng haba naman. Kailangan mo kung mahabang buhok. Okay. Direct pressure, pag ganito kalaki, huwag ka dito mag-direct pressure. Lalo na pag medyo may cavity yan. Mag-direct pressure ka in between the wound and the heart. Assuming ang heart ko. So dito ka man na mag-direct pressure. Yan yung D. Kasi ipitin mo yung artery while buying time. Bilis naman kuha ng bandage or direct pressure mo isa. Hinga malalim. Kasi lalo na kapag nasa femoral artery ka dumaan, kasama ng femoral artery, femoral nerve. Pag idiin mo yan, masakit talaga. Pahingayin mo malalim yan. Magpa-pass out yan. Pag na-pass out yan, hinimatay, okay lang yun. Hindi naman yan nag-cardiac arrest. Normal yung himatayin ka kasi. Pag hindi ka himatayin, magka-cardiac arrest ka because of pain. Yan yun. Kaya pag nahimatay ka sa sakit, normal. Para hindi mo ma-perceive ang pain, para hindi ka mag-cardiac arrest kasi in extreme pain, yung katawan mo, maliligalig yun. So, ang heart mo maglo-load. Okay? So, dito, in between the heart and the wound, kuha ka ng gauze or a packing thing. Yung iba may elevate. Sa atin, sa field, hindi na. Sa hospital, baka siguro, sige, elevate, okay lang yun. Dagdag mo yung E. P is pack, gauze. Anong klaseng gauze? Pinakamagandang gauze, ang packing is Kerlix. Ano siya? Para siyang makapal siya. Kerlix. It's a roll. Mahaba siya. So, paano ina-apply ang Kerlix? Ganito yung ipag-apply sa Kerlix. Kung gamitin ko na lang yung Kerlix na bukas na. Kunin mo yung dulo niya. Kerlix, kunin mo yung dulo. Balik ko lang ha. Pero hindi ito lagayan ng Kerlix. Wala na kasi akong lagayan dito. Tingin kayo dito. Kailangan ang inyong kamay can work left and right. Okay? Pwedeng right, pwedeng left. Kailangan ambidextrous kayo. Depende sa anong posisyon. Okay. So ito yung sugat natin. So, ganituin ko lang ha, pero mali yung position ko. Pero for the sake na kailangan matuto kayo. So, ginanito ko. Pag pisil nyo diyan sa loob, tingnan ha, sisigaw talaga yung pasyente sa sakit. Kaya laging i-assume yung 3 seconds in, 3 seconds out. Pag ganun mo, ang dugo lumalabas pa yan. Huwag mo siyang bitawan. Pag ganun mo ngayon, ang gawin mo, para mapak mo to, ilapit mo yung gauze pack. No? Ito. O dito ka, ilapit mo siya. Hawak ka. So paglapit niyan, huwag mo nang ilabas to. Kasi pwedeng nakapins na yan sa loob. I-feed mo siya nito. Pwedeng ilabas mo yung sa feed. O. Tingnan mo, feed. Feed. Okay, feed. Nag-feed ako ngayon. Pinifeed ko nito. Feed. Yung dugo kumakalat. No? Tanggalin ko muna para explain ko kumakalat yung dugo. Ngayon, pwede mo siyang gamitin to. Okay lang yan kasi sa amin, sa combat medicine, hindi naman ganong sterile environment. So tayo naman, usually baka hindi na to, sa hospital hindi tayo ganito. Sa hospital we really have to find ways to ligate it. Or we can use, mamaya may i-demo ako na hemostatic. So pag ano mo, minsan pwede mong pahiran. Pag nakita mo wala ng dugo lumalabas, happy ka na. Pero may cavity pa ako. So you have to fill the whole cavity. Fill up mo siya. Fill up mo. Ngayon, sige, hindi ko na ubusin. Anong mangyari? I-cut ko ba ng scissor? No. Ubusin mo yung buong gauze. Pag ubus niyan, kahit mag-emboss pa yan, kunwari ito yung buong gauze, no? Naka-emboss yan, hayaan mo yung emboss, saka mo patungan ng elastic bandage. Okay? Itong elastic bandage. And lock. The embossed thing, the embossed part will help push more the breached artery. Okay, so yan ang hindi common. Pero that is life-saving. Kasi pag hindi mo ganyanin, tuloy-tuloy yung bleed, soak na soak yung ano. Habang malayo sa ospital or naka-traffic ka or nasa bundok ka, mamamatay yan, mauubusan yan ng dugo. Pag umaubos yan, mga 20% of the total body fluid niya, for example, 5 liters tayo, maubusan na yan ng mga 5, no? So, 20%, no? 20%. Medyo may kakaiba na yan, no? So, hanggang 1.5. Pag nag 2 liters, ubos na yan, point of no return na yan. Wala nang pag-asa eh. Ganyan ang ating 30 yata, 30. Check nyo nga. So ito yung packing, wound packing sa P. D, direct pressure. E, elevate. P, packing, wound packing. So ganito ang wound packing, okay? And then D, E, P, T. Ano ang T? Tourniquet. Okay, ganito ang tourniquet. Hindi tourniquet na ginagamit nyo para mag-IV. Hindi yan. Tourniquet talaga na as in. So, I have your pin tourniquet. Yung nakita niyo sa presentation mo kanina. So, ito yung kanyang preloaded. So, I have here like a windlass. Ito yung panghigpit. I have here a lock C loop, letter C yan, letter C, o letter C. So, dyan sa loob. I have a velcro lock para pag nalagay mo na itong lock, pwede mo i-velcro. Lock na siya din. Dyan mo isusulat kung anong oras na tourniquet. Sa preparation, ilagay mo rito para hindi ka mahilo. So yan, ang preparedness ganyan. So ito, dinesign ko to apply to myself para mabilis. Kung ano sa giyera kasi. No? Pag kunwari nasa bulletproof vest ko, pag tanggal ko, ang kapital nito is ano lang eh, bibig eh. Okay? So pwede mo gamit ang bibig, no? Marumi kasi, ayoko lang ibibig. No? Pwede paghila mo na, hilahin mo ng bibig, mag-release siya. Okay? Mag-release. So depende sa preload mo, pwedeng gano'n na sa kalaki para sa binti mo. So pag gano'n yan, no? Pag kagat mo, crack, release siya. Kailangan to naka-point papunta sa iyo. So, i-strap ko sa sarili ko. Pag nag-strap ka ng tourniquet, laging nasa single bone. Kasi dito, radioon na dalawang bone. When you are not sure, the best tourniquet is always single bone. Dito sa paa, dito sa binti, doon sa thigh. Kahit ang warak sa iyo is ankle, pwedeng doon sa thigh. Kasi sa tibio fibula, pwedeng may laro eh. Pero allowed to, mamaya ano ko kung ano yung best way. Okay, so usually dito sa taas, sa combat dito, kahit dito ang warak ko, dito nagbi-bleed, tanggal yung warak ko, dito pa rin ako. Okay? Yan ang rule sa combat. Sa atin, sa civilian, kung saan ang injury, allowed doon sa 2 bones. Okay lang yun. Kaya ilan? 3 inches. So, ito 10 cm, ilan to? So almost, yan, dito banda. 2, tama ba ako? Ilang 1, 2 inches? So 3. 2 to 3 inches up. So kunwari ito, dito ka, ito yung papunta sa itaas, papunta sa heart. So dito ka ngayon mag-tourniquet. Okay. So dahil masakit to, so hindi ko ito tourniquet sa sarili ko. Dito ako magto-tourniquet sa kabila. So kunwari ito yung limb, tapos bulwak ang dugo. Life-saving to, maraming taong na-save nito sa combat. Ngayon, paglagay niyan, okay, slowly, itong kanyang velcro, male, female to. The velcro does not need a female. Male, female to. It can attach to itself. Oh, attach to itself. Oh. Kapit siya. Oh. So, ang pinakamandang aspekto ng tourniquet is how you will yank. Higpit talaga, i-yank mo. Yank! Higpit na kaagad. Ikot para kumapit sa tourniquet. So, inikot ko para kumapit sa velcro. It will attach to itself. Okay? Yan. Huh? Malaki siya, kaya hindi. Saktong-sakto lang doon. So, balik ulit ako dito. Pag nakakabit na, hindi ka pwedeng maglagay ng tourniquet na maluwang. Kailangan mahigpit talaga. Then, you start to twist this one. Ito siya. Kung saan siya nanggaling, doon mo rin siya ibabalik. Yan ang counting mo. So, you have to do a 2.5 to 3 counts. 1, 2. Oh. So, pwedeng mahigpit na siya, matigas na yan, pwede ka mag-2.5. Okay? So, tingnan mo, ikakabit mo siya doon sa silo. Yan. Hirap kasi nakatalikod ako para makita niyo. So, kabit siya doon sa silo. Yan. Yan, kabit na. Kung ito ay mahaba pa, lalo na sa dito sa ano mo lang, sa link, pwede mo siyang ibaybay doon sa silo mismo. Then, velcro lang. That's your tourniquet. This is your type seal. Kung pansinin nyo, talagang higpit na higpit. Wala talagang circulation. Wala na. Ito, dugo dyan na lang. Buhay yan. Masakit siya, pero buhay ang tao. Okay? So, that's your tourniquet. Sige, tanggalin ko. By the way, pwede ba tanggalin to? No. Ang magtatanggal nito, ospital, doktor na. Okay, walang magtatanggal nito. Paano sir kung pumalpak? Tanggalin ko para mag-ano hindi. Pwede ka mag-apply ng tourniquet over panibago. Nagkamali ka, mag-apply ka ng panibago doon sa ibabaw. So, yan ang tourniquet application. Kaya ako lahat ng bag ko, may tourniquet talaga. Kahit yung tungkod ko. Tuwang-tuwa kasi ako sa tungkod ko eh. Parang na-enjoy ko pag may tungkod. Pero yung tungkod ko, may tourniquet na kabit. Weird na tungkod. Tapos yung tungkod ko kasi meron yung blade. It's a weapon. Kaya yun, hindi dahil nakakatuwa kasi nagtungkod ka pero may weapon. Yan ha. So, we have here the side release. We have here the wings. We have the silo. We have the velcro lock. And we have the strap. na main body strap. So, ipipreload ko siya. Kung gusto ko para magamit ko ulit, pwede mo siya i-preload. Pero sa ibang bansa kasi sa US, mga single use. Pilipinas, single use. Walang single use. Sa hirap. Isang ganito, mga 2,000 to 2,500 yata. Kaya, minumultiple use natin. So, nag-preload ka, kailangan isukat mo na itong pula ay lalabas doon. Okay, so tingnan mo. So sinukat mong ganyan. Okay. So, ganyan. Tapos ganyan ang preload. Oops, lampas pa. Maganda. Bawasan ko pa. Pag meron kayong ganito, masasanay kayo. So ngayon, niloop ko siya. Kailangan itong pula nakikita ko. And then I will garahe ko dyan. So yan yung preload. So pwede kong lagyan ko ng rubber band. Nakakabit doon sa backpack ko. Mga lahat ng backpack ko may tourniquet. So nakakabit siya sa katawan na kayang i-access ng right, kayang i-access ng left. Kung something happens to me, I can access with both hands. So, tourniquet. Then I will go to the H. D for direct pressure. E for elevate. T for P for packing, wound packing, using Kerlix. T for tourniquet. H for hemostatic gauze. This is a special kind of gauze na kung saan meron treated siya pero hindi sasabihin ng manufacturer. Pag tumama to sa blood vessel mo, sa blood, magkaklat ang blood mo para hindi ka mag-bleed. Okay. Same procedure. Dito. So, ang heart nandun sa itaas. So, bleed siya ng bleed. Gamitan ko ng hemostatic ko. Same principle sa Kerlix. Kuha dulo. Tingnan mo ha. Kuha dulo. May rabbit ear lagi. Lagay. Tingnan mo. Awas pa rin. Pwede mong ganunin. Oops, wala. Saka, ganun siya. Wala na. Remove isa. Feed. 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 Mahaba yan. Feed. Bilis. Feed. 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 Kita mo, may dugo pa konti. Tingnan mo. Wala nang lumalabas. Tuloy ang feed. Tapos itong nakaipit na to, hinahinay mo nang i-withdraw sa labas para napapak yung sa ilalim. Hanggang napuno na siya. Yan, punong-puno na. Yan. Kita mo? Assuming napuno na, huwag mo siyang putulin. Iuubusin mo siya hanggang mag-create siya ng emboss. Ilabas ko na lang emboss dyan sa labas. And then same procedure. Lagay ng bandage. Okay? Yan. And that's your hemostatic dressing. The funny thing is, mahal siya. Siguro isang ganito, 2,500. Isang ganyan. Pero life-saving siya. Again, ang aking first aid bag, first aid kit. Marami akong first aid kits kasi hindi ako pwedeng ang first aid ko, lipat-lipat eh. Sa sasakyan ko, may first aid kit, meron talagang ganito. Sa kabila, doon yung rescue truck ko, may first aid kit. Bawat bag ko, may first aid kit, merong ganito. So, naipon ko siya, hindi naman ako niwala sa expiration kasi ilang beses ko nagamit, expired na, gumagana pa rin. Nung nasa Zamboanga, sa Sulu ako, nagagamit ko sa mga gunshot wound. Yeah. Okay? So, that's your hemostatic gauze. Hemostatic gauze. So marami tayong available na hemostatic gauze. Pwedeng Celox. Ito naman, Quick-Clot. Quick-Clot. Dati Quick-Clot granules. Hindi na ginagamit yung granules because it can cause emboli. Saka masakit, mainit. Mainit. Oh, mahaba siya. Oh, kita mo, gano'ng kahaba. Haba. Oh. So, this is your hemostatic gauze. and it's treated. Kung anuhin mo siya, yung totoo, maramdaman mo na basa siya. Soap. Well, may nagsabi sa akin na sa manufacturer siya galing. Parang galing sa shell. Sa shell. Yung shell, sa mga shellfish na ano, doon ang galing. It facilitates clotting. I don't know what component of the shell or anong klaseng shell. Yan. And this has helped our soldiers in Marawi in treating ano, kaya hindi tayo ganong maraming na save. So I was able to donate sa Marawi mga ganito galing sa US. Okay. Now, what if I have penetrating injury sa chest? Chest. Doon muna ako sa chest. Penetrating injury sa chest. So, simple lang. Sa aking chest wound. So, meron tayong mga chest seal. Kung pansinin yung chest seal, vented yan. Kung saan yung injury, nasa gitna siya. So, mag 3 seconds in breathing, 3 seconds out. Kunwari, dito ang injury. So, na-chest seal ko. Chest seal ko. So, lapat siya. Dito, ganun ko lang para makita. Dapat ideally nakaganon. Ayan. So, nandyan yung butas. Makikita nyo may mga dagta konti lumalabas. Kailan siya lumalabas? During time na mag-inhale ang pasyente. So, sa sucking chest wound, butas yan, collapse yung lungs. Kahit anong inhale mo, hindi talaga siya lalaki. Then you have to seal it. Pag na-seal mo yan, 3 seconds in, 3 seconds out, bawat laki ng lungs niya, ipupush niya yung oxygen doon sa pleural space palabas. By the time mag-exhale siya, hindi makakabalik dahil ihaharangan ng mga fluid. So hinay-hinay, lumalaki yung lungs mo, gumaganda ang color ng patient. So this is a life-saving thing. And we call it the vented, V-E-N-T-E-D, vented chest seal. Eh sir, paano kung nabaril siya tapos through and through? Yan. So takpan mo yung likod. Bahala ka kung wala kang pagtakip na plastic, sana may duct tape ka, pero takpan ng duct tape. No? So kunwari, takpan ko. Pag nagtakip ka lang, laging letter X. Takpan kong ganyan, no? Laging mag-rabbit ear. Pag gagawin ng duct tape, may infolding sa isa. Pero dapat mataas, iniksian ko lang ha. So, cross dapat, huwag lang isa. Yan, cross. Kinross ko. So, lapat. Sarado yan. Sealed yan. Dito ko ngayon maglalaro sa harap. Laging ang vented chest seal sa harap. Usually, ang ginagamit, ang issue ngayon, laging dalawang ganito. Okay? Yung isa full seal, yung isa vented seal. Twin pack tag. Pero kung wala ka, single lang, gamitin mo to, tapos sa likod, pwede ka gumamit ng plastic. Kunwari, plastic to. Itong plastic niya, itong pinagkabitan. No? Yan. Siyempre, plastic. Yan. Nakakabit na, tatanggalin ko yung plastic. Yung plastic na lang, huwag ninyong pansinin itong sila, plastic na lang. Pwede mong itabon dyan. Lagyan mo ng duct tape to hold it on all sides. So meron siya. Closed na closed talaga siya. Yan. Pero sa harap, dito sa harap, doon gumagana yung chest seal. Okay? Kung saan yung injury din siya. So, guys, it is a magic. No? It looks complicated, but it is simple. Kaya binigay na siya sa first aid lang. Sa sucking chest wound. So that's how you will execute, or put a patch So, hindi ka pwede mag-wound packing yan. Kasi cavity yan eh. Lungs yan eh. Wala, hindi ka pwede mag-tourniquet. Wala kang tourniquet. So wala, hindi ka pwede mag-hemostatic. Kung hindi, seal mo lang. Tapos kung sa tiyan evisceration, takpan mo lang. Ganun lang. Pero ang pakialam ko is sa chest kasi pag nag-collapse yung isang chest mo, sa mga taong hindi well-trained, mamamatay talaga. Sa mga taong trained, kaya pa nila parang breathing yoga. They can facilitate discipline in breathing. Pero pag hindi ka trained, yung normal tao ka lang, wala, hindi maganda yung capacity mo sa ano. Papatayin ka talaga sa pneumothorax sa sucking chest mo. Okay, so this is your seal. Yan. Kung wala talaga lahat, assuming plastic lang to, same thing, plastic. Lagyan mo siya ng tape. Gawin ko na lang. So plastic siya. Kumari plastic to. Plastic ko na lang. Tapos plastic na. So, lagay ang plastic. Tapos duct tape. Although hindi to duct tape, pero hindi ko duct tape na lang yan. Gawin ko. Plastic. Ang injury ay nandito sa gitna. So, ang una mong dadaanan ng plastic ay ibabaw. Ibabaw. %50 dun sa plastic, 50% dun sa skin. Yan. 50% sa plastic, 50% skin. Sealed. Sealed. Okay, sealed yan. Then, rabbit ear, infolding, para hindi mahirapan kung tanggalin. Seal, 50%, sealed yan. Rabbit ear. Okay. Yung 3 sides sarado. Ang 4th side bukas pero hindi flare. Dapat mahiksikip. Nandito ang sugat. So makikita mo may dugo dyan. Pag nag-inhale siya, may lumalabas. Parang bula-bula. Hayaan mo lang yun. Pag exhale niya, hindi babalik yung hangin. Kaya hina-hina lalaki. Huwag mong ipa-flare to. Baka nagkamali ka tapos naka-flare siya. Naka-usli. Wala. Assuming naka-flare siya, pwede mo lagyan ng tape pero huwag mong idikit sa skin para lang lumapat siya. Ganito yan. Assuming flare, nagkamali ka talaga. Huwag mo nang tanggalin kasi baka yung pawis ng tao maapekto ang adhesive power ng duct tape mo. So, idikit mo siya doon, wag sa skin. Doon lang mismo sa plastic. Tapos, idiin mo para mawala yung flare. So, pag nag-inhale siya ngayon, makikita mo may mga bula-bula dyan. Pag nag-exhale siya, hindi na babalik yung hangin. So, nandito yung ano. So, life-saving din yan. Okay? So, it is a chest seal. Yan. Yan ang mechanics niya. Okay? So, now let's go to the injury. Yung mga sugat. So anong gagawin natin sa mga sugat kapag walang mga gauze or what? Ano mo sasarhan? Okay? So ganito yan. Pwede tayo gumamit ng duct tape. Ito, gaping wound. So, duct tape. Pero ito na lang gamitin ko kasi sayang duct tape, mas mahal. So, itong packing tape. But this is, it should be duct tape. So, dadaan ka sa likod ng limb. Dadaan ka sa likod. Iginanon ko lang for demo purposes. So, idadiagonal mo siya. So, dadaan ka sa likod. Papunta sa harap. Pagpunta sa harap, mag-meet sila sa ibabaw ng sugat. Okay, tingnan nyo ha. Nag-meet sa ibabaw ng sugat. Tingnan nyo. Yan ang sugat. Nag-meet sa ibabaw ng sugat. Walang hila, sabay hila, dalawa. Pag hila ng dalawa, ayan, nagsara ng sugat. Tingnan mo yung sugat. Gaping wound, gaping wound. So, diagonal approach, magsasalubong. Pagsalubong yan, ang pinakamaganda, pwede mo rin siyang lagyan pala ng, dapat lagyan mo siya ng gauze na maliit. Sorry, nakalimutan ko. I'm sorry, guys. So, gauze na maliit na nakaganon. Okay? So, lagay dyan. Hindi ito yung may arterial bleed, ha? Walang arterial bleed tayo dito. Okay? Ito sa itaas. Salubong silang dalawa, sabay hila. Hila natin. Pag hila niyan, sarado na yung wound. Okay, tanggalin ko siya para makita niyo paano magsara. Tanggalin ko. So may gauze na yan para makita niyo lang yung gaping, paano siya magsasara. Ayan, sarado na siya. Sarado na yung wound mo. Ngayon, pag sara na siya, happy ka na, sara. Ikot ka ulit. Tapos gagawa ka ng rabbit ear. Landing doon sa harap. Kasama yung dulo na may rabbit ear. Yan. Sarado na siya. So kahit pa i-move mo yung limb mo, hindi iyan bubukas. Okay? Yan yung style ng using duct tape. Okay. So that's the quickest way you do first aid sa gaping wound. Non-arterial bleed. Siyempre, pag arterial bleed, wound packing ako. Wala akong pang wound pack. Gamit ka ng damit ng pasyente. Yun yung i-wound pack mo, yung clean na damit niya. Okay, you don't need to have Kerlix kung wala kang Kerlix talaga. Yan, okay? So what else do we do with meron tayong ginagamit, pinakamaganda is micromend. Micromend. So itong micromend, sige. Ano ko na lang to? Buksan ko. So meron siya. Kinakabit yan dyan, meron siyang ngipin. Okay? So ito, dito ko siya gagamitin, kuha ko ng isang micro. No, para siyang steri-strip, except na may ngipin pa siya other than addition. Okay, so kuha ko isa. Ayan. Ikabit ko. Gitna muna. Dalawa lang, gitna. Igigitna ko yung parang alambre. Tapos, para siyang band-aid, iganon ko. Okay, so kabit ng dalawa. So, nakakabit yung isa. Yeah. Tapos, yung pangalawa, same approach. Isahin ko lang muna para hindi aksaya yung micromet. Kasi mahal ang micromet. So, nakakabit siya ganyan. No? Hindi ko lang naano kasi nakatalikod eh. So, meron siyang adhesive at the same time, meron siyang parang ngipin. So, kung ilagay ko dito, sa maliit na sugat, pumula ko ah. Yan. Sayang. So, gaping yan. Kung tingnan mo gano'n siya kalakas, oh. Ganyan siya kalakas. Matigas to eh. Ganyan siya kalakas. No? Kasi meron siyang ngipin. Okay? May ngipin siya. So, yan, may ngipin. Kung titignan mo, ngipin siya. Yan. Ganyan siya kalakas. So, yan si micromen. Yan. Okay, so meron ka rin Steri-Strip para dito sa mga conjunctiva. Meron akong naging pasyente sa New Zealand. Ihiwa talaga sa itong eyelid. Sorry, itong eyelid. So, wala akong magawa. Kundi, dinesign ko ng ano, kasi hindi ka naman pwede magtahi. So, nahiwa dito. So, ginamitan ko ng Steri-Strip. So, umubra yung Steri-Strip. So, yan yung mga approaches to wound care. Okay? Again, particular ako sa burn, hugas, clean cloth, at huwag i-bandage. Okay? No bandage. Okay? So, and then kung meron kang okay yung ano, kung meron kang honey, okay yung honey. Or egg white. Kaya tingnan mo mga DOH, nagre-ready ng egg white sa bagong taon. So okay yung egg white. But you have to cover it. Kasi buying time mo yan, cover it bago mag-surgery ka or aesthetic surgery, whatever it is. Egg white is good. So it creates a film para hindi umalis yung tubig. Importante, hindi mag-dehydrate yung tissue na open. Kaya maganda ibalot sa cling wrap. Nawala lang kasi yung cling wrap ko eh. Meron akong cling wrap na bit-bit para pakita paano ibalot. Wala. No? So, yung cling wrap, no? Kung wala, pwedeng plastic. Plastic siya. Pero i-duct tape mo yung gilid para yung fluid sa exposed tissue hindi mag-evaporate. Pwede yun. Pero kailangan na tubigan siya, tapos kung meron honey, maganda yun. Kung wala talaga, tubig, tapos clean cloth, tapos light lang na ano, hindi elastic bandage, light lang, kahit i-tape mo lang siya, adhesive tape. So that's how we treat the burn. And bring it to the ano. Pero the best na burn is always a cling wrap, lalo na pag medyo malaki. Huwag maglagay ng toothpaste, ha? Mali yung toothpaste. Okay? So, the issue, kahit sa civilian life, is always massive hemorrhage. So, lahat dito, simula dito, itong nakita nyo sa sleeve ko, simula dyan pababa, tourniquet, wound packing. Ang wound packing, kailangan may bone. Kasi iipitin mo yung pack against the bone para maipit ang artery. So, wound packing, tourniquet, hemostatic, elevate. Depth, sa depth, ang pinakamaganda sa depth ay limbs kasi may buto. You can direct pressure. E, you can elevate. P, wound packing. T, tourniquet. And H, hemostatic dressing. Pagdating sa junction, bawas na. D, direct pressure. You cannot elevate. P, packing. Yes. No more tourniquet. Hemostatic dressing. Yes. So D, P, H. Pagdating dito, wala. Yung P noon, is patch. Patch ka lang. Yung tinuro ko kanina, you have to patch. Sa tiyan, patch lang. Okay? P for patch, not for packing. Patch lang siya. Kahit likod, patch. Dito. Okay? Dito sa neck, pag naano ka, tapos may injury, wound packing lang. Packing lang siya. Wala ka nang ibang gawin. Hemostatic, yes. Pwede rin hemostatic. Packing, hemostatic. Pagdating sa junction dito, junction, kasi ito junction, direct pressure, packing, hemostatic. Hindi ka pwede mag-tourniquet. Walang panghawakan ng tourniquet siya. Ang tourniquet mo, mag-start dito kung ang injury nandito. So, nasa kalagitnaan na, pwede ka baka mag-tourniquet. Pero pag nataas na, hindi ka na maka-tourniquet. Wound packing na siya. Okay? So, tandaan nyo, kailan gagamitin tourniquet, kailan gagamitin ang packing, yung depth, tandaan nyo lang depth, para ma-address nyo yung bleeding. Because ngayong panahon, pag nag-bleed ka sa extremity, hindi ka na dapat mamatay. Pag namatay ka na, they call it the stupid death. Stupid death na yan. Okay? Kasi hindi ka na dapat mamatay because of the presence of tourniquet. Yan, ang rule. Okay. Sa sucking chest wound, dapat hindi ka na mamatay kasi you can just patch wound unless may tinamaan ng heart, wala na akong magawa. Pero kung simpleng nasaksak ka, tapos sucking chest wound, mapatsihan mo yan, hindi ka na mamamatay. Buying time mo yun bago mag-chest tube drain sa hospital, mag-CTT. No? So, what else? Multiple trauma, sa bleeding pa rin tayo mag-focus. Kung ano yung mag-focus ng bleeding. Lagi ka palagi sa bleeding kasi yun yung pumapatay. Yung mga infection that comes later, that's not really actually your problem. Lalo na sa isang lugar na post-disaster. Hindi ka na pwede maglinis ka, kaupukan, maglinis ka. Importante, stop the bleed. Kahit hindi malinis, basta ma-stop mo yung bleed. Bahala ng ospital, mag-settle ng mga antibiotics sa kanya. Okay, yan. So, any questions, guys? Tanong. Tanong. May tanong? Walang tanong? Tahimik at tulog. Natulog yung mga audience.
Wala po.
Marami. Dalawa lang pag walang tanong. You fully understood or you never understood at all. So, again, the running principle sa basic life support as a first aid is to institute life-saving procedures on the basic level, whether it's trauma or medical. Okay, so yan. And then, to allay the pain, kaya mag-splint. Pag nag-splint ka, laging crossover to involve limb. Pwede kang gumawa ng splint pala. So, anong gagawin? Pwedeng pillow, pwedeng newspaper, gagawa ka. So, laging kakainin mo is half of the unaffected. So, kung ito affected, kakain ka ng half and sling. Kung ito, ano ba ang position ng comfort? Kung comfort dyan, ganyan mo. So, pwede ka mag-split ng L. So, some splint pwede siya, tapos bandage mo na. Kung hindi kaya, ganun talaga siya, tapos ito involved to, pwede ka maglagay ng kalso para lang ma-immobilize mo. And then, isang katutak na mga elastic bandage para maano siya. Kasi masakit yun. Yung muscle, pag nangalay ng spasm yun. So, splintage is to allay the pain. Kaya hanapin mo kung saan papabor sa kanya. Kung sa kaya mong idikit sa katawan, sige hanapan mo, dikit. Sige. Kung hindi madikit, mapipilitan ka maglagay. Pero believe me, hindi siya tatagal na pabor sa'yo kasi una, mag-spasm talaga yung muscle. So, lagyan mo siya ng kalso. Para ganun lang siya, dala sa ospital. Or kung ipahiga mo, lagay ka ng mga Tootsie Roll or unan para hindi ka anong ma-move. Tapos hinga lang malalim because oxygen can somehow help you allay the pain. So sa spleen, okay? So it can be depending on what is affected. You can just split it from kung itong affected po thigh, simula sa upper body, lagyan mo ng kawayan hanggang sa ibaba. So para yung thigh hindi mag-move. So galing dito sa itaas, pababa. Straighten yung thigh mo, then bandage. So you can, splint is case-to-case basis. Okay? So nakalimutan ko pala yung thumb splint ko. Thumb splint yung ginagamit natin. It's a malleable splint. Kung anong forma niya, sumasabay siya. So, it's malleable, no? Tapos bandage lang. So, then we do maneuvers wherein hindi na maging grabe yung complication. Okay? So, that's for your first aid and your basic life support. So, we have heat, decompression for adult, child, and infant, kahit inano ko lang, no? Many adult. And then explain that chain of survival, foreign body airway obstruction, yung paggamit ng BVM kasi hindi tayo pwedeng mag-mouth to mouth. So pag nag-mouth to mouth ka, 5 to 6 seconds interval, ganun din sa BVM. Pag nag-BVM ka, laging nakahook sa 15 liters of your oxygen. Okay, sa in-hospital naman, pag nag-solo ka, then non-rebreather mask ka muna. Huwag ka mag-start ng CPR na walang cover ng non-rebreather mask or else lipad lahat ang aerosol sa iyo. Okay? So that ends our first aid and basic life support session. Now, babalik ako doon sa, I will proceed into ACLS introduction para yung speaker tomorrow. I will not be around with you kasi medyo ipit yung schedule, no? So merong hahawak ng ACLS niyo, pero dadaanan muna natin yung basic algorithms para hindi kayo hirap. Tingnan ko kung anong hanggang saan natin makakaya yung for tomorrow's session. Okay? So unless you have question, guys. Meron? Tahimik yung mundo ko. Question? Walang tanong. I believe na you can hang around. If you're BLS, you can hang around and listen. May dadaanan lang din akong BLS sa lecture ko sa ACLS. Okay? So, Joy, can you 2020 ACLS of ARTED?
Okay po, Doc.
Okay, guys. So since there will be ACLS session, I don't know how many of you will push through with ACLS. So, okay, first slide. Next slide. So next, ACLS is mainly employing invasive maneuvers from your basic life support primary. Then we will bridge or we will go into performing advanced life support. So define natin ano yung ACLS, no? Yung chain of survival, nabigkas ko na, laktawan ko na yan. And then yung mga pathological ECG, and what are the electrical therapies, the drugs, the pharmacology, lahat yan. No? Next slide. So ACLS, according to American Heart Association, is intervention employing algorithms, no? Puro siya algorithm in the treatment of cardiac arrest mainly, stroke, acute coronary syndrome, and other life-threatening cardiovascular. Pag trauma siya, hindi na siya ACLS. Although, binanggit sa trauma na nag-arrest. Pag nag-arrest na yan, ACLS na. Pero kung trauma pa yan, walang arrest, ATLS yan. For doctors, PHTLS or ITLS for nurses and EMTs. Advanced trauma for nursing for nurse. And it employs recognition, it consists of recognition, ECG, pathological ECG, and during cardiac arrest, there is CPR with medications intravenously or intraosseously, and you give drugs intraosseously or intravenously and perform electrical therapy, mainly defibrillation, or kung hindi naman arresting pero tachyarrhythmia, you can do cardioversion, or merong bradyarrhythmia, no? Compromise yung hemodynamics, then you can use like pacing. Okay? So it is performed by trained personnel. I don't know in your hospital what you call it, parang code blue team. So yun siya, no? So code blue staff in hospital and even in the ambulance. Okay, next slide. So ang scope ng ACLS is 2020, ECG reading, pharmacology, advanced airway, intravenous, intraosseous, defibrillators, cardioversion, and TCP sana, TCP, no? Under electrical therapy. And capnography, para maintindihan nyo na sa bagong panahon ay ngayon dapat gumagamit tayo ng end-tidal carbon dioxide detection. And then how do you do the mega code? So kasama din doon yung acute coronary syndrome at saka stroke. Yung PALS saka NRP, Pediatric Advanced Life Support sa Neonatal Resuscitation Program, ay ibang course yan. Pero under pa rin sa AHA. So ACLS mainly adult siya. Pag nagbata ka na, PALS na yan. Pag nag-baby ka, ang nag-neonate ka, NRP na yan. So partly merong hypothermia management because of the 6H, saka reversible H and reversible T's, 6H, 6T's. Okay, next slide. Now, ACLS is the cornerstone of advanced life support. So kahit anong advanced life support na courses makukuha mo, ang pinakananay niyan is ACLS kasi lahat magka-cardiac arrest. Okay, so we have advanced trauma, pre-hospital trauma life support, international trauma life support, pediatric advanced, neonatal resuscitation program, management of obstetric emergency and trauma, ganyan, no? Saglit. And advanced disaster life support, advanced medical life support under PSE, ano to? Sa US, grabe nakalimutan ko, NAEMT, National Association of Emergency Medical Technicians. Sila yung nagmamay-ari ng AMLS, Advanced Medical Life Support. And then Wilderness Advanced Life Support. So marami palang advanced life support, no? Kakatakot. I took all of them. Ang na-retain ko lang is QALS. Pero right now, I'm an instructor for ACLS. But lahat nadaanan ko yan. When I was still in abroad, pagdating sa Pilipinas, wala kasi mga ganyang course. Patingi-tingi na ako. Although na I took my PHTLS and ITLS here already. Okay, next slide. So I will not deal so much with that chain of survival. Okay. Chain of survival, iano ko lang. Sorry guys, alam ko meron palang exam kayo. So anyway, daanan ko lang to saglit para lang merong startup. Next slide. Laktawan ko na lang yan. Doon na lang ako doon tayo sa mag-start sa slide 33. Slide 33. So it talks about Para lang may understanding kayo. Kasi sa BLS manual niyo minsan meron ding ganito. Katulad ng CPR, class ano siya, class 2A yata. So, maintindihan niyo yung application, yung mga clinical strategies, interventions, treatments in a form of class and in a form of levels. So, meron tayong tinatawag na classes which signifies strength of recommendation. Is it recommended? Kasi under American Heart Association sa mga training atras isa ha. So, yung level, pag sinabing mga levels natin, yung class 1, the benefit is 3 times greater than risk. Ano to? Katulad ng CPR, class 1 yan. Pag class 2A, moderate yan. Benefit is twice greater than. Atras mo na isa. No? Than risk. Okay? So, ano siya? Defibrillator. Katulad defibrillator. Class 2B, I think dito benefit outweighs the risk. I think lidocaine in treating part of the treatment of cardiac arrest, no? Yung mga shockable rhythm. So mga ganyan siya. So may classes. Nagdagdag sa 2020 ng levels. Level A, level B randomized, level B yung ano siya, non-randomized, tapos level C, limited data, and lastly is level C, expert opinion. So, pag nakakita kayo ng isang gamot, tapos mamarkahan nila class 2A, tapos level C, EO, alam mo na anong ibig sabihin, babalikan mo to. So, mainly makikita mo siya sa ACLS manual. Pag BLS, meron din. Saan? Sa defibrillation, saka sa compression. Yan, no? So, next slide. Okay, so sige, pindot dalawa. Isa pa. So ito yung ating, yan yung ating BLS. Makikita mo sa kaliwa, BLS. Pero pag inspectionin mo na yung mga boxes dito sa kanan, next slide. That's your ACLS. So kailan nag-ACLS? Magbigay na tayo ng fluid. Tapos, kasama sa fluid doon ay drug therapy like epinephrine, 1 mg per ml, amiodarone 300, lidocaine at 1 to 1.5 mg per kilogram. No? Yan yung dosage. Then, advanced airway na tayo is either endotracheal tube or mga supraglottic airways. And at the same time, hinahanap na natin yung reversible H and reversible C. Hypovolemia, hypoxia, hydrogen ion, hypokalemia, hyperkalemia, hypothermia. So, yan yung, actually, 6 yan. 1, 2, 3, 4, 5. Hiwalayin natin si hypokalemia sa kasi hyperkalemia kasi magkaiba treatment. Sa kabila naman, tension pneumothorax, tamponade, cardiac, toxin, tablet, thrombosis pulmonary, thrombosis coronary, and then trauma. So, 6 siya kasi pinag-isa ko lang ang pulmonary sa coronary. Okay? Pinag-isa na. Pinag-isa ko yung toxin and tablets on. So, 6 pa rin. So, those, when you study those, next slide, that becomes the ACLS. Next slide ulit. So, yan ang mga standards ng ACLS. Balik tayo sa CPR. Push hard, push fast, to incest depth, minimize interruption, avoid excessive ventilation. Kailangan merong, if no advanced airway, 30:2. Pag naka-advanced airway, asynchronous na. Then, capnography. So ito yung bago. Sa luma kasi, push hard, push fast, allow chest recoil, avoid interruption. Mga ganun. Ngayon, ang push hard, push fast, 2 inches deep at 120, no? Isinama na yung allow at chest recoil, adequate chest recoil. Yan yung nagbago. Bagong patakaran. Then we give the drugs, we give the shock. So pag biphasic, 200 joules. Pag monophasic, 360 joules. Okay, next slide. So again, yan yung format natin for basic life support. Next slide. Now we go into tachycardia with pulse algorithm. So tandaan lang natin dito, malalaman natin to tomorrow. No? Tandaan lang natin, kailan pa tayo mag-cardiovert? Kasi sa tachycardia may mga gamot tayo, adenosine, no? Tapos we can do anti-arrhythmic infusion like amiodarone. We can give verapamil and beta blocker, no? Depende kung narrow or wide QRS. So, anong gagawin natin? We will ascertain 5. Hasiya lang yan. H, is there hypotension? When do I say hypotensive? Pag 90 millimeters of mercury below na ang BP, arterial BP, hypotensive siya. Pangalawa, altered mental status. Pangatlo, signs of shock. 3, ischemic chest discomfort and acute heart failure. So pag may nakita kang ganyan, or unstable na, synchronized cardioversion mo na. Okay? Next slide. So yan yung mga pag narrow regular, we can start with 50 to 100 joules sa manual sa cardioversion or synchronized defibrillation. Then pag narrow irregular, you can start with 120 to 200. Pag wide regular, 100 joules. Pag wide irregular, i-defib mo na. Ibig sabihin, ano na yan? It's like a torsade de poids. Okay? Then we can give amiodarone at 150, tapos sotalol yung binibigay natin as our beta blocker. Dito, hindi minimension si verapamil, but verapamil is my second dose after adenosine, because adenosine is very hard in this country. Hirap pumili. Next slide. Sa bradycardia, same thing. Except, iba yung approach natin. Puro lang karamihan natin atropine, dopamine, epinephrine drip. Okay? So pag bradycardia ka, hasiya ulit. Is there hypotension? Is there altered mental status? Is there shock or signs of shock? Is there ischemic chest discomfort and acute heart failure? Pag wala, monitor. Pag meron, atropine, IV dose. Bantayan mo na yan. Pag mga 1 milligram, an interval of 3 to 5. Hanggang makaabot ka ng 3. Eh wala pa rin siya, then patulugin mo ng pasyente. Pwede ka na mag-transcutaneous spacing. Or you can start dopamine. So depende, you can start from 5 to 20. Dati kasi merong 1 to 5, 5 to 10, 10 to 20. Ngayon wala nang mga renal dose, vasopressor dose, wala nang cardiac dose, wala na. Ngayon mag-start ka sa 5, tatitrate mo lang depende sa pag-respond ng tao. Or mag-epinephrine IV infusion at 2 to 10 microgram per minute. So repair mo na rin sa cardiologist. Okay? So transcutaneous space, nagawa ko na yan. Life-saving talaga yan. Next slide. Ito naman, pag post-cardiac arrest care, so I will not deal so much with this kasi pag return sa circulation, particularly kung drowning yan, huwag mong pauwiin. Hanapin mo anong cause back ng cardiac arrest yan. So yan yung kanyang, next slide, yan yung kanyang setup. So you can have an infusion of nor-E or epi or dopa. But usually ang meron ako sa drug kit ko dopa. No? Next slide. Doon ako sa stroke, yan. Sige pa. So pag stroke algorithm, meron tayong stroke team sa hospital ideally. So galing pa lang sa ambulansya, next slide. Kailangan, meron ka na-assess mo na, natawag mo na sa hospital na, I have a stroke here. So hook sa O2, perform a glucometer, kailangan kompleto siya. So i-alert mo yung hospital that you are incoming. So from 0 to 10 minutes, should be in the ER. From 10 to 20 minutes, kailangan nagawan siya na-assess siya na oxygen, IV access na, 12-lead ECG, nag-neurologic screening ka. So sa 20 minutes to 40 minutes, kailangan naka-CT scan ka. Next slide. Para ma-ascertain natin kung no hemorrhage or with hemorrhage. Siyempre, mas gusto natin yung no hemorrhage. So, i-run down mo siya. From 40 minutes to up to 3 hours, dapat naka-ready na siya for RTPA. Candidate pa siya for fibrinolytic therapy. So, yun yung hinahabol natin sa stroke. Kaya kanina, yung BFAST mo, yung time noon, from door to needle, door to CCU, okay, magawa natin. Yeah, no? So, 3 hours ang max. So, isipin mo, grabe, strict to, no? 10 minutes nasa ER, 10 to 20 minutes nagawa na ECG na. 20 to 40 kailangan na CT scan, grabe kabilis. Next slide. Pag ACS naman, same thing, mona pa rin tayo. Although wala tayong morphine dito, walang karga yung ambulance. The best thing that we can do is 3 to 5 milligrams chew aspirin, tapos oxygen. Although ang ginagamit natin dito ay mononitrate. Sa ibang bansa, maganda kasi meron silang nitroglycerin 0.5 milligrams sublingual. No? So yan. And then Ganyan kasi sa ambulansya, katulad kung meron ako 12 lead ECG. So we can employ 12 lead ECG, tapos we can call cardiac cath lab. So pagdating naman sa ER, dapat na-perform, check vital signs, institute yung IV access, test x-ray, no? Tapos activate cardiac lab. Pero mayroong bypass. Kung ayaw mo nang idaan sa dito, diretso ka na sa cath lab, marami ka nang nagawa. Katulad na nabigyan mo ba siyang morphine? Next slide. So anong makikita mo sa ECG mo? ST elevation MI or non-ST elevation MI with yung tinatawag nating unstable angina or yung low to intermediate risk ACS na wala kang makita pero ino-observe mo. Pero pinakamaganda is STEMI. Kasi yung tinatawag nating door to needle fibrinolysis is within 30 minutes. Pag na-achieve natin yung 30 minutes, ma-fibrinolyze natin siya, pwedeng heparin, no? Mabigyan ng ACE inhibitor. Maganda para may reperfuse. Okay, so yan ang mga guidelines. Next slide. Ng ACL, basahin nyo na lang. Next slide. Doon tayo sa picture. Yan, sige picture. Yan. So yung BLS, yan, naka-BLS, tapos naglagay ng AED. Pag nasa hospital na tayo, huwag ka na mag-AED. Transfer mo na sa manual. Yan, magmamanual ka na. So ito ay American Heart po. Ito, natabo na lang yung kano na instructor namin dyan, babae. Next slide. So yan yung mga concept natin. Next slide. So these are the types of AEDs. No? So sa hospital, hindi tayo gumagamit ng AED. Manual talaga tayo. Next slide. So yan. Pag na-ACLS na, yun, meron na tayong mga advanced airway. Okay, next slide. No? Next slide ulit. Katulad ng endotracheal tube. No? Although mali pagka simulation na yan sa itaas. Next tube. Next slide. So meron tayong capnometry. The normal capnometry is 35 to 45 millimeters of mercury. Dito, nakikita mo, pag nung hindi pa intubated, nung na-intubate na, kinabitan ng umaakit siya up to 12.5 to 20. Ang isang tao, habang nire-resuscitate mo, pag hindi talaga umakyat ng mga 10 below yan, hindi talaga siya umakyat. Ang capnometry ay 10 below. Wala nang pag-asa yan. Ibig sabihin, wala nang ang tissue niya, hindi na nag-metabolize. So makikita niyo dito sa capnometry. Ayan, next slide. So pansinin niyo yung yellow na nasa BBM and sa endotracheal tube. So yan po yung capnometer. Sa akin yan. So nasira siya, nasabugan ng baterya, na lumural ako. So ginagamit na lang siya for training. Hiniram sa akin para dekorasyon sa training. Naku, hindi na ibalik sa akin. Yan, okay, so that's capnometer. Next slide. So I'm gonna leave you here for reading na lang yung ACLS. And then for tomorrow, yung instructor ninyo ang magpupustro. I'll just wait for advice of Joy. But I will let you take the exam bago makalimutan yung basic life support. Mag-exam kayo for your basic life support. So I'm gonna bring you back to Joy. Okay, Joy?
Thank you, Doc Ted. Mag-exam muna po kami, Doc, ng BLS.
Okay.
Miss Gina, please send the BLS exam link. Ayan po, nasa chat box po natin yung BLS exam link. Kindly answer na lang.